Of day 4. So this is the last day and we have very good speakers, and I must tell you and thank the online viewers who gave us an enthusiastic response. Yesterday it was more than 700 viewers online and 150 delegates who have registered for online virtual conference joined us, and day before yesterday also it was more than 700 viewers. So it is good number of viewers as compared to the physical presence. So with that, the speakers will be motivated to have a larger audience online than offline. And we will be recording all the lectures and putting on our YouTube channel for future references and sharing with all our speakers also. So I request Dr. Noria, KK Noria, our organizing committee member, to please moderate this session with the first lecture by Dr. Rajesh Agarwal.
Very good morning to everybody. I, Dr. KK Noria, the organizing chairman, MAPICON, and welcome you all who are present here, as Dr. Vitul has just told, and all those people who are attached or connected with us on online as well as on the YouTube. I think in the last 3 days, probably it was a very informative sort of a sessions we had, and a thought-provoking sort of ideas put forward by all the speakers here, and hopefully you see most of the people probably benefited from all those things, you see. And today also we see we are going to have this session with 4 speakers, and it will be followed by the felicitation ceremony and the award ceremony. And the positive thing, you see, which I felt in last 3 days, that probably this is for the first time that we feel very honored and proud that very young doctors, this time in last 3 days, so many young doctors participated with their sort of lectures and all that. I think it's a good platform for all of them, and even for the future, I think all those people will try to invite all of them and try to involve, and probably it is for them, you see, for their career, it's a very good platform. So today, the first lecture is by Dr. Rakesh Agarwal. Rajesh Agarwal. So his lecture is on pre-diabetes, treat or not to treat. I think pre-diabetes is a very subject very close to my heart, for the simple reason, you see, in the last few years, probably pre-diabetes has exceeded the number of people with diabetes, you see. And I'm sure, you see, in the coming years, you see, it's going to be alarming. They say it is a silent sort of a pandemic, which is, and by the year 2030, probably we are going to be the world capital of diabetes. And the question, I feel always that pre-diabetes, treat or not to treat, is $1 million question. And I'm sure in the next 20 minutes, I think we'll get the answer from Dr. Rajesh Agarwal. Thank you. Dr. Rajesh Agarwal, please.
जय हिंद एवरीवन, सभी को प्रणाम. First of all, I must congratulate Dr. Vitul Gupta and MAPICON team for inviting me here, and I'm really touched by his hospitality and the way he behaved with us. That is phenomenal. And because of Vitul Gupta sir, I could achieve one more milestone today only. I am, for the first time in my life, I am the opening batsman. Otherwise, most of the time, I am middleman or last man. So with this, I am talking about pre-diabetes are to be treated or not to be treated. Before that, if you permit me, we can have audience poll sort of thing. How many of you would like to treat pre-diabetes? Raise your hands, please. Me also. How many of you don't like to treat pre-diabetes? Please raise your hands. So all would like to treat pre-diabetes. So what is pre-diabetes? This will be the flow of our talk in next 15 minutes. Pre-diabetes is a condition bridge between the normoglycemia and hyperglycemia of diabetic origin, but the hyperglycemic range is less than the diagnostic criteria for type 2 diabetes. Here we are talking about American Diabetes Association criteria, which we used to follow in most of our studies and most of our talks. We know that normal A1C level is less than 5.7%. Fasting blood glucose or fasting plasma glucose is less than 100 milligram, and post glucose plasma glucose is less than 140. That is normal. In diabetes, it is more than 6.5 is A1C. Fasting blood glucose more than 126, and post glucose it is more than 200. The problem lies here in between the two. They are pre-diabetic patients. These are the patients, and this is the million-dollar question, as Dr. Noria has already pointed out, whether we should treat or not to treat. Let us see. We have both the things we will answer. Points in favor of treating pre-diabetes and not treating pre-diabetes. So before going further, these are two cases where we should understand, and we will come again at the end of the talk. This is first case, 42-year male with family history of diabetes, coronary artery disease, hypertension with obesity, signs of insulin resistance, that is acanthosis. He was feeling lethargic and presented to us with dysglycemia, and A1C was 6.3. Another case, almost similar features, 42-year male but no family history of diabetes or any comorbidity like hypertension and coronary artery disease. BMI is normal, 23, and again presented with A1C of 6.3. There was no sign of insulin resistance. So we will decide whether to treat or not to treat. Again, we can have a poll at this point. Who would like to treat both the cases, or one case, or second case? So keeping in this in mind, these are alarming figures. We have 110 million about diabetes, 136 million pre-diabetes, and 254 million people with generalized obesity, and 351 million patients with central obesity, abdominal obesity. And we all are aware of the fact that these are potential diabetics, counting about 600 million, more than 600 million, which are potential diabetes and can be prevented. That is very important figure, and for a country like ours, or Asian countries, we can prevent all this. We all are aware of as the obesity is the precursor of diabetes, and as the BMI increases, the various phenotypes of pre-diabetes, that is impaired fasting glucose, impaired glucose tolerance, and both are increasing with increasing BMI. In last 20 years, what has happened? The overall CV mortality has decreased by 30%, but CV mortality associated with obesity has increased to three times. You can see here 2.2 to 6.6. So this is very important, and that is why we have to treat pre-diabetes. This is the prevalence of various phenotypes of pre-diabetes in various ethnicities, Asian, Indians, Caucasians, and this is the meta-analysis of almost 19 studies with 32,000 patients, and we are more susceptible for impaired fasting glucose, impaired glucose tolerance, and even both. This is the natural history of the diabetes. We know that there is, when diabetes is diagnosed, almost 5 to 10 years has passed before diagnosis of diabetes, and by that time there are multiple risk factors which are operating upon and leading to the various complications. And the reason for complications are these: free fatty acid, hypertriglyceridemia, increased visceral adipose tissue, hyperglycemia, increased RAS activation, leading to oxidative stress and inflammation, endothelial dysfunction and fibrinolytic dysfunction, all leads to vascular events. And most common complications are macrovascular complication, that is peripheral arterial disease, or cardiovascular disease, or cerebrovascular accidents. This is the Veteran Health Administration study of about 72,000 patients, which has analyzed the timeline to develop progression of pre-diabetes to diabetes, and at 1 year 35% developed diabetes, and at 2 years 60% developed diabetes if they were not treated or they were not advised anything. Progression of pre-diabetes to diabetes varies from 5 to 20%, even more or less, depending on the population you study, and various other factors like age, obesity, family history, ethnicity, PCOD, history of GDM, baseline A1C, and lifestyle. Meta-analysis of more than 250,000 participants followed for 24 years. Cumulative evidence of developing diabetes was 31 to 41%. So you can imagine the burden of diabetes and pre-diabetes. As Dr. Noria rightly pointed out, this will be the biggest pandemic of pre-diabetes in near future. This is the review of more than 7,000 publications on 40 countries, that prevalence is highest in high income countries about pre-diabetes. But the highest relative growth for pre-diabetes is in low income countries. This is again a matter of stress for country like ours and Asian countries. We all are aware about the fact that pre-diabetes is a risk factor for progression to diabetes, cardiovascular disease, dyslipidemia, hypertension, and it should aggressively prompt you to comprehensive screening for all risk factors. Whom to screen? Those patients who are having obesity or high degree of BMIs, first degree relatives with diabetes, or signs of acanthosis nigricans, PCOD, physical inactivity, signs, history of cardiovascular disease, and first degree relatives of type 2 diabetes. Then patients who had GDM in the past or any time hyperglycemia in the past, they should be screened for pre-diabetes. Risk factors for pre-diabetes we have already discussed. The most important is genetic predisposition, and then comes the obesity. And all these are precipitated by older age, physical inactivity, and unhealthy diet. We are aware about the fact that insulin sensitivity is progressively impaired from normoglycemia to type 2 diabetes, and as the glycemia deteriorates, insulin sensitivity decreases. Sorry. This is ASDAB study of more than 10,000 patients, which shows that as the dysglycemia improves, means dysglycemia is increased, there is increased CV mortality and all-cause mortality. Why pre-diabetes to be treated is in a study of 577 patients from 33 clinics in China. They were followed up for 6 years, and they were divided in 4 groups. Control group, diet, exercise, and diet plus exercise. And the results are 51% lower incidence of diabetes during the active intervention period, and 43% lower incidence at next 20 years. So this is the importance of lifestyle intervention. And the average annual incidence of diabetes was 7% for intervention group versus 11% in the control group. This is the Darking study with longest follow-up, 30-year follow-up, has shown that median delay in onset of type 2 diabetes is by 4 years, and there are lesser CV events and lesser microvascular complications, and so on. This is rapid and early diagnosis of pre-diabetes. It is very important. This is my paper which was published in the IJCDM for point of care testing of for pre-diabetes, what we did, the attendants of the diabetic patients who were coming with them, we were doing point of care A1C levels in those patients, and we picked up the pre-diabetic patients. Why pre-diabetes treatment is important? Because diabetes reversal is easier and very fast at this point of time as compared to patients who become diabetic and then we try to reverse them. And it is by intensive lifestyle, dietary modification, enhanced physical activity, and it reduces the progression by 40 to 70%. This is phenomenal number. These are various diabetes prevention programs which also suggested 30 to 60% less progression to pre-diabetes to diabetes. This is another direct trial which is again weight loss trial, and those patients who achieved more than 15 kg weight loss, 86% of the patients could achieve remission, and those who sustained it 15% weight loss for 2 years, they almost 70% of the patients could remain in remission. That is very important, that you can maintain normoglycemia for very long time without any medication. Various diabetes prevention programs, DPP program, very famous, commonly known, 31% reduction with metformin and 58% reduction with lifestyle modification. Various drugs are tried and used and found to be efficacious, including all non-hypoglycemic drugs except insulin, except sulfonylureas and glycine analogs. These three are hypoglycemic drugs. Rest other drugs are found to be effective in preventing the progression from pre-diabetes to diabetes. However, ADA recommends metformin treatment for people with pre-diabetes, those who are less than 60 years of age and BMI of 35 along with pre-diabetes. Otherwise, no drug is approved for management of pre-diabetes. For obesity, which is precursor for diabetes, there are treatments. Most of them we can use, logically we can use all those drugs, but not recommended by the guidelines. Weight loss medication, again the same, which are available now, and that can be used for prevention of type 2 diabetes. Very old stop NIDDM trial with acarbose, which reduced 25% reduction in impaired glucose tolerance over a period of about 1200 days, almost 5 years or so, 4 years or so. This is step 10 trial with burning molecule, or most commonly talked about molecule as on today is semaglutide, that is Wegovy, and those patients who achieved weight loss of 20% weight loss, the 81% patient could achieve remission as compared to 14% in placebo arm. Another important point is, you can see here, only 33% patients at the baseline in this step 10 trial having A1C of less than 5.7%. But at the end of 2 years with Wegovy treatment, 65% patients are with A1C of less than 5.7%, that is in normoglycemic range. And in placebo arm, this figure decreased by 30%, from 33.9% to 21.4%. These are the various weight loss categories with lifestyle modification, minimum weight loss. This is Wegovy, and this is Mounjaro, that is tirzepatide. Now, the other side. Why pre-diabetes not to be treated? Because different criteria by different organizations for diagnosis of diabetes. Then stigma of a chronic disease which causes mental stress, and overdiagnosis and over-medication. All these are very important factors if you label a patient with pre-diabetes. These are the different criteria. WHO has not included A1C in the diagnosis of pre-diabetes. So it is very important. ADA has lowest criteria. ADA has lowest criteria. Fasting blood glucose 100 to 126. while WHO and NICE guidelines and international expert committee are considering 110 to 126 milligram fasting blood glucose for the diagnosis of pre-diabetes. So if you use ADA criteria, you are over-diagnosing. If you use NICE criteria and WHO criteria, you are under-diagnosing. And the difference is huge, about 20%. So this is the reason why not to treat. Another very important reason, our treat to target for diabetes mellitus are A1C of less than 7% or less, or even by ESD it is less than 6.5%, which is still well above the diagnostic criteria for pre-diabetes. So you have to use your clinical acumen, which patient to be treated, which are not to be treated. Long-term studies are required for evaluating the risk benefits of pharmacotherapy for pre-diabetes. We don't have robust data for in favor or against the pre-diabetes to be treated or not. Then who are the pre-diabetic patients which should not be treated? Those patients who are stable in pre-diabetic range without associated comorbidities like obesity, like hypertension or coronary artery disease or dyslipidemia, are having history of GDM, there is no history of GDM, no PCOD, then they should be watched and should not be treated right at the beginning. If there is incremental or worsening hyperglycemia, then you should start treating. If they are remain stable in the lifestyle modification are the best treatment. So last slide, a few slides. PD message is pre-diabetes is more prevalent than conversion of pre-diabetes to diabetes varies from 5 to 20%, even more are low. CV disease and mortality are higher among untreated pre-diabetes. Rapid and early diagnosis is very important. Ask yourself, are we justifying in treating pre-diabetes? Patients who are stable in pre-diabetic range without other risk factors should wait and watch. Stigma, because of the stigma associated with chronic disease like diabetes and pre-diabetes, they must be under surveillance and invested at regular intervals. If worsening hyperglycemia, worsening comorbidities, then you should treat. Coming back to the two cases, the first case, 42-year male, family history of diabetes, coronary artery disease, hypertension, obese, having signs of insulin resistance, lethargic, presentation is not important, but dysglycemia, he is the patient should be treated. Another patient with 42-year, no family history of any risk factors, BMI is normal, no sign of insulin resistance, A1C is 6.3, should be under observation, regularly investigated. If there is no worsening hyperglycemia, should not be treated, only lifestyle modification should be done. And fortunately, this is accepted in Journal of Association of Physicians of India, and in upcoming issues, probably it will be published. So thank you very much, and if there is any query, we are here to.
Thank you, Dr. Rajesh Agarwal. A very nice talk. Well, see, I think most of us probably has got the answer that pre-diabetes must be, rather should be treated. The answer is yes. Why I'm saying is, Punjabi ch kahavat hai na, ki gud de utte makhi ne aana hi aana hai. See, the sugar is there from your head to toe, you see. And if the sugar is high, you see, you are bound to have all those problems which are associated with diabetes. So I personally feel that pre-diabetics, it's not that we are trying to treat diabetes or pre-diabetes, we are trying to treat all these complications which is patient is going to have in the future, you see. So that means even if we can't treat it, at least we can delay it for years together, you see. That is the most important part as long as we have to treat the pre-diabetes. Thank you very much. Anybody have any questions, please?
Sir, diagnostic criteria keeps on changing.
Yeah.
Earlier, we used to calibrate glucose levels at much higher level as well as the captive level. But since the major bodies like NICE, ADA, WHO, since they are not coming on some consensus, what will follow then?
That's the dilemma. That's the dilemma. Then you have to use your clinical acumen. If patient is having, suppose patient is having 109, by NICE criteria it is not diabetes, it is not pre-diabetes. But by ADA criteria it is pre-diabetes. So what you should do? You should see the history, family history, all other risk factors. They are not considering risk factors. They are just claiming the numbers. They are claiming the numbers. So that is the problem with AI also. Artificial intelligence. He will label patient with 109 by NICE criteria, he will label normal. But with ADA criteria, he will label pre-diabetes. But we can understand that there is family history, there is coronary artery disease, there is dyslipidemia. So this is 109 is also considered to be pre-diabetes. 1 milligram doesn't make any difference. But these guidelines and difference of opinion is always there, even in our clinical practice also.
Our knowledge is based on these guidelines.
Yes.
Our knowledge is based on these guidelines only. But overnight, in a fortnight, 20% of population became diabetic with the change of the guidelines.
This is just data analysis. This is, we have to use our clinical acumen. That's what the lecture says. And that's how overnight Trump has made the tariff 50% and he has made the H1B visa cost from 10 times. So that that is not in your hand. What you can do is your clinical acumen.
Dr. Vinder, that is the reason. You see, the pre-diabetic, you see, before they go to diabetes, you see, even if it is 20% increase, you see, at least we are definitely treating all those patients going for all those complications, you see. Because this is all based on the guidelines, you see. We have to go by the guidelines.
Your point is well taken.
My point is that if you can decrease your criteria just to see the NICE guideline or the ADA guideline, this data is only based on the European populations. So we need our data where we have to label this patient as a pre-diabetes. If you can see 110 is the cutoff point, suppose, then the number is swelling 153 millions or something else. If you decrease by 1 millimeter, the number will swell several times. Similarly, in hyperglycemia and pregnancy, you can see different type of diagnostic criteria in different level. Even the Chinese criteria is different, the European criteria is different, Indian criteria is different. So we need our criteria for the South Asian population to label the point as in diabetes. You all know that the pharma company and the other companies are all mushrooming that the criteria should be lowered so the number of the patients should swell up. But science, where we have to use this criteria, what is the basic behind the criteria is to be determined, because this all criteria is based on the retinopathy changes. So do we examine the retinal to all the patient? No. So this is all about this
And
criteria.
guidelines are
To help.
for to guide, not to use. They just guide, just like guide wire in coronary stenting. It just guides you, but it does not cause us the treatment.
Yes.
Thank
Thank
you,
you,
thank you,
Dr.
thank-
Rajesh, for an excellent talk. And we must thank you for coming to Bathinda, facing all the hardships during travel, delayed flights, real thing that it may or may not take off is real torturous thing. So we are really indebted that
But
you have
still
made
I
to
enjoyed
Bathinda.
that. I enjoyed that.
So thank you very much. Thank you.
Since we are on the subject of diabetes, I think the next lecture is again related to diabetes. It's the ADA standards of care in diabetes. As you all know, the American Diabetic Association, every year you see there are a lot of researches regarding the pathophysiology of diabetes and the new drugs coming in the market. If I go back to my medical school days, we used to have only 2 drugs. That was number 1 was metformin, the other was sulfonylurea. The treatment of diabetes was very simple, very easy, that somebody who is obese, he should be on metformin, and somebody who is thin and lean, he should be on sulfonylurea. But today we are facing a lot of, I think maybe the advancement of this science, that there are number of drugs in the market to treat diabetes, you see. And at times, you see, we are a little confused what to use and what not to use, you see. And probably all these advancements and all these things, you see. So with the next speaker is Dr. Brez Kishore Singh. He is from Aurangabad, Bihar. So he's going to say, talk about ADA standards of care in diabetes 2025. Dr. Brez Kishore, please.
Thank you, sir. First of all, I really thanks Dr. Vitul Gupta ji for excellent hospitality. We enjoyed, and definitely the Punjab is the great personal leaders, and the hospitality of Punjab is really great. So thank you very much for inviting me, and my best wishes from not only from me also, but from the Bihar as well. So my topic is the ADA 225 standard of care. What's new? If you can see the field of diabetes, not only diabetes, all science is ever changing. So we need a regular updation, or really you can say for the diabetes is concerned, we need a yearly updation. So, and the American Diabetic Association has long been a leader in producing guidelines since 1989. That's why. And the 225 standard of care in diabetes has continues to incorporate person first and inclusive language. Many societies have endorsed different section in the ADA, this standard of care. There are 17 sections in this particular SOC, and different section will be endorsed by the different society. Like the section 4 by the Bone and Mineral Research Society, American Society for Bone and Mineral Research. The section 8, obesity and weight management by the Obesity Society. And similarly, the section 10 by the American College of Cardiology, and section 13 by the American College of American Geriatric Society. There are many changes, but what is important I incorporated in this particular section. So I will go by section by section, and if you can see the first section, the improving care and promoting health in a population, we can see that initially it was that the people of diabetics should be advised to take lifestyle modification and other things. But now this is expanded to include the people at risk of diabetes. So people at risk of the diabetes should be started with the lifestyle modification. Just Dr. Rajesh Agarwal has said the pre-diabetic patient should be having this lifestyle modification and the treatment possibility. So this is the new changes that the people at risk should be incorporated. And second is the chronic care model. The patient-centered approach must be there, and every patient is different, so a patient-centric medical home model should be applied. So patients should be educated to take care of themselves, so self-management schemes should be instituted. And there are other emphasis has been the importance of addressing disparity in the diabetes care and health outcome. You can see the different sections of the society are not accessible to the different type of care in the society. So this thing is incorporated in this subsection. In sections second, the diagnosis and classification of diabetes, there is table 2.3 was added to provide consideration related to the use of and interpretation of the laboratory management of the glucose A1C. You can see that if the glucose parameter is there, you say in different lab, the blood glucose, plasma glucose, or capillary glucose, there are different levels will be there. If you can test the whole glucose, the level will be there different. If you use plasma glucose, the level will be there. If you use capillary glucose, the level will be less. So there are some problems with the blood glucose monitoring, and similarly with the A1C measurement also, because ANC measurement should be endorsed by the different international guidelines standard. So there are certain things which to be included, and this table 2 is incorporated in that. In blood sugar test, if the blood sugar will be stored in more than 1 hour or 2 hours, so that there will be changes in the parameter, so different. So you have to use this A1C level or the blood glucose level, what you want to say. It depends upon the different situation. So in blood sugar level, you use fasting and postprandial, and similarly in HbA1c, you any time in blood sugar can be blood test to be instituted. So these are the criteria. The second recommendation is that in the importance of antibody-based screening for pre-symptomatic type 1 diabetes in individual with a family history of type 1. You all know there is a 3 stages of type 1 diabetes mellitus. The non-symptomatic patients of type 1 diabetes should be screened for in the patient with a family history of type 1 diabetes or otherwise known elevated genetic risk. Why this test is important, I will say in next slide. And the classification substation, there is provide a pragmatic approach to the management of the individual who have a feature of both type 1 and type 2 diabetes. In section the prevention or delay of diabetes and associated comorbidity, the life behavior changes of the type 2 diabetes prevention subsection. Sleep health is the very important. You all know that in the lifestyle modification, diet, second is your exercises, third is the mental yogas and mental relaxation phase, but fourth is the sleep. Sleep is a central component in the management of pre-diabetes and diabetes, placing it other form of the lifestyle modification, because you need 6 to 8 hours sleep daily. If you see that the mobile application is increased in the younger generation, and it is one of the reasons that the type 2 diabetes mellitus is increasing in the younger population in our part of the world also. Similarly, there is a recommendation that the patient having aged 8 years or more with stage 2 type 1 diabetes, the role of teplizumab infusion to delay the onset of symptomatic type 1 diabetes mellitus. So the screening of the type 1 diabetes mellitus at the stage of pre-symptomatic level should be there. In comprehensive medical evaluation and assessment commodity, dental care should be instituted. The new subsection is added, and dental examination is must every once in a year. A new subsection of female sex dysfunction was added, and the healthcare professionals should inquire about the sexual health, particularly in women who experienced depression and or anxiety and those with the recurrent UTI. So the female sex is come in this particular subsection, and that is added in new. And the nomenclature of the NFLD or NS was updated to metabolic dysfunction associated steatotic liver disease and metabolic dysfunction associated steatohepatitis respectively. And one new concept amended to the state that the patient having this MAS or the MSLD, the FIV score is the one of the very important parameter you can judge even in clinical practice. If it is more than 1.3, should be an additional risk stratification performed. So FIV score is one of the best method. And second in the treatment module is the thyroid hormone receptor B agonist in adult with the type 2 diabetes mellitus or pre-diabetes with MASLD with moderate or advanced liver fibrosis may be considered. You all know that the thyroid hormone receptor B agonist is already been in market in America as an resmetirom. In facilitating positive health behavior and well-being of the patient, the diabetes self-medical education support subsection is added, and it is has emphasized the all people with diabetes should be advised to participate in this diabetes self-management education program. Initially, it was that the patient should encourage to participate, but now it has been incorporated that the all patient of the diabetes should be advised to participate in this diabetes self-management program. And we have to do the diabetes with the fast, like the Ramadan International Alliance. Comprehensive pre-fasting reassessment is must to stratify the people with diabetes prior to engaging the fast stage. And use of recreational cannabis should be avoided in all patients who are at risk of diabetic ketoacidosis, because it is a higher chance of cannabis hyperemesis syndrome. So the use of recreational cannabis should be avoided, should be banned. In glycemic goal, the new subsection is the hyperglycemic crisis, diagnosis, management and prevention was added. There is a routine assessment of history of DK and HS and provided a structured prevention education in the outpatient setting. Means the DK and HHS, which has been incorporated in only the in-hospital patient, should be screened or structured in outpatient settings. Technology, there is a considerable advancement in the diabetes technology, and you all know that the CGM, use of adult with type 2 diabetes on glucose-rearing agent other than the insulin. Those who are insulin, you can advise the CGM, but even in those on the oral hypoglycemic agent can be used CGM for the better control of the glycemia. And similarly, the management of diabetes in pregnancy and reflect that update CGM can be used in pregnancy also, whether not only in the type 1 diabetes but also in the type 2 diabetes as well. In obesity and weight management, there is a guideline addressing weight management pharmacotherapy beyond the goal of simply lowering blood sugar, emphasizing the importance of the addressing other aspect of the metabolic health is the or patients should not only be advised to reduce their weight, but also to advise that maintain their reduced weight as well. Pharmacological approach to glycemic treatment, section 9, beyond weight loss, GLP-1 receptor agonists are now recognized for their benefit in the heart and kidney health also. The use of GLP-1 are with demonstrated benefit in individuals with type 2 diabetes, symptomatic heart failure with preserved erection function and obesity also. And the recommendation was revised to recommend use of either SGLT inhibitors or GLP-1 receptor agonists with demonstrable benefit in individuals with type 2 diabetes and CKD. Means the GLP-1 receptor agonist can not only be used in diabetic patient but also in the CKD patient. And it has also been recommended that this GLP-1 receptor and pioglitazone or combination of GLP receptor 1 agonist and pioglitazone can be used in different stages of MA, SLD and MAS. In cardiovascular disease and risk management section, then recommendation 10.2.6 as added to recommend that in most cases lipid lowering agents should be discontinued prior to conception, avoided in sexually active individual of childbearing potential, not using reliable contraception unless the benefit may outweigh the risk. So that in the patient, female patient, we are in childbearing age. So this lipid lowering agent should be cautiously used, and that should be individualized. And reduce complication, there is a glycemic management, BP management, lipid management, and use agent like the CPN, kidney benefit, GLP-1 receptor and SGLT2 inhibitor. In chronic kidney disease, as I have already said, that the GLP-1 receptor with demonstrated benefit in the population should be used to reduce cardiovascular as well as the kidney disease progression. So GLP-1 receptor agonist has come in big way in the management of diabetes. And This recommendation 11.6 was added to state that the potentially harmful antihypertensive medication in pregnancy should be avoided in sexually active individual of childbearing potential not using reliable contraception, or to switch to the option considered safer prior to the conception and during pregnancy. So in pregnancy, you use the drugs in pregnancy or the patient having a childbearing age, you use the safer drug so that if accidental pregnancy may happen, so that should be the complication could be avoided. In retinopathy, neuropathy, nothing more important, but the retinal examination must be frequent to rule out the diabetic retinopathy. And similarly, you can use your hand as an screening for this diabetic neuropathy. Because if you have not having monofilament, don't worry, you have to use your fingertip as an Ipswich test as an option for the neurological assessment. In older patient, there is, the older patient having the many cognitive disorders, and they may have dependence upon the other person for their livelihood. So you have to be very friendly and health system, that is a medication, mobility, and what's matter most as it applies to diagnostic management in older patient. And the recommendations are modified to include time in range, time below range, in addition to A1 treatment goal for older agent who are otherwise healthy and pure and stable chronic condition and intact cognitive functional disorder. In children and adolescents, the recommendation has changed to state that the insulin pump should be offered to anyone with type 1 diabetes who can use device very safely. Initially, in children, the insulin pump should be avoided, but now it is recommended that the children, if he can understand or he can use the device safely, can be used this insulin pump. And that new terminology from the hyperglycemia, hyperosmolar non-ketotic syndrome has changed to the hyperglycemic hypersmolar state, and includes the intravenous fluid as an initial step to treat severe hypoglycemia once the diagnosis is concerned. And the management of diabetes in pregnancy, we have already said that whether you are using the term gestational diabetes mellitus, management of pre-existing type 1 diabetes or type 2 diabetes, the treatment is more or less same, either insulin or you can use some metformin or other drug. But the treatment is same, so they have merged our one new section and management of diabetes in pregnancy. That's all. Nothing like gestational diabetes mellitus, pre-existing type 1 diabetes mellitus or type 2 mellitus, all incorporated in management of diabetes. I think it's a good approach. Why we should use gestational diabetes mellitus, why you should use, the treatment is the more or less same. So which includes all aspects of management of all type of diabetes, nutritional, physical activity and pharmacotherapy. And the recommendation new longer state the CGM. In pregnancy also CGM can be used. Initially it was not prescribed in the case of pregnancy, but now it can be used. The new recommendation now state that the CGM may be used in conjunction with blood glucose monitoring to achieve the glycemic load. So CGM comes in very good way. And GLP-1 receptor agonist has come again as not only in the treatment of cardiac comorbidity, cardiac condition, but also in the CKD patients also. Diabetic care in hospital setting is a very important part, and you can see that in hospital the critically ill patient and non-critically ill patient. In critically ill patient, the diagnostic glycemic goal has been set to 140 to 140. Less stringent is recommended for most critically individual, but more stringent individualized glycemic may be appropriate if they can be achieved without significant hypoglycemia. The one factor is, limiting factor is the hypoglycemia. So hypoglycemia should be avoided, and in the patient with a non-critically ill patient, the glycemic goal is 100 to 180 milligram per dl. So for the critically ill, it is 140 to 180, but if it non-critically ill, it is 100 to 180. The diabetic advocacy, the subsection of diabetes care in school setting, and diabetes and driving. This is very important when you are a diabetic patient, you are traveling from one place to other place. So there must be some criteria. So they were updated with the information from recently published advocacy statement, and the sub-center of diabetes management detention facilities. The patient who are in the prison or who are in the detention center, so there must be some management criteria for the treating the patient of diabetes in that particular group. This is all about this section. The new update as per to conclude the factor is that in type 1 diabetes, antibody-based screening is must in pre-symptomatic to symptomatic patient, because type 1 diabetes are used islet auto-antibody test and criteria for preclinical stage to type 1 to look for potential to delay the onset of using teplizumab in all the first degree relative of the type 1 diabetes, newly diagnosed patient, and based on the consensus guideline. And autoimmune disease screening is in type 2 diabetes, thyroid and celiac disease, and new screening, new recommendation, the person of DKA or the person at risk of DKA, avoid cannabis, recreational cannabis. So this is all about the screening of, we have already discussed the male and female sex health, psychological disease, fasting, and general how to screen the patient. This all about the ADA, a new recommendation, new SOC for this patient. Thank you very much for your patient hearing.
Thank you, sir. We can have one or two brief questions because he has to leave for his flight for Delhi. Brief question, please.
Sir, I don't have any question, but a comment to make. It was one of the best diabetic lecture I have ever heard in my life.
Thank you, sir.
So many cheeses, sleep, dental, this thing, never discussed, never taught. Congratulations. Thank you very much, sir. And of course, your talk was also very good.
So regarding the fasting in diabetes, I must say prolonged fasting like in Jains and Ramadan, fasting mock drill is very important. You can try like whatever you practice in fast should practice before starting the fasting. So that that will be a very important factor. Another thing is CGM, that you can use CGM for seeing the glycemic behavior even in pre-diabetics, because then you can understand which drug to be used to treat pre-diabetes. Suppose only postprandial hyperglycemia is, or midnight hyperglycemia, or in between the meals hyperglycemia is there. And third thing about your question, Americans are very fond of changing the nomenclature. That's why I was laughing, and Dr. B.K. Singh was also laughing about hyperosmolar, coma. That terminology has changed. Thank you very much.
Thank you, Dr. B.K. Singh. Again, we are highly honored to host you at Bathinda. Of facing all the travel difficulties, you made it to Bathinda, for all the hardships. Thank you very much. Now we should rush, I think, to catch your flight.
One last comment to you. I am very fond of my जो हम कवि हैं रामधारी सिंह दिनकर, you must have seen his कविता रश्मि रथी, तो आपके लिए सुटेबल है वो कविता, एक मैं कहता हूँ. This very small, मतलब Bathinda is not in medical field center, but still, but you are single-handedly done this conference for so many years, from 12 years. तो उसमें एक कविता है रश्मि रथी के, है कौन विघ्न ऐसा जग में टिक सके आदमी के नग में, है कौन विघ्न, क्या ऐसा डिफ़िकल्टी है जो आदमी के मन में हो है कौन विघ्न ऐसा जग में टिक सके आदमी के मग में, ठम ठोक ठेकता है जब नर पर्वत के जाते पाँव खड़ा, मानव जब जोर लगाता है पत्थर पानी बन जाता है। तो भाई तालियां बजाइए बैटुल साहब के लिए। थैंक यू।
थैंक यू जी। The next talk is on hyponatremia. Again, it's not very uncommon condition. I think in the previous days, you see, we didn't have the facilities of lab investigations. I mean, since you see, so many labs have come in the market, you see, and this condition has been recognized more and more now recently, and particularly in the ICU setup. And most of the time, I think it is being ignored, you see, for the symptoms, because symptoms are not very consistent. And sodium, you see, is a very critical sort of part of our system, maintaining the fluid balance. It has the nerve function and the muscle functions. And the decreased sodium can have the significant symptoms, even life-threatening at times. So today we have Dr. Mukesh Bhatia. He is from Delhi, so he is going to give us insight about the hyponatremia. Dr. Bhatia, please.
Very, very good morning to all of you. Thanks to the organizing team for inviting me to talk to the illustrious gathering. But before I talk, how many of you are postgraduate at the moment? हाथ खड़ा करेंगे? नहीं सर, मजाक नहीं कर रहे सर. एक्चुअल में जो MD कर रहे हैं, PG कर रहे हैं, no, none, never mind. Because this topic normally when I speak is more of a postgraduate oriented, but anybody can learn. चलिए, अब आप थक चुके होंगे, सुबह के आए हुए हैं, तो बिफोर आई स्टार्ट एक शेर अर्ज है ताकि आपको फ्रेश एक्टिवेट कर दूं. इरशाद बोलो यार. कुछ नशा धीमी बरसात का है, कुछ नशा तेरी बात का है, कुछ नशा धीमी बरसात का है, कुछ नशा तेरी बात का है. तुम यूं ही हमें शराबी ना समझो, तुम यूं ही हमें शराबी ना समझो, ये असर मेरे दिल पर तेरी पहली मुलाकात का है. Study should be a fun, it should be entertaining. I've been teaching postgraduate for last 30 years. अब तक 3 लाख लोगों को मेडिसिन पढ़ाई है. Learning with an entertainment is my way. इसको कैसे फॉरवर्ड करेंगे यार? नेक्स्ट इसे चलिए जी, कैसे करेंगे? ओह, थैंक यू. Well, hyponatremia. Basic normal serum sodium is 135. Oh, pointer. 135 to 145. कैसे? Oh, moisture. ठीक है. चलिए. And we say hyponatremia below 135. This is known to all of you. This is not the way. चलिए. अब मेन चीज़ है इसकी पैथोफिजियोलॉजी. If you understand this, you know 90% of your hyponatremia. देखें कैसे होता है. 3 तरीके का हाइपोनेट्रीमिया होता है. पहला होता है हाइपोनेट्रीमिया विद हाइपरवॉल्यूमिया, नंबर 1. नंबर 2 इज हाइपोनेट्रीमिया विद यूवॉल्यूमिया, SIADH. पहले वाला होता है कंजस्टिव हार्ट फेलियर में, और हाइपोनेट्रीमिया विद हाइपोवॉल्यूमिया ये होता है सेरिब्रल सॉल्ट वेस्टिंग सिंड्रोम. तो ये पहली बात. अब आगे बढ़ते हैं. लेट मी गिव ए सिंपल एग्जाम्पल. ये होता कैसे है? वेल, ये ग्लास है, 100 मिलीग्राम सॉल्ट है, 100 मिलीग्राम पानी है, तो कंसंट्रेशन इज 1 मिलीग्राम पर ml. बिल्कुल ये नॉर्मल है. दिस नॉर्मल. नाउ लुक इनटू दिस. हमने क्या किया, इसी ग्लास के अंदर, इस सेम ग्लास के अंदर आई एड 100 ml वाटर मोर. आई नाउ वॉल्यूम बिकम हाउ मच? 200. The concentration goes to 0.5. This is hypervolumic hyponatremia. That classically that we see in case of condition like congestive heart failure, of course, और बहुत सारी चीज़ें होती हैं. But what I want to emphasize, it is a volume problem, so salt remains same. Can we have a clinical applied? Yes. Here is the role of ultrafiltration जो congestive heart failure करते हैं, हमें से पानी निकालना है. If you take out पानी, definitely 200 ml का 100 ml कर दिया, the concentration again go to 0.5. तो carry home message role of ultrafiltration. चलिए, अब इसी ग्लास को मैंने क्या किया, 200 ml है, यूं कर दिया और 100 ml पानी फेंक दिया. तो क्या हो जाएगा? Now the volume is 100 ml, yes, 200 का 100 फेंक दिया, लेकिन अभी भी कंसंट्रेशन 0.5 ही है, अभी भी कंसंट्रेशन 0.5 ही है. तो दिस इज यू वॉल्यूमिक हाइपोनेट्रीमिया दैट वी सी इन SiADH. गॉट इट? अब नॉर्मल ग्लास में, ये जो ग्लास है, इसमें से मैंने क्या किया, 20 ml वाटर निकाल दिया और 60 मिलीग्राम सॉल्ट निकाल दिया. तो क्या बचा? ये रहा 80 ml पानी बच गया, 20 ml निकाल दिया मैंने, और मैंने 60 मिलीग्राम सॉल्ट निकाल दिया, 40 बच गया. द कंसंट्रेशन गोज टू 0.5. दिस इज हाइपोवॉल्यूमिक हाइपोनेट्रीमिया. तो तीनों में हाइपोनेट्रीमिया है. एक बात आपने नोट की, पंगा इज मेनली ऑफ वाटर. दिस वी अंडरस्टूड राइट नाउ. पंगा पानी ज़्यादा है या नॉर्मल है या कम है, हाइपोनेट्रीमिया इज देयर. तो जाहिर है, तो नाउ वी टॉक अबाउट, मेनली आई विल टॉक अबाउट SiADH. टाइम की लिमिटेशन है. सो नाउ बिफोर अगेन आई मूव फर्दर, थोड़ी बेसिक फिजियोलॉजी आनी चाहिए. Every postgraduate should know this formula. How we calculate plasma osmolality, sodium plus potassium. Multiply by 2, RBS in milligram percent divide by 18, BUN milligram percent divide by 2.8, ये divide है, गलत है 2.8. So we want to convert into millimole. तो sodium plus potassium multiply by 2, RBS millimole and BUN millimole per liter. तो नॉर्मल होती है 275 to 295, किसी बुक में 282 to 300 लिखा है, तो दिस स्टैंडर्ड व्हाट वी टेक इट. दिस एवरी पोस्ट ग्रेजुएट शुड रिमेंबर. और एक चीज़ और, यहाँ पर हमने पोटेशियम भी ऐड किया है. ओके, ये मैं इसलिए कह रहा हूँ कि जब एनाइन गैप कैलकुलेट करते हैं तो उसमें पोटेशियम नहीं लेते हैं ज़्यादातर. विद दिस स्मॉल बैकग्राउंड वी मूव फर्दर. नाउ आई टॉक अबाउट टॉपिक ऑफ SiADH. Syndrome of inappropriate secretion of ADH. Everybody knows ADH act in the collecting tubules and it absorbs only pure water. इसका electrolyte पे कोई effect नहीं आता है. And purpose is to maintain plasma osmolality in a normal range. चलिए, अब definition क्या है? A disorder of characterized by excess of ADH. जाहिर है, excess ADH will cause more and more water reabsorption. Okay, that lead to dilutional hyponatremia and euvolemia. Okay, the mechanism I told you कि क्यों euvolemia है, despite an inappropriate concentrated urine. इसकी बड़ी importance है. I'll talk about this point. What do you mean by concentrated urine? Causes, CNS causes, head injury you should remember with subarachnoid hemorrhage. और malignancy में small cell lung carcinoma. इफ़ यू आर ए पोस्ट ग्रेजुएट, इसको भूलना दंडनीय अपराध है, क्योंकि जब भी आपको एग्जाम में क्वेश्चन आएगा नीट SS का या नीट PG का, अगर हाइपोनेट्रीमिया है तो स्मॉल सेल लंग कार्सिनोमा ज़रूर होगा. तो वही आंसर है. तो आपका पेपर लीक कर रहा हूँ, तो डोंट फॉरगेट दिस मोस्ट कॉमन एग्जाम क्वेश्चन. लंग कॉजेज, ड्रग्स में ड्रग के अंदर कार्बामाज़ेपिन इज द वन विच इज हैज़ अ मैक्सिमम पोटेंशियल ऑफ कॉजिंग हाइपोनेट्रीमिया. और उसके अलावा हाइपोथायराइड को डोंट फॉरगेट. वेल, नोबडी कैन रिमेंबर ऑल द कॉजेज, लेकिन इन तीन को भूलना दंडनीय अपराध है. दंडनीय अपराध बड़ा प्यारा वर्ड है. जब दिल्ली मेट्रो में जाएंगे बोलते हैं दिल्ली मेट्रो में खाना पीना दंडनीय अपराध है. तो ये भी आई लाइक दिस सेंटेंस वेरी एंड आई यूज ऑफन. तो इनको भूलना दंडनीय अपराध है इफ़ यू आर ए स्टूडेंट. तो डोंट फॉरगेट स्मॉल सेल लंग कैंसर, सबरेक्नॉइड हेमरेज, हेड इंजरी एंड हाइपोथायराइड. यहाँ पे मैं हेड इंजरी, आई वांट यू टू रिमेंबर दिस, क्योंकि अभी आई बी टॉकिंग टू रिगार्डिंग सेरेब्रल सॉल्ट वेस्टिंग सिंड्रोम. तो दोनों, वो भी हेड इंजरी में होता है, ये भी होता है. एंड दैट आई विल आस्क ए क्वेश्चन टू पोस्ट ग्रेजुएट, हाउ विल यू डिफरेंशिएट द टू कंडीशन. तो हाइपोथायराइड, स्मॉल सेल लंग कार्सिनोमा, हेड इंजरी आर द मोस्ट कैरी होम मैसेज फॉर यू. Pathophysiology, मैंने पहले कहा था, excess of what ADH causes increased water absorption, that lead to what volume expansion. That body will counteract by decrease aldosterone and renin, and that lead to loss of water. So this is how body maintain the normal volume or slightly high volume. ANP, BNP, they all know they lead to loss of water and sodium. So ultimately, it lead to euvolumic hyponatremia. The point I already mentioned to you, कि 200 ml पानी का ग्लास था, 5.5 concentration, मैंने 100 ml पानी गिरा दिया, the volume became normal and concentration is reduced. Net result क्या है? Sodium less than 135, that's the definition of hyponatremia. Number 2, reduce plasma osmolality. क्यों? अभी हमने कैलकुलेट किया था प्लाज्मा ऑस्मोलिटी, उसमें आउट ऑफ 295 लगभग 270 इज कंट्रीब्यूटेड बाय सोडियम ओनली. सोडियम इज द वन द मोस्ट पोटेंट आयन विच कंट्रीब्यूट टू ऑस्मोलिटी. अब सोडियम कम होगा तो ऑस्मोलिटी कम हो जाएगी. यूरिन ऑस्मोलिटी इज इंक्रीज, इट का नो एडिमा, नो हाइपरटेंशन. दिस अ क्लासिकल क्वेश्चन. नो एडिमा, नो हाइपरटेंशन डिस्पाइट हाइपोवोल्यूमिया. दो चीज़ें ऐसी हैं विच एवरी पोस्ट ग्रेजुएट शुड रिमेंबर जहाँ पे एडिमा फीट नहीं होता है. वन इज कोन सिंड्रोम, दूसरा SIADH. एवरी स्टूडेंट शुड रिमेंबर दो चीज जहाँ एडिमा फीट नहीं होता है. पहला क्या है? SIADH. दूसरा क्या है? कॉन सिंड्रोम. ओके, डोंट फॉरगेट दिस लाइन. वेल, एक और सवाल, प्राइमरी और सेकेंडरी हाइपर एल्डोस्टेरोन को कैसे डिफरेंशिएट करेंगे बाय एडिमा? सेकेंडरी में एडिमा होता है, प्राइमरी में नहीं होता है. एंड नाउ कम द रैंक नंबर 1 क्वेश्चन. कोई पोस्ट ग्रेजुएट हो, क्वेश्चन ओनली फॉर पोस्ट ग्रेजुएट. टेल मी एनी कंडीशन यू नो ऑफ वे द सेकेंडरी हाइपर एल्डोस्टेरोन लेकिन एडिमा फीट नहीं होता है. क्वेश्चन ओनली फॉर पोस्ट ग्रेजुएट. आंसर नंबर 1 गैस्ट्रोएंटराइटिस, नंबर 2 बार्टर सिंड्रोम, तीसरा जिटलमैन सिंड्रोम. ये 3 कंडीशन हैं जहाँ पे सेकेंडरी हाइपर एल्डोस्टेरोन without edema feet. These are ranked number 1 getting questions. Well, अब clinical features क्या होता है? Again, point for postgraduate. It depends on serum sodium and how fast it develops. Not only serum sodium, but how fast it develops is the main point. But देखें, mild symptom, nausea, vomiting, fatigue, जब 125 से 134 होगा. नंबर 2 मॉडरेट के अंदर हेडेक, कन्फ्यूजन, लेथार्जी, और सीवियर के अंदर हाइपो, सीजर. एंड दिस एंटिटी इज वेरी कॉमनली सी इन न्यू बॉर्न्स. वन ऑफ द कॉज ऑफ सीजर इन न्यू बॉर्न्स इज हाइपोनेट्रीमिया ऑल्सो. बट दिस इज सिंपल, नॉट अ वेरी इंपॉर्टेंट थिंग. एंड साइन यूवोलीमिया, नो एडिमा, नो डिहाइड्रेशन. दिस द वन पॉइंट विच रियली डिफरेंशिएट फ्रॉम सेरेब्रल सॉल्ट वेस्टिंग सिंड्रोम. एंड edema and hypertension are not the feature of SIADH. And now come the prize-winning question for all of you. कि hyponatremia and brain का क्या relation है? This every postgraduate should remember. This question is asked every year in the exam. Now, normal state में cerebral cell, plasma osmolality ठीक है, सही है, ठीक ठाक है, और body के अंदर it's equilibrium with water, normal. Now, what happen? 2 पॉसिबिलिटी होती हैं जब प्लाज्मा ऑस्मोलिटी गिरती है. मैंने कहा था इट डिपेंड ऑन नॉट ओनली सीरम सोडियम बट ऑल्सो हाउ फास्ट इट डेवलप. दिस इज द मेन रीजन. स्लोली डेवलपिंग में क्या होता है? स्लोली डेवलपिंग हाइपोनेट्रीमिया पॉइंट, इफ प्लाज्मा ऑस्मोलिटी डिक्रीज ग्रेजुअली, क्रॉनिक हाइपोनेट्रीमिया, सेरेब्रल सेल हैव ए टाइम टू अडेप्ट. सेल इनिशियली टेक वाटर ड्यू टू ऑस्मोटिक, पहले पानी अंदर जाएगा एज यूजुअल, लेकिन बाद में टू अवॉइड सेल स्वेलिंग, न्यूरॉन लूज सेलुलर ऑस्मोलाइट, पोटेशियम, अमाइनो एसिड एंड मायोआइनोसिटॉल. दिस क्वेश्चन केम लास्ट ईयर इन नीट SS एग्जाम. तो क्या करेगा? स्लोली पोटेशियम बाहर, अमाइनो एसिड बाहर, मायोआइनोसिटॉल बाहर. इसका फायदा ये रहेगा विद एडेप्शन सेल साइज रिमेन्स नॉर्मल. सो यहाँ पर रिमेंबर, इन क्रॉनिक हाइपोनेट्रीमिया सेल स्वेलिंग नहीं होगी तो सेरेब्रल एडिमा इज नॉट ए फीचर. आई रिपीट अगेन, इन क्रॉनिक हाइपोनेट्रीमिया सेरेब्रल एडिमा इज नॉट ए फीचर because of body has adapted by losing potassium, myoinositol and amino acid. लेकिन acute sudden hyponatremia क्या होगा? Again, water will enter the cells because of hyponatremia, and that lead to cellular swelling, and that lead to cerebral edema. Okay, and that can lead to, in case ICP, that can lead to herniation, cerebral tonsil may come down, and that lead to death. So point to be noted, क्या सीखा हमने? It's not only serum sodium, but how fast it develops is also very important to talk about. Well, this is a beautiful picture. ये normal cell है, ये normal cell है, ये chronic hyponatremia है, chronic hyponatremia cell size normal है, ये acute hyponatremia cell soil बढ़ गई, and that lead to cerebral edema. याद रहे, serum sodium is normal in both the condition. Well, clinical picture, अब जब chronic को treat करेंगे even, तो कभी भी always का treat very slowly, otherwise it can lead to osmotic demyelination syndrome, which can lead to acute paraplegia. How to investigate a case of hyponatremia? Serum sodium कम होगा, बिल्कुल ठीक है, osmolality कम होगी, that we know, and ADH level is usually high. And urine के अंदर osmolality high होगी, sodium high होगा, उल्टा है. सीरम के अंदर सोडियम भी कम है, osmolality कम है, यूरिन में दोनों बढ़ गए हैं. एंड लैब पैरामीटर नॉर्मल सोडियम ये है, और यहाँ पे लेस देन 135, osmolality 275 जिससे कम होगी, यूरिन सोडियम लेस देन नॉर्मल, यहाँ पे मोर देन नॉर्मल. पॉइंट टू बी नोटेड, ये सेम फाइंडिंग वी गेट इन केस ऑफ इन कंडीशन लाइक एक्यूट ट्यूबुलर नेक्रोसिस में यही होता है, लेकिन यहाँ पे यूरिन ऑस्मोलिटी हाई होती है. और देन वाटर लोडिंग टेस्ट, normally we call the patient and we give 20 ml of water per kg, and को 20 मिनट पी लेगा. नॉर्मल पर्सन विल secrete more than 90% within 4 hours, लेकिन इनमें it is less than 90%. This so called water loading test is done. But most accurate test is serum ADH level. Barter and Short criteria के बारे में to diagnose hyponatremia with hyposmolality. Number 2, increase urine concentration. Number 3, urine sodium more than 40. का चौथा, clinical euvolumia, no sign of dehydration, no edema also, normal kidney function, no diuretic use. ये criteria है, not very important. Treatment, stop the जो भी problem है, whatever reason, and the immediate and the most important is restrict water intake. Normally we lose water by 1000 ml per day. तो अगर पानी भी बंद कर देंगे तो भी उसका hyponatremia ठीक हो जाएगा. Oral salt we can give in some cases. We can give conivaptan or 12'th. They act on the vasopressin receptor. Severe cases may we give 3% saline, but very, very important line. Should be given very slowly so that sodium doesn't rise more than 0.5 to 1 milliequivalent per liter per hour. Otherwise, it can lead to osmotic demyelination. Golden line to remember. Carry home message for all the postgraduate. Most common, number 1, most common malignancy causing SIDH is small cell lung cancer. Number 2, most common drug is carbamazepine. Number 3, volume static, euvolumic, no edema feed. Number 4, rapid correction can lead to osmotic demyelination. Number 5, first line treatment, acute chronic, is water restriction. The last slide, cerebral salt wasting syndrome, hypovolemia, head injury and salt craving. जब ये लाइन मिल जाए या पेशेंट मिल जाए कि बंदा आता है जी नमक खिलाओ, आपका एक दोस्त आया आपके घर में, उसकी हेड इंजरी हुई थी और आपको मिठाई खिलाएंगे कि यार ये मत खिला, तो नमक खिला. नमक कौन खाता है? जब कोई नमक खाने वाला बंदा मिल, सिर्फ नमक मुट्ठी भर के, हिस्ट्री पूछो, वो किचन, उसकी माँ कहेगी मेरा बेटा किचन में जाके नमक की ऐसे लेके यूँ खाता है. ये कहीं नहीं मिलता. अगर ये चीज़ मिल जाए तो क्या आंसर है? आंसर है सेरेब्रल सॉल्ट वेस्टिंग सिंड्रोम है ये वाला. कैरी होम मैसेज. और हेड इंजरी में मैंने कहा था इसमें ये भी मिलेगा, और इवन SIADH भी हेड इंजरी में मिलेगा. नाउ लेट्स फाइंड आउट ब्रीफली, क्यों टाइम कम है. लास्ट स्लाइड. दोनों में SIADH दोनों में सोडियम कम होगा, हैं? मैं ले लूँ? तो क्या है, पहले बोलते तो मैं तो और भी मैं तो नहीं 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 सर, ऐसा है, पिक्चर तो एक ही बार देखी जाती है। चलिए, तो इसमें फिर आई लाइक टू टेक लिटिल एक्स्ट्रा टाइम विद यू कबॉल जी। ही इज़ ए वंडरफुल होस्ट, गिव ए बिग हैंड टू हिम, वी रियली अप्रिशिएट। तो फिर यहाँ आ जाता हूँ यार। चलिए, तो दोनों में सोडियम कम है। यूरिन ना पॉइंट, यूरिन इस वाले में यूरिन सोडियम ज़्यादा है, क्योंकि इसमें बहुत ज़्यादा होता है। यहाँ पे मोर देन 100, यहाँ पे लगभग 150 पौने 200 होता है। यूरिन आउटपुट नॉर्मल, यहाँ पे बहुत ज़्यादा होता है। उसके बाद नाउ कम आईवी वॉल्यूम स्टेटस, यहाँ पे नॉर्मल, यहाँ पे डिहाइड्रेशन। दिस वन पॉइंट, क्या मतलब इसका? हेयर आई टेक 1 मिनट। आप पोस्ट ग्रेजुएट हैं, आपकी ड्यूटी है हॉस्पिटल में, आज इमरजेंसी जो ड्यूटी है। अब आपने कहा यार डॉक्टर भाटिया का लेक्चर है, हाउ कैन आई मिस? आपने सिस्टर को कहा यू आर पोस्टेड इन आईसीयू, ठीक है, और सिस्टर का सिस्टर बस मैं गया और आया, यूं गया और आया। यू गेट ए कॉल राइट नाउ, आईसीयू की सिस्टर, डॉक्टर, ओके ओके डॉक्टर, नर्सेज बहुत तेज बोलती हैं, तो आप कैसे बोलोगे? हाँ सिस्टर। आप तो कॉन्फ्रेंस में बैठे हो, धीरे बोलोगे। क्या है? पेशेंट है हेड इंजरी का। नर्सेज बहुत तेज बोलती हैं, सोडियम कम है। ओके, हेड इंजरी पेशेंट, सोडियम कम, दो चीज़ें हैं। पहला क्या है का SIAD है, दूसरा क्या है सॉल्ट वेस्टिंग सिंड्रोम। दोनों का ट्रीटमेंट उल्टा है। अब यहाँ बैठे बैठे कैसे पता लगाओगे कि बंदे को SIADHS या सेरेब्रल सॉल्ट वेस्टिंग सिंड्रोम? तो आप पूछोगे सिस्टर उसकी जीभ देखो, सी द टंग, अगर टंग ड्राई है तो क्या है? सेरेब्रल सॉल्ट वेस्टिंग सिंड्रोम है। टंग नॉर्मल गीली है तो क्या है? वो SIAD है। यहाँ बैठे बैठे आपने जवाब दे दिया। क्यों? क्योंकि आपको बेसिक कंसेप्ट आते हैं। दोस्तों, अगर ज़िंदगी में तरक्की करनी है, योर बेसिक कंसेप्ट शुड बी वेरी वेरी स्ट्रॉन्ग। ये कैरी होम मैसेज है। तो वॉल्यूम स्टेटस में इसमें नॉर्मल होगा, और यहाँ पे डिहाइड्रेशन, साइंस ऑफ डिहाइड्रेशन, आई डोंट नीड टू टॉक टू टेल टू द इलस्ट्रियस गैदरिंग। साइंस ऑफ डिहाइड्रेशन मिल जाए वो सेरेब्रल सॉल्ट वेस्टिंग सिंड्रोम है, और अगर नॉर्मल हाइड्रेशन है तो SIAD है। उसके बाद सीरम ADH लिखते हैं, करता कोई नहीं है। लेकिन सबसे इंपॉर्टेंट चीज़ है ट्रीटमेंट, रिस्ट्रिक्ट वाटर इन केस ऑफ SIAD है, और यहाँ पे क्या है? गिव एक्सेस सॉल्ट एंड वाटर इनटेक। तो इस स्लाइड में क्या सीखा? हेड इंजरी पेशेंट, साइंस ऑफ डिहाइड्रेशन, सेरेब्रल सॉल्ट वेस्टिंग सिंड्रोम, ट्रीटमेंट इज इंक्रीज सॉल्ट एंड वाटर इनटेक, और अगर इसका हाइड्रेशन नॉर्मल है, रिस्ट्रिक्ट वाटर इनटेक। सिंपल। दिस हाउ व्हाट कैरी होम मैसेज। ओके, मेडिसिन सिंप्लीफाइड बुक अवेलेबल है, अल्टीमेट बुक, एक कॉपी है मेरे पास, आई कैन शो यू, एनीबॉडी वांट टू सी इट एंड यू कैन क्लिक। कोई क्वेरीज होंगी, यू कैन आस्क मी क्वेश्चन, कोई टाइम की कमी है, और you can talk later on. Thank you. Thank to our organizing team. Thank you very much to all of you for patient listening. Thank you very much. Thank you very much.
Thank you, Dr. Bhatia. I think after a long, long time, it reminds of our medical school days. I mean, like our teacher, the way he has explained each and everything in a very, very simplified way. I think most of the people probably will understand what hyponatremia is and how to treat it and how to recognize it. I tell you just one simple example of the way he has said SIAD is the common is a small cell carcinoma. You see, way back almost 50 years ago, there was a round, so I was working one of the hospitals in London. So on the rounds, when we told the consultant that this patient has got a small lesion at the right apex of the lung, and he's got hyponatremia. We didn't know anything about what hyponatremia is. You know, the first answer is from the consultant. He said, give a call to the chest physician to do a bronchoscopy to tell me that this patient has got a oat cell carcinoma. That was 50 years ago. You see, I still remember his wording. And ultimately, when he did the bronchoscopy, it turned out to be oat cell carcinoma. So I think in all SIADs, we must investigate patient thoroughly to rule out the underlying lesion. I think that is very important. With these words, thank you very much. Anybody having any questions, please?
Thank you very much.
Thank you very much, Dr. Bhatia, for an enlightening talk. A little bit of delay in Dr. Clay's coming, so I will fill up with my lecture on pollution. So I will be talking about a upcoming branch or risk factor, that is air pollution in 21st century, challenges and solutions. So I start the lecture with tributes to my late father, Comrade Ved Prakash Gupta, and gratitude towards my friend, mentor, guide, Dr. Gurpreet Singh Wander. Coming on to the topic, the United Nations Environmental Programme defines pollution as the direct or indirect alteration in biological, thermal, physical, or radioactive properties of any medium in such a way as to create a hazard or potential hazard to human health. So these things are real important, that is, create a hazard or potential hazard to human health or to the health, safety or welfare of any living species. So that include animal, plants, etc. So whenever they are threatened with adverse effects, that content we call it as pollution. So to define air pollution, the contamination of indoor and outdoor environment. Mind you, the pollution is indoor as well as outdoor by any chemical, physical or biological agent that modifies the natural characteristics of the atmosphere. So this we include under the definition of air pollution. So causes, we all know, we have already discussed, that can be outdoor, that can be indoor, and air pollutants include particulate matter, nitrogenous oxides, sulfur dioxide, carbon monoxide, ozones and volatile organic compounds. So these are the major constituents of air pollution. So it can be because of industrial emissions, transportation, agriculture, household activities or burning of fossil fuels. So these are the main causes which are leading to air pollution. In 21st century, air pollution presents a significant global challenge. So that is what we are talking about. WHO reports 9 out of 10 people. So this is a major statement by WHO that 90% of the population worldwide breathe polluted air. So 9 out of 10 people are living under the influence of air pollution, with India being one of the most affected countries. In India, air pollution is now considered to be as significant public health issue, and you find daily media reports of air pollution. It is affecting almost every major city in India. China and India has largest number of premature deaths due to air pollution. Now it is evidence based. The scientific literature states that premature deaths are increasing because of air pollution, and it is estimated that air pollution costs India approximately $36.8 billion annually, which is about 1.36% of annual GDP. So this is almost equal to the health budget of India. So this slide is quite scary because air pollution, 63 Indian cities are among the first 100 polluted cities in the world. So we are living, India is a major population who is living in air polluted conditions. So what are the challenges? Challenges include global health burden and climate change. Climate change, you again will find media reports that climate change is leading to adverse environmental issues, increasing floods, increasing rains, increasing cloudbursts, landslides, etc. So what is health? Health is a state of complete physical, mental, social well-being, and not merely absence of disease or infirmity that we all know from WHO definition, and emphasizes on resilience, adaptability with dimensions to present a holistic view such as emotional health, spiritual health, intellectual health, environmental health, occupational and vocational health, as well as financial health are now being included in a broader definition of what is health. So this slide again tells us about the Indian challenge about air pollution. Air pollution shortens the average Indian life expectancy by 5.2 years. So this is a major fact. 1.4 billion people in India live in the areas where annual average particular pollution levels exceeds WHO guidelines. So almost every person is living under the influence of air pollution in India. Since 1998, average annual particulate pollution has increased by 42%. So that is what India is facing about air pollution challenge. So this chart again gives us an impression how much air pollution is affecting the world. So Earth's health and health of Earth's inhabitants, both planet as well as their inhabitants, are linked together. Pollution and climate change are interlinked and increasingly being recognized as gravest threat to both Earth and every living being on Earth. Pollution is now recognized as a silent crisis and a grave public health issue. Adverse effects of pollution are not only with air pollution, but equally serious and not very much talked about. Soil pollution, water pollution, noise pollution is again a very important issue. You go to any marriage, people enjoy high sound orchestra. You go to gym, the sound is very high and people don't realize that it is having adverse health effects, but they enjoy, and that enjoyment in future is going to lead to health issues. Air pollution not only impacts Earth's ecological system, but also contributes to burden of disease, leading to significant economic and societal cost. This emphasizes the far-reaching impact on human health. So we must stress on this, that air pollution, which was considered years before that only affecting the lung health, is affecting each and every aspect of Earth's inhabitants, whether humans, plant, anything you consider, it is being affected by air pollution. So if we consider mortalities and morbidities due to air pollution, in India in 2017, despite constituting 18% of global population, it accounted for 26% of global disability adjusted life years attributed to air pollution. So this is a huge number. 8% of India's overall disease burden and 11% of premature deaths among people less than 70 years of age are directly linked to air pollution. Ambient pollution contributes to about 0.67 million deaths, and indoor pollution, which was responsible for about 0.48 million deaths in India. So if we consider impact on health, you see it is impacting almost each and every system of the body, that is heart, reproductive system from head to toe, respiratory system, gastrointestinal, arteries, and leading to obesity, diabetes, bladder cancer, kidney cancer, systemic inflammation, and ultimately leading to increased mortality. So this book we published this year, and it was released in Delhi by Dr. Jitendra Singh, Union Health Minister. So this is the comprehensive first of its kind in the world, which is having 34 chapters. Each chapter is pertaining to the effect of air pollution, or pollution you can say, on every part of the body, whether you consider reproductive, you consider neurological, gynecological, eye, ENT, every part of the body is affected. And this is comprehensive book which you can download free of cost from our website www.apimalwa.com, and this we are distributing free of cost at the PDF copy. So these are the chapters. If you enumerate, every chapter is considering the cardiovascular health, communicable diseases, hypertension, atherogenesis, heart failure, metabolic health. So all these systems are included in this book. So that is how we at least I was apprised that how air pollution is adversely affecting our body. So what are the mechanisms? Mechanisms again are very worse and affecting through each and every part. So it starts with the upper respiratory tract, lower respiratory tract, affecting the alveoli, which is leading to prenatal exposure, epigenetics, immunology, oxidative stress, and it starts from the airways and alveoli. So that is the portal of entry from where the mechanism or pathophysiology starts. So it is impacting the air pollution and metabolic health. I will not go in detail, but this cartoon depicts how it is impacting the metabolic health, and similarly the cardiovascular diseases. Basically, we should be apprised that mechanisms are there by which we infer that how air pollution is affecting each and every system. So this is how cardiovascular system is being affected. This is how hypertension is going to increase under the influence of air pollution. This is having neurotoxic effect. Until unless I started with the book, I was not knowing what is the pathomechanism of air pollution having neurotoxic effect. So this is the stroke mechanism, and you won't believe that it is increasing the incidence of Alzheimer's disease also through a set pathomechanism which is depicted here. So it contributes to depression. So depression is not only the disease as such, but air pollution is one of the risk factors causing depression. Non-communicable diseases attributable to air pollution encompasses a spectrum of serious health conditions, notably heart disease, stroke, chronic pulmonary obstructive disease, and lung cancers. So these types of NCDs are linked to air pollution, including respiratory diseases, cardiovascular diseases, cancers, metabolic diseases, as well as neurological diseases. So if we consider burden of disease in India, air pollution contributes to about 1.67 million deaths annually in India, and vulnerable population include children, elderly, low socioeconomic groups, and deprived section of society, including pregnant women also. So these are the vulnerable groups who must take care to live or mitigate air pollution. At least they can decrease the indoor air pollution, because the outdoor air pollution may not be in their hands, but still if there are deprived sections, elderly, children, and pregnant women should have a clean indoor environment. So climate change is said to be the gravest existential challenge to the planet Earth, environment, economy, as well as human health. So including these 21st centuries, first we have discussed the health, and that next is climate change. WHO has sounded alert that climate change is a fundamental threat to human health. So 3.6 billion people already residing in highly susceptible areas to climate change endure the hardest health impacts as well as environmental effects. So what is climate change? It refers to both global warming as well as its effect on Earth's climate and weather patterns. Climate change has increased the intensity and frequency of extreme weather events like droughts, hurricanes, heavy rainfall, as well as heat waves. Melting ice caps and glaciers, marine life has been affected. Climate change is threatening the biodiversity. Climate change, as WHO has warned, is impacting human life and health like never before, with serious economic consequences. And this is how the climate change is affecting. It is leading to global warming, heat events incorporated with air pollution, age, socioeconomic status, and health status. It is increasing our vulnerability and increasing adverse health effects. So again, climate change is, we have discussed the air pollution pathophysiology, how it is adversely affecting health, and this is how climate change is affecting adversely the population. So this is neutral heat exposure. Again, I will not go into detail, but just apprise you, there is set pathophysiological mechanism that the impact of climate change on adverse health effects. So Earth's health and health of the Earth inhabitants are incruciably linked to each other. Pollution and climate change are interlinked and increasingly being recognized as the gravest threat to both Earth and every living being on Earth. Mark these lines. The population, the human population, as well as every living being on earth is being affected. So what are the solutions and way forward? So this is a topic in itself, but briefly, climate change, environmental pollution, terrorism and many other global threats do not stop at borders. So they are across border threats. We all bear the global responsibility and thus need a global identity to enable us to cope with them. We must learn to integrate different levels of identity in ourselves. Policy and regulatory solutions are of prime importance. With aid of technological innovations, we can mitigate the effect of air pollution and climate change, behavioral and lifestyle changes with sustainable transportation, improved indoor air quality, and waste management will go a long way in mitigating the adverse health effects. So challenges in addressing air pollution, lack of awareness is first and foremost. So our book is going to help sensitize the people about health effects affecting each and every system of the body, and ineffective enforcement. Again, today's headlines were stubble burning. So there was lack of enforcement and lack of incentives also, which is leading to increasing air pollution. Urbanization, we cannot stop urbanization. It again is leading to environmental hazards. To conclude, my dear friends, in 21st century, air pollution is fast becoming a major driver of adverse health effects in India. Tackling air pollution is essential for improving public health outcomes. So this is real important. If we don't contain, mitigate, decrease air pollution, we are in for increasing adverse health effects. Urgent action is needed from policymakers, health providers, and public health to curb pollution levels and mitigate health effects. So this is the book. We are promoting this. Please download the book from www.apimalwa.com and go through it. Thank you very much.
Thank you, Dr. Vittal, for filling the gap. I think, you see, when you say challenges, I personally feel, I mean, whatever we are doing, the most important part is the population control. See, until and unless we control the population, you see, all these problems are not going to reduce, you see, whatever we may do. After all, the amount of earth is limited and the number of people are increasing. So we need a space, you see, and the space is not there. So probably that is creating all the problems. See the number of vehicles because of all these people and the land. All those things probably they're all related to the air pollution, climate change, and all that thing. And I personally feel that we must control our population before doing anything seriously to control the pollution-related diseases. Next speaker. After listening to so many academic sessions, so now I have come to a little lighter side of the academic part. The talk is Heart to Heart Talk by Dr. T.S. Kaler. And the little, I mean, though he doesn't need any introduction, but just few words about him, you see. And he is a prominent Indian cardiologist, a great friend, a guide, and his particular interest is electrophysiology. He is a pioneer of electrophysiology in India and Southeast Asia, and he is the person who started electrophysiology first center in India. So three cheers for him. And he's also a pioneer in starting the intracardiac devices the first time in India, you see. He's again pioneer for ICD, sort of thing. With all these words, you see, I'll request and I'll call Dr. Kaler for his talk, please. When we say heart to heart talk, in Hindi we say dil se dil ki baat. Or when we say in Punjabi, dil diyan gallan. So Dr. Kaler, please.
नौरिया साहब, मेरे को लगता है कि पॉपुलेशन प्रॉब्लम नहीं है हमारी ना. आई टेल यू, आई डोंट नो हाउ मेनी ऑफ यू हैव बीन टू चाइना. China is equally populous country as compared Indian, but China is, if not more, 60, 70 years ahead of us. So India में क्या problem है boss? India में problem है lack of discipline, lack of integrity, lack of accountability. It has never, the day we got freedom, दो तीन चीज़ें करनी चाहिए थी जो गवर्नमेंट ने नहीं करी. सबसे पहले ये करना चाहिए था, वी गॉट डिवाइडेड ऑन द बेस ऑफ रिलीजन. वो हमारे भाई थे ना, हमारे साथ ही रहते थे टिल अगस्त 47 और फ्यू मंथ्स बिफोर दैट. उनकी बहनें को हम बहन मानते थे, वो हमारी बहन को हम मानते थे. फिर क्या हो गया 10 दिन में कि उन्होंने मारना शुरू करा, एक दूसरी बहनों के रेप करना शुरू कर दिया. वो क्या था? वो जहर था रिलीजन का. तो जब इंडिया ने आज़ादी पाई और उनको पता था कि ये देश 3 टुकड़ों में बांट गया, क्यों? सिर्फ रिलीजन की वजह से. और क्या पंगा था? और कोई लड़ाई झगड़ा नहीं था हमारा, उनके साथ कोई झगड़ा नहीं था. उसी वक्त ये रूल होना चाहिए था, दी रिलीजन विल नॉट बी अलाउड टू प्रैक्टिस इन पब्लिक. आप घर में जो मर्जी प्रैक्टिस करो, कोई भी इंस्टीट्यूशन धर्म के नाम की नहीं हुई. गुरु नानक स्कूल, अभी गुरु नानक का स्कूल कैसे हो सकता है? आप किसी स्कूल को गुरु नानक का स्कूल लिख रहे हो, उसमें टीचर अच्छे नहीं, बच्चों को पढ़ाई की फैसिलिटी नहीं, गुरु नानक का तो नाम बदनाम कर रहे हो आप. ये शुरुआत ही गलत करी हम लोगों ने. इट वॉज ए बिग ब्लंडर. सो दूसरी चीज़ है कि हमारे कंट्री में शुरू से कोई अकाउंटेबिलिटी फैक्टर है नहीं. जब अकाउंटेबिलिटी नहीं तो कोई काम करेगा? कोई नहीं करेगा. चाइना में अकाउंटेबिलिटी है, द मेजर डिफरेंस अकाउंटेबिलिटी है. उन्होंने रोड बनानी है कि बीच में कोई मंदिर आता है, टेम्पल आता है, इट विल डिमोलिश नेक्स्ट डे. यहाँ कुछ नहीं कर सकते आप. सड़क टेढ़ी हो जाएगी, हंगामे हो जाएंगे, स्ट्राइक हो जाएगी. सो ऑल दिस, और ये कंट्री कभी नहीं तरक्की करेगा. लेट मी टेल यू, अगर तरक्की, हम बहुत पीछे हैं. डोंट थिंक कि अब हमारे पास यहाँ पे मोबाइल फ़ोन है, ये प्रोग्रेस नहीं है. वी हैव टू कंपेयर प्रोग्रेस विद आवर अदर काउंटर पार्ट्स. मलेशिया जैसे कंट्री, वो वियतनाम जैसे कंट्री, उनमें भी डिसिप्लिन है. जब आप रोड पे जाते हो कोई लगता है कि डिसिप्लिन है, हमारे तो डिसिप्लिन ही नहीं कोई. दिल्ली द कैपिटल ऑफ इंडिया, द कैपिटल ऑफ इंडिया इज़ ए शेम, इज़ ए प्योर शेम, नथिंग एल्स. कोई इधर को जा रहा है, कोई इधर को जा रहा है. तो मैनी ईयर्स बैक वन ऑफ द डॉक्टर डेविड, ही वाज चीफ ऑफ इलेक्ट्रोफिजियोलॉजी इन मिनियापोलिस यूनिवर्सिटी. तो वो चाइना से आ रहा था, फिर उसका इंडिया का विजिट था. तो मेट्रॉनिक वालों ने मेरे को बुलाया कि सर वो बहुत सीनियर डॉक्टर हैं, तो वी वांट यू टू हैव ए ब्रेकफास्ट विद हिम. मैंने ठीक है. तो हम ब्रेकफास्ट ले रहे थे, तो मैंने उनसे पूछा कि डॉक्टर डेविड, यू हैव बीन टू चाइना एंड यू हैव बीन टू इंडिया, व्हाट डिफरेंस यू फाइंड बिटवीन दीज 2 कंट्रीज. तो ही पॉज फॉर ए मिनट. कहता वेल, कहता देयर इज अ लॉट ऑफ पीपल इन इंडिया, देयर आर लॉट्स ऑफ पीपल इन चाइना. कहना पर चाइना, आई फेल्ट दैट पीपल आर मूविंग विद some idea, with some direction, and the people in India look directionless. And I think it was a very, very good comment. I don't know how he jumped to that conclusion, but मेरे को लगता है कि हम डायरेक्शनलेस हैं. कंट्री में कोई डायरेक्शन नहीं है किसी चीज़ की, कि हमारे जो लीडर थे, जो लीडर आए भी हैं, उनमें कोई विजन नहीं है. अब लुक एट दी पंजाब. मैं पंजाब से, मेरे को बहुत प्यार है, बल्कि हर आदमी को अपनी माँ से प्यार होना चाहिए. प्यार होता है. मेरे लिए पंजाब मेरी माँ है. तो अगर मैं देखूं पिछले 30-40 ईयर्स में जो पंजाब का डिटीरियोरेशन हुई है, डे बाई डे, ये सत्यानाश हो रहा है. दुख की बात है. वी हैड दी बेस्ट GDP इन दी कंट्री. पंजाब वाज शान ऑफ इंडिया, दी प्राइड ऑफ इंडिया. अब हमारी GDP 18th नंबर पे पहुंच गई है. ठीक है. There has been no leader. I am not a political man. There has been no leader, maybe perhaps after Caron, जिसमें कोई विजन हो. चाहे वो अकाली थे, चाहे वो कांग्रेस वाले थे, चाहे वो आप वाले हैं, कोई मेरे को कोई लीडर नहीं मिला जो जिसकी विजन है. और मैं तो ये भी कहता हूँ कि आप जितनी मर्जी करप्शन कर लो, अगर किसी लीडर में विजन हो, करप्ट लीडर में भी वो कुछ बना सकता है. इनमें विजन ही नहीं है. दे हैव नो विजन. दैट्स ए पिटी. So population not a problem. Population is asset if you use it the right way. I agree. Right. It has to be used in the right way. देखो एक बनिया है, उसके 3 बच्चे हैं, उसकी गांव में हट्टी थी, वो तीनों बच्चे बड़े हो गए, थोड़े बहुत पढ़ गए, तीनों ने बिजनेस शुरू कर दिया, शहरों में चले गए, जो बाप का बिजनेस था उसको 10 गुना ले गए. दिस कॉल्ड डिसिप्लिन्ड काइंड ऑफ अप्रोच इन लाइफ. दूसरा 3 बच्चे थे, बड़े हो गए, तीनों आपस में लड़ रहे हैं कुत्तों की तरह, जो बना था बाप ने वो भी बर्बाद कर दिया. सो इट्स ए क्वेश्चन ऑफ द डायरेक्शन. वी लैक डायरेक्शन इन दिस कंट्री. और दुख की बात ये भी है कि बहुत से लोग, हमारे जैसे लोग, हम अपने बच्चों को भी सही डायरेक्शन नहीं दे रहे, उनको भी डायरेक्शन नहीं हम सही दे रहे, ताकि फ्यूचर भी हमारा, मेरे को डाउटफुल लगता है कि क्या है, बल्कि दी थिंग्स आर गोइंग दी रिवर्स डायरेक्शन. कि जो हमारे संस्कृति, जो हमारा कल्चर था, जिसमें कुछ वैल्यूज़ थी, वो इरोड हो रही हैं. मैं बहुत बार मेट्रो में ट्रैवल करता हूँ दिल्ली में, बहुत बार, क्योंकि दिल्ली में कार से जाना इज़ बिग चैलेंज. तो हर कोच में देयर इज़ अ स्पेस फॉर सीनियर सिटीजन्स. ठीक है, कोई बंदा सीट नहीं देता. भाई कहाँ पहुँच गए हम? मतलब द टाइप ऑफ डिटोरेशन वी हैव इज़ रियली पेनफुल. So anyway, this was not my talk, but this is only instigated by my friend Malwa. हाँ जी, मन की बात. So पहली बात तो मन की बात ये करूँगा मैं, जो पीछे मेरे दोस्त खड़े हैं, प्लीज़ अंदर आ जाइए भैया. विठल, डॉक्टर विठल, अंदर आ जाओ. आपके बिना दिल नहीं लग रहा, अंदर आ जाओ. मैं दिल की बात कर रहा हूँ, दिल वाला बाहर चला गया. हाँ ना, बाहर नहीं जाना. देखो पता क्या है, हाय तो बात ये है कि जब मैं अंदर आया हॉल के, मेरे को थोड़े बंदे नज़र आए, ज़्यादा नहीं थे. मैं सोचा क्या यार गलत गड़बड़ है कुछ. पहले मेरे ख्याल आया कि मैं एसएसपी पे फ़ोन करूं कि भाई ट्रक भर के लेके आ यार बंदों का कि भैया डंडे मार लेके आओ उनके. ठीक है, पर फिर सोचा यार सो रहा होगा, संडे है, चलो कोई बात नहीं. सो एनीवे दी थिंग है, देखो जो मेरा 30-40 ईयर्स का एक्सपीरियंस है, उसमें धक्के बहुत खाए हैं, धक्कों से सीखता भी है इंसान. सो मैंने ज़िंदगी में क्या रियलाइज़ किया, मैंने ये रियलाइज़ किया है कि देयर आर 3 थिंग्स इंपॉर्टेंट इन लाइफ, ओनली 3. व्हाट आर दोज? मैडम आप बताओ, आपसे पूछती हूँ. हाँ बोलो बोलो, कोई नहीं, घर की बात है, ये कोई क्लास नहीं, कोई टीचर नहीं, मैं नंबर नहीं दूंगा आपको. बोलो, what are 3 most important things in life? पैसा, बच्चे और हैप्पीनेस. चलो ओके. सो what is my concept? My concept is, first is health, number 2 is health, number 3 is health. Nothing else is important. पैसा important नहीं, आपके बच्चे important नहीं, आपकी वाइफ important नहीं, आपका हस्बैंड important नहीं, आपकी गर्लफ्रेंड important नहीं. Why? अगर आपके पास हेल्थ ही नहीं है, किसी गर्लफ्रेंड का कोई फ़ायदा नहीं. क्या फ़ायदा? चाहे वो मिस इंडिया हो, लेकिन आपको सांस चढ़ रहा है तो क्या करोगे? राइट. नहीं, पर मैं चाहता हूँ, मैं इसलिए बैठा हूँ कि आप मेरे से बहुत यंग लोग हैं यहाँ, कम से कम वो सुधर जाए. ठीक है, ठीक है. सो भैया, सबसे जो ज़्यादा ज़िंदगी में कीमती चीज़ है वो हेल्थ है. वो जैक मा है ना, जो अली बाबा का क्रिएटर, वन ऑफ द वेल्थिएस्ट मैन इन द वर्ल्ड. तो उसने वो कहता है, उसकी सेइंग है कि इफ़ यू थ्रो $200 इन फ्रंट ऑफ ए मंकी एंड यू आल्सो थ्रो 2 बनानाज, एक केले रख दो, एक $200 रख दो, वो बंदर ने केले चकने हैं. क्यों? पता क्यों? कि बंदर ਨੂੰ ਇਹ ਅਕਲ ਨਹੀਂ ਕਿ $200 ਦਾ ਇੱਕ ਟਰੱਕ ਆ ਜਾਏਗਾ ਕੇਲੇ ਦਾ, ਉਹਨੂੰ ਪਤਾ ਨਹੀਂ. Similarly, most of the people in this world, me all of us, don't realize that health can bring a lot of money. Actually, health can bring a lot of money. You know, ये अनिल अंबानी एक बार अमेरिका गया, इसकी कंपनी की कोई टाई अप होना था, नेगोशिएशन हो गई थी, सारा कुछ फाइनल मतलब बोर्ड मीटिंग थी साइन होने के लिए. तो जो दे वर ऑल ऑन दी दैट रूम, तो उस कंपनी का जो अमेरिकन कंपनी का CEO था वो भी था, and Anil Mani, they had to sign that day. Practically every homework was done. तो वो आया तो अनिल अम्बानी को पहले मेल से या फ़ोन से बातें हुई थी, कभी फिजिकल नहीं मिला था। तो अनिल अम्बानी काफ़ी मोटा था उन दिनों में, तो उसने कहा कि सॉरी मिस्टर अम्बानी, वी कैन नॉट साइन ए डील विद यू। He said, what happened? He said, I'm not sure your own future. So I don't want to tie up with a man whose health is in doubt. And I think he got a shock of his life and he came to India, फिर दौड़ना शुरू किया, कम खाया, then he made his health. So health बहुत important, हम नहीं समझते, हम रियलाइज नहीं करते इस चीज़ को, चाहे डॉक्टर भी हैं हम, डॉक्टर भी इस चीज़ को रियलाइज नहीं करते कि भैया हेल्थ बहुत ज़रूरी है। सो मेरा अगेन एंड अगेन स्ट्रेस यही रहेगा कि जो डॉक्टर हैं पर्टिकुलरली, तो वो तो समझें कम से कम, क्यों वो तो हेल्थ, दे आर हेल्थ गिवर्स, अगर उनकी हेल्थ नहीं है तो फिर क्या फ़ायदा है। अब इंडिया के ये सीन है कि वी हैव लॉट ऑफ चैलेंजेस। 83% of their studies, I'm quoting not studies, 83% doctors complain emotional stress. They almost 70% feel that they feel fear in working place of intimidation, of कि फलाना केस ना कर दे, मेरा कोई आके दुकान ना तोड़ दे, ये पेशेंट मर गया, ये क्या होगा। And female doctors even 87%. These are data because they have, females have more challenges. They have challenge at home, they have challenge of working as a professional, they have double headache. And almost इंडिया में स्टडीज़ हैं कि डॉक्टरों की जो एज है इट इज़ 5 years लेस दैन द जनरल पॉपुलेशन। सो इट्स नॉट अ गुड सीन, ठीक है। सो वी नीड टू डू समथिंग फर्स्ट अबाउट अवर सेल्स। एंड व्हाट इज़ दिस, एक तो मैं कहूँगा कि द मोस्ट इम्पॉर्टेंट थिंग इज़ कि वी हैव टू गेट यूनाइटेड। द डॉक्टर्स इन इंडिया आर नॉट यूनाइटेड, वो एक दूसरे की बुराई करते हैं लोगों के सामने, और पॉलिटिशियन और बाकी लोगों को यही चाहिए। अब मैं कभी दिल्ली में कहीं पार्टी जाता हूँ तो बड़ी कॉमन सी चीज़ है, डॉक्टर साहब कारपेट में तो आपको सबको टारगेट मिलते हैं, और ये लोगों का कंसेप्ट बन गया है। तो मैंने कहा भैया मेरे को तो किसी टारगेट दिया नहीं, अब कारपोरेट बंदा कैसे आपको दे सकता है टारगेट, ठीक है। नो टारगेट कैन गिव एनी डॉक्टर एनी टारगेट, एटलीस्ट मेरे को किसी ने नहीं दिया। सो टारगेट तो डॉक्टर खुद लेते हैं। तो अगर मैं कहूँगा जी मेरे को तो 20 लाख चाहिए महीने का, अगर मेरे को 20 लाख चाहिए तो वो कहेंगे जी ठीक है आपको 20 × 10 कि आप 2 करोड़ का बिजनेस लेके आओ, ठीक है। उनकी जो कैलकुलेशन है इन प्राइवेट सेक्टर, रफली मैं बता रहा हूँ आपको कि कैलकुलेशन इज़ कि इफ़ ए डॉक्टर इज ब्रिंगिंग रेवेन्यू ऑफ 100 रुपीज़, उसको 10 रुपये देंगे वो। अगर थोड़ा स्मार्ट है बिटल की तरह शायद 15 मिल जाएंगे क्योंकि नहीं क्योंकि नो देखो अल्टीमेटली लाइफ में ये भी डिपेंड करता है आप नेगोशिएटर कितने अच्छे हो ना। अगर नेगोशिएटर अच्छे हो, अगर लगता है आपका पलड़ा भारी है तो वो परसेंटेज बढ़ जाएगी, बट ऑन एन एवरेज मतलब 10% देते हैं। अगर कहोगे भी मेरे को 20 लाख चाहिए, 2 करोड़ का रेवेन्यू लाओ, तो वो टारगेट देते हैं, हम अपने आप लेते हैं टारगेट। सो दिस इज़ रॉन्ग कंसेप्ट, लोगों के बिल्कुल गलत कंसेप्ट है कि टारगेट मिलते हैं। सो व्हेन वी कम टू यू नो इन लाइफ इन जनरल कि ज़िंदगी का पर्पज़ क्या। अब मेरे को नहीं समझ आया, आई एम सॉरी, मेरे को नहीं समझ आया ज़िंदगी कि मेरे को नहीं पता परमात्मा ने हमें क्यों भेजा है यहाँ, क्या चाहता हमारे से, जो भी है वो। हम आते हैं, बड़े हो जाते हैं, पढ़ते हैं, फलाना करते हैं, बच्चे हो जाते हैं, दोनों मारा मारी करते हैं, पैसे कमाते हैं, फिर बच्चों के पीछे लग जाते हैं, फिर पोतों के पीछे लग जाते हैं, फिर मर जाते हैं। आई डोंट नो व्हाट इज दिस सर्कल, राइट। सो पर मैं जो समझता हूँ क्या पर्पज़ है, मैं चाहता हूँ कि आदमी का पर्पज़ ये है कि पहले तो ही शुड डू समथिंग अबाउट हिमसेल्फ, मीन्स वी शुड एजुकेट आवर सेल्स, वी शुड बी एबल टू अर्न आवर लाइवलीहुड इन ए रिस्पेक्टेबल मैनर, we should look after our health, then we should look after our family and friends, then we should not restrict ourselves to that, then we go beyond, we should look after the society. So this is the way I think. दूसरा मैं ये भी सोचता हूँ कि अगर आप मरने के बाद जीना चाहते हो, दिस इज ए पैराडॉक्स कि मरने के बाद कैसे जी सकता है आदमी को। मरने के बाद अगर जीना चाहते हो, इस वर्ल्ड में रहना चाहते हो, तो कुछ करके दिखा दो, कुछ राइटर बन जाओ, कुछ ऐसी चीज़ लिख दो जो लोग पढ़ें, कुछ ऐसा काम कर जाओ कि दुनिया याद करे आपको। जैसे लता मंगेशकर कभी नहीं मरेगी, रफ़ी कभी नहीं मरेगा, चलो वो तो नेचुरल टैलेंट है, लेकिन परमात्मा ने सब बंदों को इतनी कैपेबिलिटी दी है कि हम कुछ कर सकते हैं। ऐसी बात नहीं है अगर हमारा एटीट्यूड सही हो। चलो अगर नहीं भी करना, हर आदमी नहीं कर सकता, कम से कम मरने के बाद ऑर्गन ही डोनेट कर दो, कम से कम 15 साल 20 साल तो किडनी उसकी आप में जियोगी। द मैक्सिमम लॉन्जिविटी रिकॉर्डेड आफ्टर हार्ट ट्रांसप्लांट इज 33 ईयर्स। तो जो बंदे ने हार्ट दिया था इन ए वे 33 ईयर तो वो और जिया ना इस दुनिया में। सो दीज आर द थिंग विच आई थिंक विच कैन हेल्प अस टू चेंज आवर एटीट्यूड इन लाइफ। जहाँ तक गॉड का सवाल है, मैंने तो गॉड देखा नहीं, मैंने बड़ा ढूंढा, मैंने दुनिया के सारे गुरुद्वारे देख लिए, मंदिर देख लिए, पुष्कर भी चला गया, मैं सारी मस्जिदां भी देख ली, वेटिकन सिटी भी हो आया, मक्का मदीना नहीं जा सका बिकॉज अलाउड नहीं है। मैं अभी रिसेंटली करबला होके आया हूँ, जो कि इस्लाम का सेकंड मोस्ट रिलीजन। मेरे को परमात्मा नहीं मिला, मैं नहीं ढूंढ पाया। अब पूछो मेरे से, सर आप बिलीव करते हो कि नहीं? येस एंड नो, येस एंड नो। यस इसलिए कि ये दुनिया सारी चलती है, जब ब्रह्मांड चल रहा है, एक बीज लगाते हैं हम, पेड़ बन जाता है, एक ओवम से बच्चा बन जाता है, और जब वहाँ रात को सो रहे होते हैं तो मिलियंस ऑफ रिएक्शंस आर अकरिंग इन दी बॉडी। कोई हेपेटोसाइट ये कर रहा है, फलाना ये कर रहा है, कोई मेटाबॉलिज्म हो रहा है। यार कोई तो पावर है ना इस दुनिया को कंट्रोल करने वाली। तो वो पावर क्या है? वो उसको नेचर भी कह सकते हो आप, मैं नेचर कहता हूँ, आप रब भी कह सकते हो। लेकिन मैं एक चीज़ में बड़ा क्लियर हूँ कि गुरुद्वारे में और मंदिर में और मस्जिद में रब नहीं है, वहाँ कुछ नहीं है। इससे मैन मेड स्टोरी, ये तो हमारी क्रिएशन है, इसमें कुछ नहीं है। जो रिलीजन है, पहले आदमी जंगल में घूमता था, कोई गवर्नमेंट नहीं होती थी, फिर कबीले बढ़ने शुरू हुए, उसके बाद रिलीजन का कंसेप्ट आया। रिलीजन का कंसेप्ट क्यों आया? कि किसी तरह तक बंदों को कंट्रोल करना है। सो दिस वाज ए कंट्रोलिंग वे ऑफ पीपल। लेकिन धीरे धीरे क्या हुआ, जैसे दुनिया प्रोग्रेस करी, अब हमारी गवर्नमेंट कंट्रोल करती है। देखो ना, अब मेरे को सिखिज्म नहीं बताता कि लेफ्ट साइड चलना रोड पे, ये तो मेरी गवर्नमेंट बताती है ना। सो आज की घड़ी में मेरे ख्याल में जो रैशनल आदमी है, उसको धर्म की ज़रूरत नहीं है। धर्म बहुत फ़ायदेमंद है, क्योंकि धर्म के बेस पे एक बहुत विश्वास की वॉल है एक आम आदमी के लिए कि मेरा रब मैनू बचा लेगा। असी गुरुद्वारे क्यों जाने? असी गुरुद्वारे जाके कदे ये तो नहीं मंगया कि मेरे जिहड़ा गवांढी उसकी तरक्की हो जाए, ये तो कदे नहीं मंगते ना। असी तो अपने लिए मंगते हैं कि मेरे बच्चे हो जाए, फलाना हो जाए, तिमका हो जाए, मैं पास हो जाऊँ। सो दैट वे रिलीजन इज़ ए ग्रेट वॉल। जब आदमी प्रॉब्लम में होता है, बीमार होता है, तो लोग मंदिर जाते हैं कि मेरे को परमात्मा, ये दिस इज़ ए गुड पार्ट ऑफ रिलीजन। बट द अदर पार्ट इज़ वेरी डेंजरस, वेरी मेलिशियस, जिसकी वजह से 1 मिलियन पीपल डाइड व्हेन इंडिया एंड पाकिस्तान डिवाइडेड। Even in Christianity, millions of people have been killed in the name of religion, and it continues. अब पैलेस्टीन में क्या हो रहा है? क्या पंगा है? कुछ पंगा धर्म का पंगा है ना। अब ये देखो, इजरायलीज आर बम्बार्डिंग देयर गाजा स्ट्रिप, दे डोंट इवन बॉदर के बच्चा है या स्कूल का बच्चा है या माँ है, दे आर नॉट बॉदर्ड एट ऑल। यहाँ इस तरह की ह्यूमैनिटी का लेवल पहुँच गया है। दिस आई से, जैसे उसने कहा था अपने आई थिंक स्टालिन सेड कि रिलीजन इज़ ए ओपियम ऑफ मासेस। एक बहम, एक नशा है। लेकिन प्रॉब्लम ये हुई है दुनिया में, जो मेरी बड़ी डिसअपॉइंटमेंट हुई है, कि पढ़ने के एजुकेशन के बाद कोई लोगों में फ़र्क नहीं पड़ा, कोई फ़र्क नहीं पड़ा। मतलब इफ़ आई स्टार्ट माई कैरियर फ्रॉम माई विलेज, जहाँ ऑलमोस्ट 99% लोग अनपढ़ थे, स्कूल नहीं गए थे। नाउ आई लिव इन ए सोसाइटी वेयर एवरीबॉडी सो कॉल्ड एजुकेटेड, लेकिन उनमें ये रैशनलिटी नहीं है, उनमें ये धर्म का जहर सब में है। एंड आई डोंट नो वाई, अब भी डॉक्टर आते हैं कई बार हमारे जो टी रूम होता है, जय श्री राम, आई एम नॉट अगेंस्ट जय श्री राम, but at the same time a doctor who knows that the heart, the blood, the kidney of a Muslim, Hindu, Sikh or is same. We don't see any difference, but people do. People, they are willing to criticize each other and blah blah things of that nature. So, you know, that's the place where I think education has not been able to lift the spiritual component of mankind. ये दुख की बात है। मैं बड़े प्रोफेसर देखे हैं बेवकूफ़ एक नंबर के, और मैं सारी दुनिया को, सारे बंदों को 4 हिस्सों में डिवाइड करता हूँ। एक ग्रुप है अनएजुकेटेड। अनएजुकेटेड मीन्स कि कभी स्कूल नहीं गए बेचारे हो, लेकिन वैसे भी बेवकूफ़ हैं, उनको कोई अकल नहीं। दूसरे हैं अनएजुकेटेड एजुकेटेड, स्कूल नहीं गए पर उनको इंसानियत बारे पता है। अब बाबा नानक पर स्कूल नहीं गया, अब पिंडां जाओ तुसी बुढ़ियां मिलदियां बड़ी अकल दी गल्लां करदियां, वो अरे स्कूल नहीं गईयां, बट दे आर अनएजुकेटेड बट एजुकेटेड। देन देयर इज थर्ड क्लास विच इज़ इंक्रीजिंग डे बाई डे, वो है एजुकेटेड अनएजुकेटेड। ये क्लास बड़ी खतरनाक है, ये बड़ी मिलती है मैनू, हरेक तो मिलती है। MA कर ची, PSC कर ली, डॉक्टर बन गए, पर हैं उल्लू के चरखी, वो वहीं के वहीं हैं। वहीं के वहीं हैं। The last class which I want all of us to be educated। भी आपके पास ट्रेडिशनल एजुकेशन भी है, लेकिन आपको इंसानियत के बारे में पता है। सो दैट शुड बी आवर गोल एंड दैट इज़ व्हाट वी शुड टीच आवर चिल्ड्रन। अब धर्म के बारे में कहता हूँ कि मैंने अपने बच्चों को कभी ये नहीं कहा कि आप गुरुद्वारे जाओ, मंदिर जाओ, क्योंकि मैं खुद नहीं जाता। हाँ, देखने के लिए हर जगह गया हूँ। तो अगर आप सेकुलर हो, या तो अपने बच्चों को कहो कि बेटा इस हफ्ते आप मंदिर जाओ, अगले हफ्ते गुरुद्वारे जाओ, फिर तीसरा मॉस्क चले जाओ, फिर तुम भाई चर्च चले जाओ, ठीक है, दैट्स ए ट्रू सेकुलर मैन। या कहो कितने जाने की लोड़ नहीं, जो मैं कहना भी थोड़ी मर्जी है, इट्स नॉट माई कप ऑफ टी, जो आपका ब्रेन कहता हो वो करो। सो आई हैव नॉट सीन बाई द वे ट्रू सेकुलर मैन सो फार इन माई लाइफ, आई हैव नॉट सीन, क्योंकि मैंने कोई ऐसा आदमी नहीं देखा जो कि अपने बच्चों को एनकरेज करे कि दूसरे रिलीजन को फॉलो करो, मैंने नहीं देखा। एटलीस्ट यू मे हैव सीन दैट। सो आई हैव मेड 13 डिक्टेट्स हाउ टू लिव ए हैप्पी एंड हेल्दी लाइफ। उसको मैं कहता हूँ बाबा कलेज 13 हिंट्स फॉर हैप्पीनेस एंड हेल्थ। वो बाबा कलेज इसलिए कहना पड़ रहा है कि हिंदुस्तान के लोग ना किसी पढ़े लिखे वो नहीं मानते, बाबे के पिछे जाते हैं। तो हुण प्रॉब्लम मेरी एको है, वो भगवे कपड़े पाने पैने मैनू, नहीं तो किसी सुनता नहीं कोई बंदा, ठीक है। So what are those 13 points? I want you to listen to that. So I'm sorry I'm taking your time. सबसे बड़ा दुश्मन इंसान का, सबसे बड़ा दुश्मन फियर है, डर। फियर ऑफ डेथ, फियर ऑफ डिजीज, फियर ऑफ अभी असी नीचे ना चले जाइए जिंदगी च, पहले तो साढ़े बहुत कमाई सी, हुण घट गए, लोग की कहणगे, यू नो, बला बला बला। मैं लोगों को कहना कि यार फियर ऑफ डेथ इज़ नॉट जस्टिफाइड एट ऑल। वाई? बिकॉज मौत है वो एक दिन आपकी लिखी हुई है, आपका डे भी फिक्स्ड है, टाइम भी फिक्स्ड है, शहर भी फिक्स है। जे मेरी थे मैं मरना बठिंडे, मैं बठिंडे आके मरूंगा, चाहे मैं दिल्ली रहना है। और जो चीज़ होनी है, जो चीज़ 100% होनी है, उसको आने दो। सो मैं कहता हूँ लोगों को भी डाई ग्रेसफुली वंस इन लाइफ, वन डे, डोंट डाई डेली। हिंदुस्तान के लोग क्या हैं, बहुत, टू माई माइंड दे आर लिविंग डेड, दे आर लिविंग बट दे आर डेड पीपल, बिकॉज उनके दिल में इतना फियर, इतना गुस्सा भरा हुआ है जहाँ वो लाइफ का कोई फ़ायदा नहीं। हाँ, फियर ऑफ डिजीज़ इज़ मोर जस्टिफाइड कि यार मैं लंगड़ा लुलना ना हो जाऊँ, पैरालिसिस ना हो जाए, हार्ट अटैक ना हो जाए। वो लिए की कर सकते हैं आप? वी शुड फॉलो हेल्दी लाइफ स्टाइल, सिंपल। वी शुड हैव एनुअल चेकअप भी कराओ। अगर डॉक्टर के पास जाते हो, उसके विश्वास करो, उसकी बात मानो, इससे ज़्यादा कुछ नहीं कर सकते, isn't it? सो फियर जो है इंसान का बहुत सबसे बड़ी ख़तरनाक चीज़ है. एंड बिलीव मी, एटलीस्ट आई हैव बीन एबल टू मेक माई माइंड टोटली फियरलेस, इफ़ नॉट 100%, आई विल से 98%. तो डरता हूँ, अपनी वाइफ से थोड़ा डरता हूँ. बाकी मैं मतलब मैं परमात्मा तो नहीं डरता. आई डोंट केयर हु इज़ गॉड, आई डोंट केयर हु इज़ मोदी एंड हु इज़ भगवंत मान. मेरे को कर लेंगे साले, ਵੱਧ ਤੋਂ ਵੱਧ ਮਾਰ ਦੇਣਗੇ, मैं मर ਲਈ ਤਿਆਰ है. ठीक है, ਜਿਹੜਾ ਬੰਦਾ ਮਰ ਲਈ ਤਿਆਰ ਹੈ, ਜਿਹੜਾ ਬੰਦਾ ਨੰਗਾ ਹੈ ਵੀ ਮੈਂ ਤਾਂ ਜੋ ਕਰਨਾ ਕਰ ਲਓ ਭਾਈ, ਠੀਕ ਹੈ, ਉਹਨੂੰ ਉਹਦਾ ਕੁਝ ਨਹੀਂ ਤੋੜ ਸਕਦਾ ਆਦਮੀ. ਠੀਕ, ਮੈਂ ਬਾਈ ਦੀ ਵੇ ਨੌਰੀਆ ਸਾਹਿਬ ਦਿੱਲੀ 'ਚ ਮੈਂ ਇਨਕਮ ਟੈਕਸ ਕਮਿਸ਼ਨ ਨੂੰ ਮੈਂ ਆਪਣੇ ਕਮਰੇ 'ਚੋਂ ਧੱਕੇ ਮਾਰ ਕੇ ਬਾਹਰ ਕੱਢਤਾ. तो ही वॉज ट्राइंग टू शो ऑफ. तो मैं तो दफ़ा हो जा, गेट आउट फ्रॉम दिस प्लेस. मैं तू कर ला जो कुछ करना है. मैं तू मैनू पता है तू मेरे खिलाफ झूठा केस पा सकता है, तेरी च पावर है. देखो ये तंग कर सकते ने. मैं ਵੱਧ ਤੋਂ ਵੱਧ ਮੈਨੂੰ जेल हो जू. मैं स्टैथोस्कोप लेके जाऊँगा, उत्थे मरीजों को देखा, गवर्नमेंट फ्री रोटी दूगी. मैं तू जा दफ़ा हो जा. एनी वे ही अपोलोजाइज, वो बंदा बन गया. उसके बाद सो फियर अगेन आई वांट टू चल फियर दिमाग चो निकाल दो. दूसरी चीज़ जी है, सब तो जी जरूरी चीज़ है कि ईगो इंसान की घट होनी चाहिए. जिन्नी भी तुम घटा लो चंगी गल. ईगो जिमें मैं कहा यार मैं डॉक्टर क्लीयर, मैं पद्मा भूषण, मैं फलाना, मैं तिमका, ये बिटल खड़ा नहीं हुआ जब मैं आया, इन्हें तो जब कुछ गल मेरी मैंने कुछ समझ ही नहीं. दिस इज़ ईगो. ईगो इंसान को मारती है. और जे मैं कोई बंदा देखा मोडेस्टी वाला, जो मेरा गुरु है इन मोडेस्टी, दैट वाज डॉक्टर मनमोहन सिंह. क्योंकि आई वॉज वेरी क्लोजली एसोसीएट. मैंने उसका इलाज किया एंड आई न्यू दी फैमिली वेरी वैल. इन्नी मोडेस्टी मतलब कि इंसान सीगी कि भी जिन्ने बारी भी असीं उहदे घर गए या मैं गया, दे विल ऑलवेज रिसीव यू, चाहे पानी जो भी है. उसके बाद दे विल ड्रॉप यू टू दी कार. जब तक नहीं जाते सी जब तक थोड़ी कार चल नहीं जाती. मतलब आई यूज टू फील माई सैल्फ एम्बेरस्ड कि इन्ना बड़ा आदमी प्राइम मिनिस्टर ऑफ इंडिया, सो ही इज़ माई आइडियल इन मोडेस्टी. माई आइडियल इन ग्रिट इंसान की होनी चाहिए. दैट इज़ फौजा सिंह. फौजा सिंह की पिक्चर मैं घर रखी हुई है अपने कि यार बंदे च अगर डिटर्मीनेशन हो कुछ भी कर सकता. अब दिस मैन 88 ईयर्स से उन्हें शुरू किया दौड़ना एंड ही बिकेम द वर्ल्ड फिगर. Not only he highlighted an Indian being such a grateful man, बल्कि if you think in a shorter sense, मतलब कि सारी दुनिया चो ने सिखिज्म नूं इंपॉर्टेंस दी कि बंदा पगड़ बन के दाढ़ी रख के दौड़ रहा. अपने ही बिकेम ए लीजेंड. खैर असी हिंदुस्तान वाले ने तो कसर नहीं छड्डी कि वो अपने पिंड आया सी. हुण रीसेंटली वो किसी ने साइकिल सूकल पता नहीं किने मार के मारता उन्होंने. असी तो यही कंट्रीब्यूट कर सकते हैं. ठीक है, वो कहानी असी ख़त्म करती. सो ईगो इज़ ए बैड थिंग एंड आई थिंक वी शुड डू वट एवर डिक्रीज वी कैन डू. नाउ थर्ड थिंग विच बॉदर्स एंड मेक्स आर अनहैप्पी इज एक्सपैक्टेशंस. हर जगह अपने रिलेशनस, अपने दोस्तों से, अपने लोगों तो जिन्नी आप एक्सपैक्टेशन करांगे उन्ना दुखी होवांगे. क्योंकि वट इज़ फ्रस्ट्रेशन? फ्रस्ट्रेशन इज़ एक्सपैक्टेशन माइनस वट यू गेट इन लाइफ. थोनों रियली मिलता की है, वो जिन्ना ज़्यादा गैप होएगा ज़्यादा दुखी होगे. सो एको तरीका है कि मिलना तो लिमिटेड ही है. देखो सीधी गल है, अपनी एक्सपैक्टेशन लो कर लो. आ मैं वेरी छोटी छोटी गल्लां हुंदियां ने कि मेरे बेटे ने फ़ोन नहीं किया, मैनू बहू मेरी पुछ के नहीं गई कित्थे गई. बई जानते जिथे आती है थोनों पुछण की लोड़ है. यू नो these are unnecessary headaches. Why we want to take those headaches? ठीक है यार, leave them alone. वो प्रॉब्लम साड़ी पता की होंगी है कि जब तक इंसान मी एंड माई तो बाहर नहीं आता, असी बंदे नहीं बन सकते. मी, मैं, माई सन. भाई माई सन क्या है भाई? ठीक है, वो एक सेपरेट इंसान है ना. वो माई सन तो उदे तक किया जब तक बच्चा है, जब तक उन्होंने अपना नहीं पता सब कुछ. When he is become adult, he is adult, he has his own thinking, his own brain. I don't have ownership. साड़ी ओनरशिप नहीं है ना. असी ओनरशिप दिखाने हैं. मेरी वाइफ है, मतलब मेरी वो गुलाम थोड़ा है यार भैया, और भी अपना दिमाग है. सो मैं कदे ये नहीं कहता जब मैं मेरी वाइफ नाल होंदी है, आई डोंट इंट्रोड्यूस दैट शी इज़ माई वाइफ. आई इंट्रोड्यूस दैट दिस इज़ डॉक्टर नीलम, शी इज़ ए न्यूरोलॉजिस्ट She happens to be my wife. No, believe me. Yeah, no, it's fortunate. She's a great lady. She's a lady of substance. So I am very lucky. अब ब्राह्मण है, मैं तो ज़्यादा अकल है, मैं जाट आदमी है, ठीक है ना. सो ओनरशिप छड़ दो अपनी, ठीक है. मैं कदे ये भी नहीं कहता ये मेरी कार है, मैं कहना ये कार मैंने बाबे नानक ने दी है, यूज़ कर ली. जे मन ओदा हुक्म हो गया ना, 1 सेकंड ये खत्म हो जाएगी. साडा कुछ नहीं जिंदगी च. वी हैव टू अंडरस्टैंड कि साडा जिंदगी च कुछ नहीं है. इट इज़ ऑल ए वेरी ट्रांजिटरी, वेरी वेरी टाइमली थिंग विच यू हैव. देखो ना, जहाज उड्या अहमदाबाद से 3 मिनट की होल थिंग इज़ ओवर. तो सानू नैक्सट घड़ी का पता नहीं. असी लंबी लंबी स्कीम है, मैं ये कर दूंगा, मैं फलाना कर दूंगा, धिमका कर दूंगा. सो वी हैव टू अंडरस्टैंड दैट लाइफ इज़ ए ट्रांजिटरी एंड डोंट वेस्ट इट अननैसेसरली. वर्क इज़ वर्शिप. जिहड़ा काम तुसीं करना बिल्कुल ठीक करो. तुसीं डॉक्टरां दा अपनी अच्छी तरह करो. कोई भी काम है वर्क. बाबे नानक ने भी यही कहा है कि जी 3 गल्लां बाबे नानक ने कही हैं कि जी मतलब कि काम हाथ तुहानूं दित्ते हैं, वंड के छको, कोई सारा माल आप ही ना खा लो, किसी गरीबां नूं भी दो. नाम जपो. तो नाम जपो का मतलब ये नहीं सी कि गुरुद्वारे जाओ. ये लोग बड़ा गलत कंसैप्ट है. नाम जपे का मतलब है कि रिमेंबर योर क्रिएटर, कि जिस इस क्रिएटर ब्रह्मांड ने पैदा किया आपको, उसको याद करो. बिकॉज इट मेक्स यू मोर हम्बल. गोइंग टू गुरुद्वारा इज नॉट ए नाम छकना बाई दी. बड़े लोग हैं, मैं देखा है, रोज़ गुरुद्वारे जाते हैं, रोज़ मंदिर जा, सारा दिन झूठ बोलते हैं. सारा दिन एक लेके मंदिर हथ टेकिया टन खड़ाई, वो बाद सारा झूठ शुरू हो जाता है. और दिस डुप्लीकेसी, हिपोक्रेसी, और क्या. सो मैं मेरे को बंदा जी आप नहीं जानते गुरुद्वारे. मैं जी मेरे तो कैपेबिलिटी नहीं है, मैं ना ईमानदार है नहीं कि गुरुद्वारे जाने के लायक होवां. तां ही जा सकता मैं बाबे नानक के सामने जाकर मैं ठीक है, मैं ठीक ही नहीं है, मैं क्यों जाऊँ. आई कांट गो. डेली एक्सरसाइज, योगा, मैडिटेशन, मेक इट ए पैशन ऑफ लाइफ. मतलब कि ये तुहानूं नशा चाहिए. जिवें ओपीएम का एडिक्ट होंदा ना बंदा, यू शुड बी, इफ यू हैव टू गेट एडिक्शन इन लाइफ, गेट एडिक्टेड टू एक्सरसाइज. और थोड़ी बहुत हो जाती है. मैं अज सब तो पहला उठ के रोज़ गार्डन गया थोड़े बठिंडे, बड़ा अच्छा हो गया पहला तो. सो आई हैव ऑलरेडी वॉकड 8000 9000 स्टैप करके आए बाई दी वे. मैंने लभ रहा सी बिटल नहीं सीगा उत्थे बाई दी. ठीक है जी. यू शुड हैव ए प्रिंसीपल दैट ऑलवेज कीप ए एटीट्यूड टू हैल्प अदर्स. जिथे मर्जी, चाहे तुम कितने अमरीका अफ्रीका फलाना धिमका, अगर थोड़ी पॉलिसी है कि हेल्प करनी है, और हेल्प करने थोड़ा पैसे की जरूरत नहीं होंगी. इट्स ए एटीट्यूड. अब कोई बंदा डिगया, उन्होंने भी हाथ खिदे के चलो यार कोई नहीं, खड़ा हो जा, खड़ा, तेन छड़ता नहीं लगी. इट्स ए एटीट्यूड. दी अनदर थिंग विच आई ऑलवेज टेल टू माई सेल्फ एंड आई वांट एवरीबॉडी एल्स टू अज्यूम, कि तुम अपने आप अज्यूम कर लो कि मैंने वाहिगुरू ने, बाबा नानक ने, या राम ने, या कृष्ण ने, जो भी आपका गुरु है, कि मेरे को इस दुनिया में देने के लिए भेजा है, मेरे को लेने के लिए नहीं भेजा. अगर आपको ये कंसेप्ट हो जाएगा, फॉर एग्ज़ाम्पल अगर ये कंसेप्ट हो जाएगा, तो मैं अपनी बहन से, अपनी वाइफ से, अपने रिलेशन, ये उन्होंने मेरे को दिया नहीं, वो दुख नहीं होएगा. फिर मैं तो कहूँगा मैं तो देने के लिए, मैं लेने के लिए है ही नहीं. सो वो कहते हैं जैसे जी हैंड शुड बी लाइक दिस, इट शुड नॉट बी लाइक दिस. तो अगर वो बना लोगे, आपको सुख होगा, दुखी नहीं, आपको सुख होगा. वी आर नाउ रीचिंग दी, ज़्यादा तंग नहीं करूँगा मैं, फिक्र ना करो. हाँ जी, राइट. नहीं, 7वां हो गया, दैट assume that you are sent by God to give others, not to take. 8वां पॉइंट ये है जी कि जदों भी जिंदगी टाइम मिलता है, फ्री मस्ती करो, इंजॉय टू दी. फिर भुल जाओ की काम करना, फलाना काम करना. फिर जो भी थोड़ा खुशी दिंदा है, डांस करो, दारू पियो, फलाना करो, डोंट वरी. नो देखो मैं कहना, अगर थोनू दोस्तों नाल दारू पी के खुशी होंदी है, क्यों नहीं. मैं तो इत्थे तक जाना है कहने लई कि इफ इट रियली गिव्स यू मैंटल पीस एंड हैप्पीनैस, जे थोड़े 5 साल जिंदगी घट भी है तो घटन दे की फर्क है. देखो बई, एक है कि तुम बंदा दारू नहीं पींदा, वो बहुत डिसिपलिनड है, ठीक है, ਉਹ ਕੋਈ ਗਲਤ ਕੰਮ ਨਹੀਂ ਕਰਦਾ, ਸਾਰਾ ਦਿਨ ਦੁਖੀ ਰਹਿੰਦਾ, ਚਿੜਿਆ ਰਹਿੰਦਾ ਹੈ, ਠੀਕ ਹੈ। ਉਹ ਰਹਿੰਦਾ 100 ਸਾਲ, ਠੀਕ ਹੈ। ਦੂਸਰਾ ਬੰਦਾ ਮੇਰੇ ਤਰ੍ਹਾਂ ਕਿ ਮਸਤੀ ਕਰਨੀ ਹੈ ਮਸਤੀ ਕਰਨੀ ਹੈ, ਦਾਰੂ ਵੀ ਪੀਣੀ ਹੈ, ਦੋਸਤਾਂ ਨਾਲ ਵੀ ਗੱਪਾਂ ਛੱਪਾਂ ਮਾਰਨੀਆਂ। ਭਾਈ ਮੈਂ 95 ਤੇ ਮਰ ਗਿਆ, ਜਦ 10 ਸਾਲ ਪਹਿਲਾਂ ਮਰ ਗਿਆ, ਕੀ ਫਾਇਦਾ। ਸੋ ਇਟ ਇਜ਼ ਨਾਟ a question of longevity of years, the question of how much happy, no। ਮੈਂ ਤੁਹਾਨੂੰ ਦੱਸਦਾ ਕਿ ਜੇ ਮੈਨੂੰ ਪੁੱਛੇ ਕਿ what is the yardstick of a happy life, successful life, sorry, yardstick of a successful life, yardstick of successful life is not कि how much money, how many properties, how many फलाना तिमका कीता है, कि मरन तो पहला बंदे की इंटरव्यू लत्ती जाए कि तू दस भाई तेरी जिंदगी तू किन्ने घंटे खुश रहे हैं, किन्ने घंटे तेन आत्मा तेरी कहती भी हाँ जी मैं खुश, अंदरों खुशी किन्ने। हाँ, अगर उस दिन थोड़ी आत्मा कहती है कि मैं खुश हैं, दैट्स ए सक्सेसफुल लाइफ। और एक आस्ट्रेलियन नर्स ने बड़ी अच्छी स्टडी करी, ਉਹਦੀ ਡਿਊਟੀ ਲੱਗ ਗਈ ਐਂਡ ਕੇਅਰ ਵਾਰਡ ਵਿੱਚ। ਉਹ ਸਾਰੇ ਬਾਬੇ ਹੁੰਦੇ ਸੀ ਮੇਰੀ ਤਰ੍ਹਾਂ, ਕੋਈ 80 ਸਾਲ ਦਾ, ਕੋਈ 90 ਸਾਲ ਦਾ, ਮਤਲਬ ਕਿ ਐਂਡ ਸਟੇਜ ਡਿਜ਼ੀਜ਼ ਹੁੰਦੀ ਸੀ। ਉਹਨਾਂ ਤੋਂ ਉਹਨੇ ਪਰਫਾਰਮਾ ਬਣਾ ਲਿਆ ਛੋਟਾ ਜਿਹਾ, ਪੁੱਛਣ ਲੱਗ ਗਈ ਵੀ ਤੁਹਾਡੀ ਜ਼ਿੰਦਗੀ ਦੀ ਅਚੀਵਮੈਂਟ ਕੀ ਹੈ, ਤੁਹਾਨੂੰ ਰਿਗਰੈਟ ਕੀ ਨੇ, ਅਤੇ ਫਲਾਣਾ ਤਿਮਕਾ। ਅਤੇ ਉਹਨੇ ਸਟੱਡੀ 'ਚ ਇਹ ਆਇਆ ਕਿ ਕਿਸੇ ਬੰਦੇ ਨੇ ਇਹ ਨਹੀਂ ਕਿਹਾ ਕਿ ਮੈਂ ਪੈਸੇ ਨਹੀਂ ਕਮਾਏ ਜਾਂ ਮੈਂ ਇੰਨੀ ਪ੍ਰੋਪਰਟੀ ਬਣਾ ਨਹੀਂ ਸਕਿਆ। ਸਾਰੇ ਬੰਦੇ ਨੇ ਇਹੀ ਕਿਹਾ कि मैं अपने दोस्तों को टाइम नहीं दिता, मैं अपना खुश नहीं होया, या मैं अपनी बच्चों को टाइम नहीं दिता। ऑल वर पीपल, नो बडी स्पोक ऑफ दोज थिंग्स विच वी आर ट्राइंग टू। सो अगर आप मरन तो पहले उन्होंने एहसास कर लीए, फिर शायद सानू रिगरैट नहीं होएगा। हुण मेरा प्रिंसीपल की है कि मैं बिलीव मी, हुण जो मैं बठिंडे आया, मेरी बठिंडे च लिस्ट है मेरे यारों दोस्तों की, मैं उन्होंने पहले फ़ोन करदा मैं आ रहा भाई मिलते हैं, ठीक है। मैं इत्थे मिलना आया, मैं कोई लैक्चर देने नहीं आया भाई, बिलीव मी। नहीं मैं तो अज मैं गया रोज़ गार्डन, रोज़ गार्डन सीगा, तो मैंने फ़ोन आता एक कि सर आप कहाँ हो। मैंने कहा आप कौन। मैं जी ड्राइवर बोल रहा हूँ। मैं कहाँ, मैं वाराणसी एयरपोर्ट के बाहर वो शायद ऑर्गेनाइज़र भूल के बताना, तो मेरे को लेने आया था। मैं यार बठिंडे आ जा, मेरे को लेना है ठीक है। सो आई एम इन बठिंडा जस्ट टू मीट माई फ्रेंड, दिस इज़ माई फूड माई सोल फूड है कि अपने दोस्तों यारों से मिल लो। क्यों पता कल का की पता पाया कि कहानियाँ ख़त्म हो जाए, ठीक है जी। सो नाउ वी आर रीच दी हाँ 8th पॉइंट पर पहुँच गए। 9th, स्लीप 7 आवर्स ए डे। ये ज़रूरी है क्योंकि स्लीप जो है, जो बॉडी की रेजुमिनेशन नींद में होती है, माइंड एंड बॉडी की, वो कोई नहीं कर सकता। और आज की घड़ी में 1/3 ऑफ द पॉपुलेशन इन द वर्ल्ड इज़ नॉट एबल टू स्लीप प्रॉपरली। और उसका रीज़न भी क्या है, वो ये लाइफस्टाइल, एक्सरसाइज नहीं करते, रात को लेट खाते हैं एंड दुखी रहते हैं, तो नींद कैसे आएगी। सो नींद बहुत इंपॉर्टेंट है, और वो भी गुड क्वालिटी नींद। जो नींद है 2 तरह की होती है, REM एंड नॉन REM, रैपिड आई मूवमेंट। सो जो नॉन REM है, जिसमें कि आई मूवमेंट नहीं होती, दैट इज़ रियली रिलैक्सेशन स्लीप। जितना कंपोनेंट वो ज़्यादा हो गया। अगर स्लीप स्टडी कराओ ना, वो बता देते हैं आपको कि नॉन REM कितनी थी और REM में कितनी थी। जिसकी ज़्यादा नॉन REM है, अगर नॉन REM में आपको 2 घंटे भी मिल गई, यू विल बी रिलैक्स। बाकी जो स्लीप है, जो कच्ची स्लीप जिसको बोलते हैं, उसमें रिलैक्सेशन कम मिलती है। सो दिस इज़ ए पॉइंट 7। सो आई थिंक वी हैव रीच्ड 9th पॉइंट। 10th पॉइंट ये है कि ऑलवेज कीप ए पॉजिटिव एटीट्यूड। कई चीज़ें मुश्किल हैं करनी, पर अगर आप करो तो हो सकती हैं। जैसे फॉर एग्जांपल आप गिर गए, सट लगी, हड्डी टूट गई, फिबला टूट गई, वो 2 एटीट्यूड होता है। एक तो मैं दुखी हूँ यार, मैं 15-20 दिन महीना नहीं जा सकता काम से, मैं बैठ के रहूँ। दूसरा मैं वाहगुरू का शुक्र करूँ यार, मेरा ब्रेन तो बच गया, ठीक है, वधिया, कोई गल नहीं, बैठांगे पिक्चर देख लाँगे कोई जी देखी नहीं जा रही जिंदगी। सो इट्स ए क्वेश्चन ऑफ द वे यू लुक एट। वो कहते हैं जी हाफ ग्लास फुल और हाफ ग्लास एम्प्टी। नहीं पता सारिਆਂ ਨੂੰ ਸਾਨੂੰ ਗੱਲਾਂ ਦਾ, पर ਅਸੀਂ प्रैक्टिकली नहीं करते। प्रैक्टिकली करने की लोड़ हैगी है। सो दैट इज़ अनदर थिंग। इन मनी, एक 11वां नंबर है, इन मनी एंड एसेट्स ऑलवेज कंपेयर विद ए पर्सन हु इज़ लेस दैन यू। ठीक है कि भाई मेरे को एवरीथिंग इज रिलेटिव। देखो जे मैं हुण कंपेयर करा अपने आप नूं, मेरा भरा इत्थे समराले प्रोफैसर पढ़ाਉਂਦਾ, वो प्रोफैसर है, प्रोफैसर की बेचारे की किन्नी तनख्वाह होंदी है, ਉਹਦੇ ਕੋਲ मेरे को पैसे घट हैं, मेरे को ज़्यादा है। अगर मैं ਉਹਦੇ ਨਾਲ कंपेयर करा, मैं बड़ा खुश हाँ, मैं तो बड़ा अमीर है, ਜਦੋਂ ਮੇਰੇ ਕਾਲਰ ਉੱਪਰ, ਹੁਣ ਮੈਂ ਕੰਪੇਅਰ ਕਰਾਂ ਆਪਣਾ ਕਿਸੇ ਪੋਲੀਟੀਸ਼ੀਅਨ ਨਾਲ ਜਾਂ ਬਿਲ ਗੇਟ ਨਾਲ, ਫਿਰ ਤਾਂ ਮੈਂ ਕੁਛ ਵੀ ਨਹੀਂ, ਫਿਰ ਤਾਂ ਮੈਂ ਜ਼ੀਰੋ ਹੈ। ਸੋ ਇਟਸ ਏ ਕੰਪੈਰੀਜ਼ਨ। ਦੇਖੋ ਮੈਂ ਕਹਿੰਦਾ ਕਿ ਪੈਸਾ ਜਿਹੜਾ ਮਾਮਲੇ 'ਚ ਕੀ ਹੈ ਕਿ ਆਈ ਡਰਾਈ 2 ਲਾਈਨਸ, ਇਹ ਜ਼ੀਰੋ ਹੈ, A ਪੁਆਇੰਟ, ਇਹ B ਪੁਆਇੰਟ। A ਪੁਆਇੰਟ ਤੋਂ ਥੱਲੇ ਸਬਸਟੀਟੈਂਸ ਇਜ਼ ਡਿਫੀਕਲਟ, ਮਤਲਬ ਕਿ ਖਾਣਾ ਪੀਣਾ, ਬੱਚਿਆਂ ਦੀ ਪੜ੍ਹਾਈ ਮੁਸ਼ਕਿਲ ਹੈ। ਉੱਥੇ ਤੱਕ ਤਾਂ ਅਸੀਂ ਪਹੁੰਚਣਾ। ਐਵਰੀਬਾਡੀ ਸ਼ੁੱਡ ਅਰਨ ਦੈਟ ਮਚੀ। ਫਿਰ ਪੁਆਇੰਟ ਆਉਂਦਾ B, ਠੀਕ ਹੈ, ਕਿ ਵੀ ਤੁਹਾਡੇ ਕੋਲ ਸਭ ਕੁਛ ਹੈ, ਤੁਸੀਂ ਵਕੇਸ਼ਨ 'ਤੇ ਵੀ ਜਾ ਸਕਦੇ ਹੋ, ਇਹ ਵੀ ਜਾ ਸਕਦੇ ਹੋ। ਫਿਰ ਜਦ B ਤੋਂ ਉੱਪਰ ਹੈ, ਉਹ ਪੈਸਾ ਫਿਰ ਬੈਂਕ ਅਕਾਊਂਟ ਹੀ ਹੈ, ਹੋਰ ਕੋਈ ਨਹੀਂ। ਹੁਣ ਜਿਹੜੇ ਫਾਰ ਐਗਜ਼ਾਮਪਲ ਬਿਲ ਗੇਟ ਨੂੰ ਕੀ ਫਰਕ ਪੈਂਦਾ ਹੈ, ਜਦੋਂ ਚਾਹੇ ਇੱਕ ਦਿਨ 'ਚ 2 ਮਿਲੀਅਨ ਦਾ, ਮਤਲਬ ਕਿ 50 ਮਿਲੀਅਨ ਲੂਜ਼ ਵੀ ਹੋ ਜਾਂਦਾ, ਫਾਇਦਾ ਵੀ ਹੋ ਜਾਂਦਾ ਹੈ। ਸੋ ਯੂ ਸ਼ੁੱਡ ਰਿਮੇਨ ਇਨ ਇਸ ਬ੍ਰੈਕਟ ਬਿਟਵੀਨ A and B. Or there is nothing, I don't advise people not to earn money. I think you should earn money as much as possible, but not at the cost of health and happiness. ये underline है कि जितने मर्जी पैसे कमाओ अच्छी बात है, but not at the cost of your health and happiness, in the right way. क्यों? पैसा बहुत ज़रूरी है। देखो तो प्रैक्टिकल गल है, पैसे बिना कुछ नहीं चलता। जे मेरे को 4 पैसे मैं किसी की हेल्प कर सकते हैं, ठीक है, जे मैं ही नंग है तो की दूँगा। It's a simple story. So earning money is a good idea, but in the right way. ਹੁਣ ਜਿਹੜੇ ਇੱਥੇ ਰੋਜ਼ ਧੱਕੇ ਖਾਣੇ ਮੈਂ ਦੇਖਿਆ, ਮਲਟੀਨੈਸ਼ਨਲ ਕੰਪਨੀ, ਨਾ ਸਾਡੇ ਸੌਂਦੇ ਆ ਨਾ ਪੀਂਦੇ ਆ, ਮੈਨੂੰ ਟੈਨਸ਼ਨ ਹੋ ਗਈ, ਫਿਰ BP ਹੋ ਰਿਹਾ ਹੈ, ਫਿਰ ਪੈਲਪੀਟੇਸ਼ਨ ਹੋ ਰਹੀ ਹੈ, ਉਹਦਾ ਕੋਈ ਫਾਇਦਾ ਨਹੀਂ। ਦਿਸ ਇਜ਼ ਯੂਜ਼ਲੈਸ। ਸੋ ਦੈਟ ਮੀਨ ਦੈਟਸ ਏ ਨੰਬਰ 11. ਨਾਓ ਵੀ ਗੋ ਟੂ ਨੰਬਰ 12. ਨੰਬਰ 12 ਹੈ ਕਿ ਜਦੋਂ ਤੁਹਾਡੇ ਤੋਂ ਗਲਤੀ ਹੁੰਦੀ ਹੈ, whenever you are wrong, learn sincerely to feel sorry in life. ਚਾਹੇ ਚੌਕੀਦਾਰ ਹੋਵੇ, ਚਾਹੇ ਕੋਈ ਲੋਐਸਟ ਮੋਸਟ ਰੰਗ, ਚਾਹੇ ਰਿਕਸ਼ਾ ਵਾਲਾ ਹੋਵੇ, ਅਗਰ ਥੋੜੀ ਗਲਤੀ ਹੈ ਆਪਣੇ ਦਿਲੋਂ ਕਹਿ ਪਾਈ ਮੈਂ ਸੌਰੀ, ਮੈਂ ਗੁੱਸੇ 'ਚ ਕਹਿ ਗਿਆ ਪਰ ਗਲਤੀ ਹੈ। ਐਟ ਦੀ ਸੇਮ ਟਾਈਮ ਜੇ ਤੁਹਾਤੋਂ ਕੋਈ ਸੌਰੀ ਕਹਿੰਦਾ, ਤੁਹਾਡਾ ਬੇਟਾ ਜਾਂ ਸਕੂਲ ਜਾਂ ਕੋਈ ਵੀ ਹੈ, ਤੁਹਾਡਾ EMPLOYE, ਆ ਤੁਹਾਨੂੰ ਲੱਗਦਾ ਸਿੰਸੀਅਰਲੀ ਸੌਰੀ, ਉਹਨੂੰ ਫਿਰ ਉਹਨੂੰ ਮਾफ़ ਕਰ ਦਿਓ। ਫਿਰ ਆਪਣੇ ਇਹ 'ਚ ਕਚਰਾ ਨਾ ਰੱਖੋ, ਉਹਨੂੰ ਕੱਢ ਦਿਓ। ਮਤਲਬ ਦਿਸ ਸ਼ੁੱਡ ਬੀ ਲਾਈਕ, ਜੇ ਬਟਨ ਹੁੰਦਾ ਨਾ ਆਪਣਾ ਡਿਲੀਟ ਕੰਪਿਊਟਰ 'ਚ, ਉਹ ਡਿਲੀਟ ਕਰਦੇ ਫਿਰ ਉਹ ਇਨਫੋਰਮੇਸ਼ਨ ਚਲੇ ਜਾਂਦੀ ਹੈ। ਹਿੰਦੂ ਆਦਮੀਆਂ ਦੀ ਪ੍ਰੋਬਲਮ ਪਤਾ ਕਿ ਇਹ ਕੰਪਿਊਟਰ ਬੜਾ ਖਤਰਨਾਕ ਹੈ, ਇਹ ਕੰਪਿਊਟਰ ਕੱਢਦਾ ਨਹੀਂ ਗੱਲਾਂ ਨੂੰ, ਉਹੀ ਫਿਰ ਯਾਦ ਆ ਜਾਂਦੀਆਂ। ਉਹ ਫਲਾਣੇ ਨੇ ਮੈਨੂੰ ਫਲਾਣੀ ਜਗ੍ਹਾ ਇਹ ਕੀਤਾ ਜੀ, ਉਹਨੇ ਤਾਂ ਜੀ ਫਲਾਣਾ ਕੀਤਾ ਸੀ। ਇਹ ਬੜਾ ਮੁਸ਼ਕਿਲ ਹੈ, ਆਸਾਨ ਨਹੀਂ ਹੈ, ਲੇਕਿਨ ਅਸੀਂ ਅਗਰ ਕੱਢ ਦਈਏ, ਉਹਨੂੰ ਡਿਲੀਟ ਕਰ ਦਈਏ, ਸਾਡਾ ਇਹ ਸਾਫ਼ ਹੋ ਸਕਦਾ, ਇਹ ਜ਼ਰੂਰੀ ਹੈ। ਸੋ ਵੀ ਦਿਸ ਇਜ਼ ਨੰਬਰ 12, ਠੀਕ ਹੈ ਜੀ। ਨੰਬਰ 13 ਮੈਂ 13 ਪੁਆਇੰਟ ਕਿਉਂ ਬਣਾਇਆ? ਕਿਉਂਕਿ ਮੇਰਾ ਬਰਥਡੇ 13 ਤਰੀਕ ਨੂੰ ਹੋਇਆ ਸੀ, 13 ਜੁਲਾਈ ਨੂੰ। ਹੀ ਇਜ਼ ਰਾਈਟ। ਸੋ ਮੈਂ 13 ਹੀ ਬਣਾਉਣੇ ਆ, ਹੈ ਜੀ। ਤੁਸੀਂ ਬਚ ਗਏ, ਇਹ ਤੁਸੀਂ ਬਚ ਗਏ ਕਿ ਰਿਮੈਂਬਰ ਡੇਲੀ, ਮੈਂ ਥੋੜਾ ਪੈਰਾਡੌਕਸ ਗੱਲ ਕਰ ਰਿਹਾ, ਰਿਮੈਂਬਰ ਡੇਲੀ ਦੈਟ ਵਨ ਡੇ ਯੂ ਆਰ ਗੋਇੰਗ ਟੂ ਡਾਈ। ਮੈਂ ਮੋਰਨਿੰਗ 'ਚ ਬਿਲੀਵ ਮੀ ਬੌਸ, ਜਦ ਮੈਂ ਸੈਰ ਕਰਦਾ ਮੋਰਨਿੰਗ ਜਾਂ ਸਾਈਕਲਿੰਗ ਕਰਦਾ, ਆਈ ਟੈਲ TS ਕਲੀਅਰ, ਤੂੰ ਇੱਕ ਦਿਨ ਮਰ ਜਾਣਾ, ਤੂੰ ਅੱਜ ਕੋਈ ਚੰਗਾ ਕੰਮ ਕਰ ਲਈ। ਬਿਕੋਜ਼ ਆਈ ਥਿੰਕ ਐਟ ਲੀਸਟ ਟੂ ਮੀ ਦਿਸ ਕੰਸੈਪਟ ਹੈਜ਼ ਮੇਡ ਮੀ ਬੈਟਰ ਹਿਊਮਨ ਬੀਇੰਗ। ਔਰ ਉਹ ਸੱਚਾਈ ਹੈ ਵੈਸੇ ਵੀ। ਸੋ ਆਈ ਐਮ ਏ ਡਾਕਟਰ, ਆਈ ਡੋਂਟ ਵਾਂਟ ਪੀਪਲ ਟੂ ਡਾਈ। ਮੈਂ ਤਾਂ ਕਹਿੰਦਾ ਮਰੇ ਨਾ ਬੰਦਾ, ਲੇਕਿਨ ਮੈਂ ਕਹਿੰਦਾ ਯਾਦ ਜ਼ਰੂਰ ਕਰੋ ਕਿ ਮੌਤ ਆਉਣੀ ਹੈ ਇੱਕ ਦਿਨ। ਇਹ ਜਿਹੜਾ ਹੈ ਖਲਬਲੀ ਕਰਦਾ ਕੋਈ ਫਾਇਦਾ ਨਹੀਂ ਕਿ ਇੱਧਰ ਵੀ ਪੈਸਾ ਕਮਾ ਲਓ, ਇੱਧਰ ਵੀ ਪੈਸਾ ਕਮਾ ਲਓ, ਉਹ ਬਕਵਾਸ ਤੋਂ ਬਾਹਰ ਨਿਕਲੋ, ਯੂ ਨੋ, ਐਜ਼ ਫਾਰ ਐਜ਼ ਯੂ ਕੈਨ ਡੂ। ਅਤੇ ਮੈਨੂੰ ਇਹ ਵੀ ਪਤਾ ਹੈ ਕਿ ਜਿਹੜੀਆਂ ਗੱਲਾਂ ਮੈਂ ਕਰੀਆਂ ਤੁਹਾਡੇ ਨਾਲ, ਤੁਹਾਨੂੰ ਸਾਰਿਆਂ ਨੂੰ ਪਤਾ ਹੈ, ਕੋਈ ਨਵੀਂ ਗੱਲ ਨਹੀਂ, ਕੋਈ ਵੀ ਨਵੀਂ ਗੱਲ ਨਹੀਂ। ਲੇਕਿਨ ਪ੍ਰੋਬਲਮ ਇਹ ਹੈ ਕਿ ਤੁਸੀਂ ਪ੍ਰੈਕਟੀਕਲੀ ਨਹੀਂ ਕਰਦੇ। ਮੈਂ ਪ੍ਰੈਕਟੀਕਲੀ ਕਰਦਾ, ਮਤਲਬ ਕਿ ਮੈਂ ਉਸ ਚੀਜ਼ 'ਤੇ ਆ ਗਿਆ ਕਿ ਮੈਂ ਪ੍ਰੈਕਟੀਕਲੀ ਕਰਦਾ ਆਲਮੋਸਟ 95%। ਈਗੋ ਦੀ ਪ੍ਰੋਬਲਮ ਹਾਲੇ ਵੀ ਹੋ ਜਾਂਦੀ ਹੈ ਕਦੇ ਕਦੇ। ਫਿਰ ਮੈਂ ਉਹ ਈਗੋ ਬੜੀ ਚੀਜ਼ ਹੈ, ਈਗੋ ਜਿਹੜਾ ਕਿ ਖੁੰਬ ਉਹ ਮਸ਼ਰੂਮ ਹੁੰਦੀ ਹੈ ਨਾ, ਉਹਨੂੰ ਕੱਢ ਦੋ ਫਿਰ ਖੜੀ ਹੋ ਜਾਂਦੀ ਹੈ। ਬਟ ਯੂ ਹੈਵ ਟੂ ਰਿਮਾਈਂਡ ਅਗੇਨ ਐਂਡ ਅਗੇਨ। ਬਟ ਫੋਰਚੂਨੇਟਲੀ ਕਿਆ ਹੈ ਕਿ ਯੂ ਆਲਵੇਜ਼ ਨੀਡ ਸਮ ਮੈਂਟਰਸ, ਸਮ ਗੁੱਡ ਫਰੈਂਡਸ ਟੂ ਰਿਮਾइंड यू अगेन एंड अगेन कि नहीं भाई ये तू गलत कर रहे हैं। फॉर्चुनेटली आई हैव वेरी गुड फ्रेंड्स एंड वेन एवर वी सिट टुगेदर, वी टॉक टुगेदर, वी टॉक दीज थिंग्स, ठीक है। तो मैं आपको एक स्टोरी सुनाता हूँ कि मेरा फ्रेंड है बलबीर, ही इज़ इन अमेरिका, ही इज़ ए न्यूरोलॉजिस्ट। तो जब मैंने पद्म भूषण मिलिया तो ਉਹਨੂੰ भी पता चल गया, ਉਹਦਾ फ़ोन आया मैनू कहता क्लेयर मैनू नहीं पता तू भी चालू आदमी है, कहना तू भी फ्रॉड है। मैं क्यों? कहना पद्म भूषण का फ्रॉड नहीं मिलता इंडिया च। ठीक है, एक्चुअली ही इज़ नॉट रॉन्ग, देयर आर मैनी of these awards are given to people who don't deserve, and there are people who almost buy these awards, giving Rajya Sabha seat for example, पैसे दे के ले लो, you know, ये भी award ले लो। तो he was not wrong, so I have those kind of friends who will make me sit on the ground। ठीक है, so ਤੁਹਾਨੂੰ ਕੋਈ ਨਾ ਕੋਈ ਬੰਦਾ ਚਾਹੀਦਾ ਜਿਹੜਾ ਧਰਤੀ 'ਤੇ ਬਿਠਾ ਕੇ ਰੱਖੇ। ਉਹ ਜ਼ਿਆਦਾ ਦੋਸਤ ਨੇ ਜਾਂ ਥੋੜੀ ਵਾਈਫ ਹੁੰਦੀ ਹੈ, ਮੇਰੀ ਵਾਈਫ ਵੀ ਨੀਚੇ ਕਰ ਦਿੰਦੀ ਹੈ। ਸੋ ਦੋਸਤੋ, ਅਖੀਰ 'ਚ ਮੈਂ ਇੱਕ ਗੱਲ ਹੋਰ ਤੁਹਾਨੂੰ ਕਹਿਣਾ ਚਾਹੁੰਦਾ ਕਿ ਮੈਂ ਇਹ ਲੈਕਚਰ ਦੇਣ ਨਹੀਂ ਆਇਆ, ਨਾ ਤਾਂ ਮੈਂ ਟੀਚਰ ਹਾਂ, ਨਾ ਮੈਨੂੰ ਤੁਹਾਡੇ ਤੋਂ ਜ਼ਿਆਦਾ ਗਿਆਨ ਹੈ, ਨਾ ਮੈਂ ਕਿਸੇ ਤਰ੍ਹਾਂ ਦਾ ਬਾਬਾ ਹਾਂ। ਮੈਂ ਕੀ ਹਾਂ? ਸਿੰਸੀਅਰਲੀ ਮੈਂ ਤੁਹਾਡਾ ਇੱਕ ਵੈਲ ਵਿਸ਼ਰ ਹਾਂ, ਇਹ ਤੋਂ ਉੱਪਰ ਕੁਛ ਨਹੀਂ ਹੈ। मैं चाहना है कि एज डॉक्टर्स you should have a capability to become gracious, give best to your patients and earn respect of the society, and the last, earn your own respect। फाइनल रिस्पैक्ट जी मिलती है इंसान को, वो अपनी आप तो मिलती है। जिस तरह फॉर एग्जाम्पल जोड़े मेरे क्लास फैलोज़ हैं, ਜਿਹੜੇ ਮੈਨੂੰ ਚੰਗੀ ਤਰ੍ਹਾਂ ਜਾਣਦੇ ਆ, ਮੇਰੇ ਕੱਛਾ ਬਣਾਉਣ ਵੀ ਜਾਣਦੇ ਆ, ਅਗਰ ਉਹ ਮੇਰੀ ਪ੍ਰੇਜ਼ ਕਰਦੇ, ਮੇਰੀ ਐਸੈਂਸ ਵਿੱਚ ਉਹ ਹੈ ਕਮਾਈ। ਮੂੰਹ ਦੇ ਸਾਹਮਣੇ ਤਾਂ ਬਹੁਤ ਪ੍ਰੇਜ਼ ਕਰਦੀ ਦੁਨੀਆ, ਉਹਨੂੰ ਮੈਂ ਕਦੇ ਸੀਰੀਅਸ ਨਹੀਂ ਲੈਂਦਾ। ਸੋ ਅਰਨ ਦੈਟ ਰਿਸਪੈਕਟ, ਦੀ ਥਿੰਗ ਇਜ਼ ਦੈਟ ਯੂ ਆਰ ਕੈਪੇਬਲ ਆਫ ਅਰਨਿੰਗ ਦੈਟ। ਇੱਕ ਤਾਂ ਬੰਦੇ 'ਚ ਹੁੰਦਾ ਕੈਪੇਬਿਲਿਟੀ ਹੈ ਨਹੀਂ, ਉਹਦਾ ਕੁਝ ਨਹੀਂ ਕਰ ਸਕਦੇ ਆਪਾਂ। ਤੁਹਾਡੇ 'ਚ ਕੈਪੇਬਿਲਿਟੀ ਹੈ, ਯੂ ਹੈਵ ਏ ਕੈਪੇਬਿਲਿਟੀ ਟੂ ਬਿਕਮ ਆਈਡੋਲਸ, ਦੀ ਪਾਥ ਸ਼ੋਇੰਗ ਪੀਪਲ, to your children, to the society। Thank you very much for your attention।
I think a great lecture, as Dr. Clare has said कि जो कुछ इन्होंने दसिया है, मेरा ख्याल कोई आदमी ऐसा नहीं जिन्होंने ਇਹਦਾ नहीं पता। The only thing is कि ਅਸੀਂ how ਜ਼ਿੰਦਗੀ 'ਚ ਲਾਈਫ ਨੂੰ ਪ੍ਰੈਕਟੀਕਲੀ ਕਿਸ ਤਰ੍ਹਾਂ ਉਹਨੂੰ ਯੂਟਿਲਾਈਜ਼ ਕਰਦੇ ਹਾਂ ਜਾਂ ਕਿਵੇਂ ਕਰਦੇ ਹੈਗੇ ਹਾਂ। The only thing which I could feel, मैं ਹੁਣ ਆਰਾਮ ਨਾਲ ਕਹਿ ਸਕਦਾ ਕਿਉਂਕਿ ਗੱਲਾਂ ਹੁਣ ਦਿਲ ਦੀਆਂ ਗੱਲਾਂ ਕਰ ਰਹੇ ਹਾਂ। I know him since 1989, so you can very well imagine almost 36 years। The biggest change I have noticed today, that from Dr. Clare, probably he has gone to a philosopher, and maybe coming time, you see, we will see Baba Clare, you see, with all bharga kapde and all that, and lot of ladies after him। That's my feeling।
And he's right actually। ये तो पक्की गल है कि what you can achieve by becoming Baba in this country, you can never achieve as a cardiologist। देखो, अगर बाबा है, कोई पैसे की कमी नहीं, कोई इनकम टैक्स नहीं, पॉलिटिशियन पैर पकड़ते हैं, बीबियाँ थोड़े चारों पासे घूमदियाँ ने, होर की चाहिए। ठीक है, हुण मैं एरिया लभ रहा जाना कित्थे है, वो असीं दस देंगे।
Any comments, please?
So thank you very much।
If there's
Doctor-
any question, if there's any
नहीं कोई भी आपदा ਜਿਹੜਾ ਹੈ ਨਾ, this is free session।
नहीं, खुल के-
आपदा ਕੋਈ ਐਕਸਪੀਰੀਅੰਸ ਕੋਈ ਹੋਰ ਹੈ, ਤੁਸੀਂ ਸ਼ੇਅਰ ਕਰ ਸਕਦੇ ਹੋ।
ਜਾ।
ਕਲੀਅਰ ਬਾਰੇ ਮੈਂ ਦੱਸ ਰਿਹਾ ਕਿ ਸਾਡੀ ਕਨਵਰਸੇਸ਼ਨ 2 ਮਹੀਨੇ ਪਹਿਲਾਂ ਹੋਈ ਸੀ। ਡਾਕਟਰ ਸਾਹਿਬ ਨੇ ਕੱਲ ਕੁਇਜ਼ ਕਰਨਾ ਸੀਗਾ, ECG ਕੁਇਜ਼ ਫॉर ਡਾਕਟਰਸ। ਕੱਲ ਫਲਾਈਟ ਕੈਂਸਲ ਹੋ ਗਈ, ਦੂਜੀ ਡਿਲੇ ਹੋ ਗਈ, ਸਰ ਨੂੰ ਕਿਤੇ ਹੋਰ ਜਾਣਾ ਪੈ ਗਿਆ ਤੇ
ਮੇਰਾ ਹੈਦਰਾਬਾਦ
ਡਾਕਟਰ
ਤੋਂ
ਜਿੰਦਲ ਬੈਠਿਆ, ਸਰ ਤੁਸੀਂ ਅੱਗੇ ਆ ਜਾਓ। ਤੇ ਪਰਸੋਂ ਮੈਨੂੰ ਫੋਨ ਆਇਆ ਕਿ ਯਾਰ ਮੈਂ ਤਾਂ ਵਾਰਾਣਸੀ ਜਾਣਾ ਹੈ ਤੇ ਮੇਰਾ ਔਖਾ ਹੋ ਜਾਊਗਾ। ਮੈਂ ਕਿਹਾ ਸਰ ਤੁਹਾਡੇ ਬਠਿੰਡੇ ਬਹੁਤ ਫੈਨ ਹੈ ਜੀ। ਮੈਨੂੰ ਤਾਂ ਜਦੋਂ ਦਾ ਤੁਹਾਡਾ ਸਾਇੰਟੀਫਿਕ ਪ੍ਰੋਗਰਾਮ ਛਾਪਿਆ ਅਸੀਂ ਫੋਨ ਆ ਰਿਹਾ ਕਿ ਕਲੇਰ ਸਾਹਿਬ ਕਦੋਂ ਆ ਜਾਣਗੇ, ਕਦੋਂ ਅਸੀਂ ਮਿਲਣਾ ਹੈ। ਤੇ ਬਾਈ ਚਾਂਸ ਮੈਨੂੰ ਡਾਕਟਰ ਜਿੰਦਲ ਮਿਲ ਗਏ, ਸਾਡੀ ਮੀਟਿੰਗ ਸੀਗੀ। ਮੈਂ ਡਾਕਟਰ ਸਾਹਿਬ ਨੂੰ ਦੱਸਿਆ, ਮੈਂ ਕਿਹਾ ਜੀ ਕਲੇਰ ਸਾਹਿਬ ਦਾ ਥੋੜ੍ਹਾ ਜਿਹਾ ਡਾਊਟਫੁਲ ਹੈ। ਇਹਨਾਂ ਨੇ ਉਦੋਂ ਹੀ ਫੋਨ ਮਿਲਾਇਆ ਕਿ ਡਾਕਟਰ ਸਾਹਿਬ ਨਾਲ ਗੱਲ ਕੀਤੀ ਕਿ ਜੀ ਤੁਹਾਡੇ ਬਠਿੰਡੇ ਤਾਂ ਇੰਨੇ ਹੋ, ਵਾਰਾਣਸੀ ਕਿੱਥੇ ਤੁਸੀਂ ਜਾ ਰਹੇ ਹੋ। ਤੇ ਮੈਂ ਡਾਕਟਰ ਜਿੰਦਲ ਦਾ ਦਿਲੋਂ ਧੰਨਵਾਦ ਕਰਦਾ ਹਾਂ ਕਿ ਡਾਕਟਰ ਸਾਹਿਬ ਦੇ ਐਫਰਟਸ ਨਾਲ ਸਾਡੇ ਐਫਰਟਸ ਕੰਬਾਈਨ ਹੋ ਗਏ। ਬਾਕੀ ਬਾਬਾ ਕਲੇਰ ਦੇ ਉਰੇ ਮਤਲਬ ਡਿਸਾਈਪਲ ਵੱਧ ਗਏ ਹੁਣ। ਸੋ ਵੀ ਆਰ ਰੀਅਲੀ ਥੈਂਕਫੁਲ ਸਰ, ਕਿਉਂਕਿ ਸਾਡੇ ਵਾਸਤੇ ਨਾ ਤੁਸੀਂ ਮੈਂਟਰ ਵੀ ਹੋ, ਸਾਡੇ ਗਾਈਡ ਵੀ ਹੋ, ਸਾਡੇ ਤੁਸੀਂ ਐ ਸਮਝ ਲਓ ਕਿ ਆਈਕਨ ਹੋ, ਕਿ ਅਸੀਂ ਸਾਰੇ ਬੰਦੇ ਤੁਹਾਡੇ ਨਾਮ ਤੇ ਬਹੁਤ ਕਰਦੇ ਆ ਵੀ ਕਲੇਰ ਸਾਹਿਬ ਸਾਨੂੰ ਜਾਣਦੇ ਆ ਯਾਰ, ਚੱਕ ਦਿਓ ਕੰਮ।
ਸ਼ਕਲ ਫੱਟੇ।
ਦੋ ਲਾਈਨਾਂ ਮੇਰੇ ਕਰਨੀਓ। Since I had the privilege of working under his tutelage when I was in Escorts, Delhi, ਮੈਂ ਇੱਕ ਗੱਲ ਹਮੇਸ਼ਾ ਬਹੁਤ ਵਾਰ ਆਪਣੇ ਪੇਸ਼ੈਂਟ ਨਾਲ ਜਦੋਂ ਵੀ ਕਿਤੇ ਡਿਸਕਸ਼ਨ ਹੁੰਦੀ ਹੈ, ਜਦੋਂ ਵੀ ਕਿਤੇ ਗੱਲ ਹੁੰਦੀ ਹੈ ਐਥੀਕਲ ਪ੍ਰੈਕਟਿਸ ਦੀ, ਬਿਕੋਜ਼ ਕਾਰਡੀਓਲੋਜੀ ਇੱਕ ਐਸੀ ਬ੍ਰਾਂਚ ਹੈ ਵਿਚ ਇਜ਼ ਆਲਵੇਜ਼ ਸੀਨ ਵਿਦ ਲੋਟ ਆਫ ਸਸਪੀਸ਼ਨ, ਲੋਟ ਆਫ kind of wrongdoings and lot of vested interest and all those things. ਤਾਂ ਜਦੋਂ ਵੀ ਕਦੇ ਐਥੀਕਲ ਪ੍ਰੈਕਟਿਸ ਦੀ ਗੱਲ ਹੁੰਦੀ ਹੈ, ਰਾਈਟ ਐਂਡ ਰੋਂਗ ਦੀ ਗੱਲ ਹੁੰਦੀ ਹੈ, ਤਾਂ ਕਾਰਡੀਓਲੋਜੀ ਸਭ ਤੋਂ ਪਹਿਲਾਂ ਫਿਗਰ ਕਰਦੀ ਹੈ। ਤਾਂ ਮੈਂ ਹਮੇਸ਼ਾ ਕਹਿੰਦਾ ਵੀ ਐਸਕੌਟਸ ਜਦੋਂ ਮੈਂ ਸੀਗਾ ਉੱਥੇ ਬਹੁਤ we have just seen worked with lot of people, and most of the people were adhering to very high standards of ethical practice. Most of the people, I would not say 100%, but most of the people. And who was the torch bearer? Dr. Clare. He was one man who actually led in this particular trade. He set a benchmark that nobody can go down below this level as far as ethics is concerned. So far, more so in cardiology, because here stakes are highest. ਤਾਂ ਅਸੀਂ ਗੱਲ ਕਰਦੇ ਵੀ ਯਾਰ ਫਲਾਨੀ ਐਂਜੀਓਪਲਾਸਟੀ, ਇਹ ਐਂਜੀਓਪਲਾਸਟੀ, ਉਹ ਦੇਰ ਵਾਜ਼ ਅ ਟਾਈਮ ਜਦੋਂ ਅਸੀਂ 15 20 ਐਂਜੀਓਪਲਾਸਟੀਆਂ ਇੱਕ ਦਿਨ 'ਚ ਕਰਦੇ ਸੀਗੇ, ਅਤੇ 5-7 ਐਂਜੀਓਪਲਾਸਟੀਆਂ ਪੋਸਟਪੋਨ ਕਰ ਦਿੰਦੇ ਸੀ, ਕਿਉਂਕਿ ਸਾਡੇ ਕੋਲ ਟਾਈਮ ਨਹੀਂ ਹੁੰਦਾ ਸੀਗਾ। ਪੇਸ਼ੈਂਟ ਨੂੰ ਜਾ ਕੇ ਕਹਿੰਦੇ ਯਾਰ ਵੀ ਖਾਣਾ ਖਾ ਲਓ ਯਾਰ, ਅੱਜ ਟਾਈਮ ਨਹੀਂ ਮਿਲਿਆ, ਕੱਲ੍ਹ ਸਵੇਰੇ ਕਰ ਦਾਂਗੇ, ਪਰਸੋਂ ਕਰ ਦਾਂਗੇ। ਤਾਂ ਇੱਕ ਬੰਦਾ ਕਹਿੰਦਾ ਯਾਰ ਜਦੋਂ ਇੰਨਾ ਕੰਮ ਹੋਵੇ ਤਾਂ ਕੋਈ ਵੀ ਬੰਦਾ ਓਨੈਸਟ ਹੋ ਜਾਊਗਾ। very easy to understand ਕਿ if you have lots of work, lots of patient waiting, anybody can afford to be honest, ethical. ਗੱਲ ਤਾਂ ਉੱਥੇ ਹੈ ਵੀ ਤੁਹਾਡੇ ਕੋਲ ਕੰਮ ਹੈ ਨਹੀਂ ਗਾ, ਫਿਰ ਓਨੈਸਟੀ ਦਿਖਾਓ, that is your absolute honesty. ਚਲੋ ਉਹ ਕਹਿੰਦੇ ਨਾ ਜਿਵੇਂ ਰੱਬ ਨੇ ਟੈਸਟ ਕਰਨਾ ਸੀਗਾ, ਤਾਂ ਉੱਥੇ ਟਰਮੋਇਲ ਹੋਇਆ ਐਸਕੌਟ ਦੇ ਵਿੱਚ, ਡਾਕਟਰ ਤ੍ਰੇਹਾਨ ਚਲੇ ਗਏ, ਸ਼ਿਫਟ ਹੋ ਗਏ, ਦੈਟ ਵਾਜ਼ ਅ ਵੈਰੀ ਡਿਫਿਕਲਟ ਟਾਈਮਸ, ਬੜੀਆਂ ਨਿਊਜ਼ ਇਹ ਉਹ ਨੈਗੇਟਿਵ ਪਬਲਿਸਿਟੀ। ਤਾਂ ਦੇਰ ਵਾਜ਼ ਅ ਟਾਈਮ ਵੈਨ ਵੀ ਹੈਡ ਐਕਚੁਅਲੀ ਡਰਥ ਆਫ ਪੇਸ਼ੈਂਟਸ। ਉਹ ਗੱਲ ਬਾਲੀ ਟਾਈਮ ਨਹੀਂ ਲੱਗਿਆ ਉਸ ਚੀਜ਼ ਨੂੰ ਟੈਸਟ ਕਰਨ ਲੱਗੇ। 15 ਐਂਜੀਓਪਲਾਸਟੀਆਂ ਪਰ ਡੇ, 5-7 ਪੋਸਟਪੋਨ। ਅਸੀਂ ਉਸ ਟਾਈਮ ਆ ਗਿਆ ਸਾਡੇ ਕੋਲ ਵੀ ਅਸੀਂ 5-7 ਐਂਜੀਓਗ੍ਰਾਫੀਆਂ ਕਰਕੇ ਘਰੇ ਚਲੇ ਜਾਂਦੇ ਸੀ, ਐਂਜੀਓਪਲਾਸਟੀ ਇੱਕ ਵੀ ਨਹੀਂ ਕਰਦੇ ਸੀਗੇ। ਇੱਕ ਦਿਨ, 2 ਦਿਨ, 3 ਦਿਨ, ਮਹੀਨਾ ਹੋ ਗਿਆ। ਅਸੀਂ ਕਿਹਾ ਯਾਰ ਪਤਾ ਸਡਨਲੀ ਇਤਨਾ ਪੇਸ਼ੈਂਟ ਵਰਕਲੋਡ ਡਰੋਪ, ਬਿਕੋਜ਼ ਦੈਟ ਵਾਜ਼ ਅ ਟਰਮੋਇਲ ਗੋਇੰਗ ਔਨ, ਸ਼ਿਫਟਿੰਗ, ਇਹ ਉਹ, ਕੌਣ ਇੱਥੇ ਹੈਗਾ, ਡਾਕਟਰ ਕਲੇਅਰ ਇੱਥੇ ਹੈਗੇ ਨਹੀਂ ਹੈਗੇ, ਕਿੱਥੇ ਚਲੇ ਗਏ, ਉਹ ਕਿੱਥੇ ਚਲੇ ਗਏ, ਇਹ ਸਭ ਚੱਲ ਰਿਹਾ ਸੀਗਾ। ਤਾਂ ਫਿਰ ਕਿਸੇ ਬੰਦੇ ਨੇ ਕਿਹਾ ਦੇਖੋ ਦਿਸ ਇਜ਼ ਐਬਸੋਲਿਊਟ ਓਨੈਸਟੀ। ਹੁਣ 5-7 ਐਂਜੀਓਗ੍ਰਾਫੀਆਂ ਆਪਾਂ ਕਰਦੇ ਹਾਂ, ਅਸੀਂ ਟੈਸਟ ਕਰਦੇ, ਅਸੀਂ ਦੇਖਦੇ ਵੀ ਯਾਰ ਕਿਤੇ ਦੇਖਦੇ ਹਾਂ ਸਰ ਕੀ ਰਿਸਪੌਂਸ ਦਿੰਦੇ ਆ। ਕਿਸੇ ਪੇਸ਼ੈਂਟ ਦੀ ਐਂਜੀਓ ਕੀਤੀ 60-70%, 80% ਲੀਜਨ ਹੈ, ਠੀਕ ਹੈ ਸਰ ਇਹ ਤਾਂ ਕਰਨ ਵਾਲਾ ਹੈ ਜੀ, ਇਹ ਤਾਂ ਐਂਜੀਓਪਲਾਸਟੀ ਹੋਣੀ ਚਾਹੀਦੀ ਹੈ। ਅੱਛਾ ਮੇਰੀ ਵੀ ਗੱਲ ਸੁਣ ਲੈਣੀ, ਉਹਦੀ ਵੀ ਸੁਣ ਲੈਣੀ, ਉਹਦੀ ਵੀ ਸੁਣ ਲੈਣੀ, ਅੱਛਾ ਲੱਗਦਾ ਟਾਈਟ ਲੱਗਦਾ, ਚੱਲ ਇੱਕ ਵਾਰ ਇਹਨੂੰ ਦਵਾਈ 'ਤੇ ਪਾ ਦਿਆ, ਫਿਰ ਦੇਖਦੇ ਹਾਂ। He never budged from his principles. He showed his real character in those times, and that is why we all respect him so much, because he always adhered to his principles, whatever the circumstances may be, whatever the time may be. So that is his character, that is his personality. That is why we salute him, and that is why we very kind of proudly say that he is my teacher, my guru, and my mentor. That's it.
So thank you, Rajesh, for your kind words. ਮੈਂ ਦੋ ਗੱਲਾਂ ਹੋਰ ਕਹਿਣੀ ਚਾਹੁੰਦਾ, ਪਾਰਟੀਕੂਲਰਲੀ ਯੰਗ ਬੰਦੇ ਜਿਹੜੇ ਮੇਰੇ ਉਮਰ ਦੀਆਂ, ਖੈਰ ਉਹ ਤਾਂ ਦੂਸਰੀ ਗੱਲ ਹੈ, ਕਿ ਸਭ ਤੋਂ ਬੜੀ ਗਲਤੀ ਇਨਸਾਨ ਕਰਦਾ ਪੈਸੇ ਦੇ ਪਿੱਛੇ ਭੱਜਦਾ, ਸਭ ਤੋਂ ਬੜੀ। ਮੈਂ ਲੋਕਾਂ ਨੂੰ ਕਹਿੰਦਾ ਪੈਸੇ ਦੇ ਪਿੱਛੇ ਕਦੇ ਨਾ ਭੱਜੋ। ਆਈ ਟੈਲ ਯੂ, ਮੈਂ ਐਗਜ਼ਾਮਪਲ ਦੱਸਦਾ ਤੁਹਾਨੂੰ। ਮੈਂ ਆਈ ਵਾਜ਼ ਇਨ PGI, ਅਤੇ PGI 'ਚ ਮੈਨੂੰ ਇਸ਼ਕ ਹੋ ਗਿਆ ਵਾਈਫ ਨਾਲ, ਜੋ ਬਾਅਦ ਮੇਰੀ ਵਾਈਫ ਬਣ ਗਈ। तो सीधे ब्राह्मण तो मैं जट आदमी है, बापू मेरा लड़ गया, कहता मैं ये शादी नहीं हो सकती। सो मैं जी भाई तू जो नुक्स दस तो कुड़ी च की है, देखो नूं ठीक ठाक है। ब्राह्मण तो जट्टां तो उपर ही होंदे, मतलब थल्ले तो नहीं होंदे ना। मैं जी ਉਹਦੇ फादर ਸੀਗੇ, ही वाज जॉइंट डायरेक्टर हैंडलूम्स एंड हैंडीक्राफ्ट JNK, ਉਹਦੇ मामा जी डायरेक्टर जनरल पुलिस के थे JNK में। मैं ਅਸੀਂ ਪਿੰਡ ਦੇ ਰਹਿੰਦੇ ਹਾਂ, ਅਤੇ ਸਾਡਾ ਜਿਹੜਾ ਬੈਡਰੂਮ ਆ, ਮੱਝਾਂ ਦਾ ਬੈਡਰੂਮ ਉਹ ਇੱਕੋ ਸੀ ਬੈਡਰੂਮ ਸਾਡਾ, ਮੱਝਾਂ ਨਾ ਆਈ ਐਮ ਟੈਲਿੰਗ ਦੀ ਰਿਐਲਿਟੀ। ਇਟ ਵਾਜ਼ ਏ ਹਾਲ, ਜਿਹੜਾ ਸਾਡਾ ਘਰ ਸੀਗਾ ਬੜਾ ਜਿਹਾ, ਉਹ ਹਾਲ ਜਿਹਾ ਸੀਗਾ, ਇੱਧਰ ਅਸੀਂ ਹੁੰਦੇ ਸੀ, ਉੱਧਰ ਮੱਝਾਂ ਹੁੰਦੀਆਂ ਸੀ, ਅਤੇ ਇੱਧਰ ਵਾਜ਼ ਮੈਨੀ ਡੋਰ, ਜਿੱਥੇ ਦਰਵਾਜ਼ਾ ਨਹੀਂ ਸੀ ਉਹ ਚਾਦਰ ਜੀ ਪਾਈ ਸੀ ਜਾਂ ਠੰਡ ਹੋ ਜਾਂਦੀ ਸੀ। ਮੈਂ ਕਿਹਾ ਵੀ ਅਸੀਂ ਤਾਂ वी आर नो वे आर इन फ्रंट ऑफ दैम तुम कुड़ी पढ़ी हुई है शी वाज एम डूइंग एम डी खैर एनी वे टू कट दी स्टोरी जट तो पागल कौम होंगी है सॉरी अगर कोई जट बैठा उन्होंने कह रहा मैं उन्हें मन्ने लड़े झगड़ा हो गया मैं जी ठीक है चलो तो साल आप रुक जाने तुम भी सोच लो मैं भी सोच लूँगा मैं बड़ी ट्राई करी जोड़े भी मेरे डैड के दोस्त थे उन्होंने भी किया पर ही डिडंट बच मैं जी 1 साल मैं वेट करूँगा शादी कर लूँगा उसके बाद तो शादी होनी थी फिर मतलब ही ट्रायल किल यू जहाँ तक हालत पहुँच गई तो मेरे को पता था कि चूहा तक भी मारा नहीं मेरे डैड ने भाई मेरे को क्या मारेंगे बट आई वॉज कॉन्फिडेंट बिकॉज आई हैड नो फियर इवन फ्रॉम दैट टाइम सो फिर वो मामा जी ने मेरी वाइफ के मामा जी ने पंजाब डीजी को फ़ोन किया भाई ये शादी के चक्कर में ये लड़का है कि मारी ना देवे बापू सो एनी वे दे आल्सो वर इन्फॉर्म्ड तो मैं आई हैड टेकन मनी फॉर 10,000 रुपीज़ फ्रॉम माई डैड वैसपा स्कूटर बुक कराया सी उदों वैसपा स्कूटर बहुत बड़ी चीज़ सी उन्होंने दिनों वैसपा आज टुडे मर्सिडी तो उपर सीगा करा के ना बुक फिर 5 साल 6 साल 10 साल बाद नंबर आता सीगा वो लड़ाई हो कहने जी मेरे 10,000 रुपये दे क्योंकि 10 रुपये है नहीं सी तो मेरा फ्रेंड शामोन बाणिया मेरा फ्रेंड सीगा बाणिया को पैसे होंगे उन्होंने मैं फोन किया मैं 10,000 रुपया लेके आया मैं पिंड गया तो 10,000 दिता सो टू टेल यू द स्टोरी सो आई स्टार्टेड माई कैरियर लाइफ 10,000 माइनस मेरे को कोई पैसा नहीं सीगा फिर जी चले गए असी बाद चला गया मैं वेंट टू सऊदी बाद यूके चला गया सो आई डिड माई MRC आई क्लियर ऑल माई एग्जाम्स फर्स्ट टाइम 89 से मैं वापस आया 89 वापस आया तो मेरी वाइफ हैड ज्वाइंड गंगाराम हॉस्पिटल 1 साल हो गया सी उन्होंने ऑलरेडी एंड शी डिड वेरी वेल तो सीनियर फैकल्टी स्टार्टेड लाइकिंग हर उत्थे श्री डॉक्टर PL खन्ना सीगा चीफ ऑफ कार्डियोलॉजी तो ही साढ़ा अपने पति को भी बुला ले भी गिव हर ए जॉब सो आई वेंट देयर उन्होंने दे ऑफर्ड मी 50,000 रुपीज़ पर मंथ और प्रैक्टिस वाज अलाउड रहंदे भी 1.5 किलोमीटर सी पटेल नगर रहंदे सी तो उत्थे कैथ लैब नहीं सी फिर मैनू नहीं चंगा लगे हॉस्पिटल मैनू लग्या मैनू कि कुछ मज़ा नहीं आया सो अल्टीमेटली आई वेंट टू स्कॉट हार्ट इंस्टीट्यूट मैं तो तरियानू जानता भी नहीं सीगा सो वो कमरे चला गया मैं जी आई एम सो एंड सो आई एम ट्रेन फ्रॉम PGI चंडीगढ़ आई एम वर्किंग इन UK नाउ सो डू यू हैव एनी प्लेस फॉर मी तो मेरे को कहता फर्स्ट डायलॉग था उसका कि यू आर द राइट काइंड ऑफ पर्सन आई वॉज लुकिंग फॉर उन्होंने मैंने कुछ नहीं पूछा तो मैं वो ऐसी गूगली फेंकी उसने कि मेरे और कोई सवाल ही नहीं पूछा फिर मैं नहीं पूछा मेरी तनख्वाह कितनी होएगी मेरा स्टेटस क्या होगा वो कहने यू कैन ज्वाइन टमारो तो कल अपने सर्टिफिकेट लिया HR चले जाते मैं आ गया सो HR ने 2-3 घंटे मेरी वेट कराई तो उन्होंने मैंने लैटर दे दिता और मैं बाहर आके लैटर खोलिया टू माई शॉक दी टोटल सैलरी पर मंथ वाज 7,500 they were offering 50,000 rupees practice was allowed ਇੱਥੇ 7,500 सैलरी प्रैक्टिस नॉट अलाउड 25 किलोमीटर दूर ਸੀਗਾ ਤੇ ਉਹ ਸਾਡੇ ਕੋਲ ਉਦੋਂ ਇੱਕ ਕਾਰ ਸੀ ਮਰੂਤੀ 800 ਠੀਕ ਹੈ ਉਹ ਕਦੇ ਉਹ ਲੈ ਜਾਂਦੀ ਸੀ ਕਦੇ ਮੈਂ ਲੈ ਜਾਂਦਾ ਸੀ ਕਦੇ 3 ਵੀਲਰ ਤੇ ਜਾਂਦੇ ਸੀ ਸੋ ਟੂ ਕੱਟ ਦੀ ਸਟੋਰੀ ਸ਼ਾਰਟ ਕਿਸੇ पता नहीं कौन सा वो परमात्मा कहूँगा बाबा नानक है जो भी है मेरे को उसने दिमाग में डाला कि ये जगह तेरी फ्यूचर के लिए ज़्यादा अच्छी है सो आई एक्सेप्टेड 1/6 ऑफ द सैलरी एंड दैट वाज वन ऑफ माई बेस्ट डिसीजन ऑफ लाइफ एंड आई एम नॉट ए पुअर मैन टुडे आई हैव एनफ मनी सो मैं लोगों को कहता हूँ अपने बच्चों को भी ये कहता हूँ और जूनियर बंदों को ज़रूर कहूँगा कि वो सुने मेरी बात कि बेटा पैसे के पीछे नहीं भागना यू रन आफ्टर क्रेडिबिलिटी एंड कैपेबिलिटी आप अपनी कैपेबिलिटी बनाओगे आप अपनी क्रेडिबिलिटी बनाएंगे पैसा आपके पीछे भागेगा लोग तरले करेंगे सो जो प्रिंसिपल चाहिए पैसे के पीछे ना भागो पैसा आपके पीछे भागेगा 100% उसमें डाउट नहीं कोई
एक स्टोरी मैं भी रिलेट करता हूँ इनके साथ की ही स्टार्टेड सेइंग -10,000 in 75 that was my first flight to UK at that time only 3 pounds were allowed to take with you and the conversation rate was 18 rupees per pound that means कि 54 रुपये मुझे जेब में डाल के मैं फ़्लाइट पे बैठ गया फ़्लाइट की टिकट भी मेरे मामा जी रहते थे वहाँ से उन्होंने भेजी थी अच्छा यंग थे पता नहीं था एयर होस्टेस आई वुड यू लाइक टू हैव ए ड्रिंक हमने ड्रिंक ले ली बाद में पता लगा कि उसके तो पैसे लगेंगे वो 1.5 पाउंड उसने ले लिया हमारे पास बचा 1.5 पाउंड। तो अब मामा जी ने कहा था कि मैं आपको लेने आऊँगा, वो लेने नहीं आए। वो कहते अच्छा टैक्सी करके आ जाओ टैक्सी वाले ने 3 पाउंड मांग लिया, हमारे पास तो 1.5 पाउंड थे तो वो क्या 1.5 पाउंड मामा जी ने दिए। So that means I started with my career with minus 1.5 pound. And again I say, money is the byproduct of my profession. I don't have to ask for it. If I'm working, I'm there, you see, money is bound to come. So you don't have to run after money, money will automatically come to you.
ਬਿਲਕੁਲ ਠੀਕ ਹੈ। ਸੋ ਮੈਂ ਤੁਹਾਨੂੰ ਦੱਸਦਾ ਇੱਕ ਗੱਲ ਹੋਰ ਕਿ ਮੈਨੂੰ ਬਠਿੰਡੇ ਦੀ ਫੈਸੀਨੇਸ਼ਨ ਕਿਉਂ ਹੋਈ, ਕਿਉਂਕਿ ਸਾਡੇ ਮੈਡੀਕਲ ਕਾਲਜ 'ਚ ਬਠਿੰਡੇ ਦੇ ਮੁੰਡੇ ਇੱਧਰੋਂ ਆਉਂਦੇ ਸੀ, ਭੁੱਚੋ ਮੰਡੀ, ਰਾਮਪੁਰਾ ਫੂਲ, ਤਪਾ ਮੰਡੀ, ਠੀਕ ਹੈ, ਇੱਧਰੋਂ ਕਾਫੀ ਮੁੰਡੇ ਆਉਂਦੇ ਸੀ। ਅਤੇ ਫਿਰ ਮੈਨੂੰ ਪਤਾ ਚੱਲਿਆ, ਕਹਿੰਦਾ ਯਾਰ ਮੇਰਾ ਫਰੈਂਡ ਜਿਹੜਾ ਹੈਗਾ, ਕਹਿੰਦਾ ਕਲੀਅਰ ਤੈਨੂੰ ਨਹੀਂ ਪਤਾ ਜਿਹੜੇ ਬਠਿੰਡੇ ਦੇ ਬਾਣੀ ਹੈ ਨਾ ਜੱਟਾਂ ਤੋਂ ਉੱਪਰ ਹੈ। ਮੈਂ ਜੱਟ ਆਦਮੀ, ਮੈਂ ਯਾਰ ਫਿਰ ਤਾਂ ਜਾਣਾ ਪੈਣਾ ਉੱਥੇ। ਸੋ ਬਟ ਦੈਟ ਵਾਜ਼ ਏ ਟਰੂ ਸਟੇਟਮੈਂਟ। ਆਈ ਡਿਫਰੈਂਸ਼ੀਏਟ ਬਠਿੰਡਾ ਏਰੀਆ ਫਰਮ ਅਦਰ ਏਰੀਆ, ਦ ਪੀਪਲ ਆਰ ਡਿਫਰੈਂਟ। खैर ਹੁਣ ਤਾਂ चेंज आई होनी है पक्का, बट दे आर वेरी स्ट्रेट फॉरवर्ड। लाइक जो फार्मर कम्युनिटी में क्या होता है, वेरी स्ट्रेट फॉरवर्ड होते हैं ना पहले, तो दे आर स्ट्रेट फॉरवर्ड। वो कोई बनिया वाली एटीट्यूड नहीं सी इन्होंने लोगों का। हुण मैनूं नहीं पता, हुण तो थोड़ा बहुत चेंज हो गया, पर ये बाकी ਜਿਹੜੇ ਬਠਿੰਡੇ ਦੇ ਬਾੜੀਆਂ ਜੱਟਾਂ ਦੇ बराबर ही है। थैंक यू वेरी मच। सो मैं आखिर में डॉक्टर बिटल का आप सब लोगों का बहुत शुक्रिया करता हूँ। आप लोगों ने इतना प्यार मोहब्बत राजेश आपने दिया है जो मैं डिज़र्व नहीं करता, और मैं उसके लिए आपका बहुत बहुत शुक्रिया करता हूँ। बिटल, थैंक यू वेरी मच।
ਸੋ ਤੁਸੀਂ ਸਾਡਾ ਥੈਂਕਸ ਨਾ ਕਰੋ ਜੀ, ਅਸੀਂ ਵੀ ਆਰ ਰੀਅਲੀ ਐਕਸਾਈਟਿਡ ਟੂ ਹੈਵ ਯੂ ਹੀਅਰ ਬਿਫੋਰ ਯੂ ਕੇਮ, ਐਂਡ ਆਈ ਥਿੰਕ ਯੂ ਆਰ ਦੀ ਮੋਸਟ ਐਪਰੋਪ੍ਰੀਏਟ ਪਰਸਨ ਟੁਡੇ ਐਜ਼ ਚੀਫ ਗੈਸਟ ਆਲਸੋ, along with 2 other dignitaries, Dr. Baldev Singh Aulik, ਡਾਕਟਰ ਕਰਮਵੀਰ ਸਿੰਘ ਕਹਤਾ ਜੀ ਕਿਉਂਕਿ ਹੁਣ ਜੱਟਾਂ ਨਾਲ ਬੈਠਾ ਹੈ, 2 ਜੱਟਾਂ ਨਾਲ ਤੀਜਾ ਜੱਟ ਹੋ ਗਿਆ ਜੀ। ਹਾਂ ਜਿਵੇਂ ਸਾਨੂੰ ਬ੍ਰਾਊਨ ਵਾਲਡ ਮਿਲਿਆ ਜਿਹਨੇ ਕਾਰਡੀਓਲੋਜੀ ਦੀ ਬੁੱਕ ਲਿਖੀ ਸੀ, ਅਸੀਂ 2 ਮਿੰਟ ਹੱਥ ਹੀ ਮਿਲਾਈ ਗਏ ਵੀ ਸ਼ਾਇਦ ਮਾੜੀ ਮੋਟੀ ਕਾਰਡੀਓਲੋਜੀ ਸਾਡੇ 'ਚ ਹੀ ਆ ਜੇ। ਸੋ you are the most appropriate person to give away the awards during the award ceremony to the people who have significantly made contribution for success of MAPICON over 12 years. And I must thank my doctor friends in organizing committee, and more importantly, non-medical friends who have contributed. So I invite all the 3 dignitaries, the chief guests, the super chief guests, to come here in front of the stage. So there is no stage as such, because this is very informal meeting we do every year. So ਅੱਜ ਡਾਕਟਰ ਸਾਹਿਬ ਦੇ ਕਹਿਣ ਤੇ ਹੋਰ ਇਨਫੋਰਮੈਲਿਟੀ ਵੱਧ ਗਈ, ਸਾਡਾ ਰਿਜ਼ੋਲਵ ਹੋਰ ਵੱਧ ਗਿਆ ਕਿ ਤਾਮ ਝਾਮ ਨਾਲੋਂ ਭਾਈ ਬੁਕੇ ਦਿਓ ਜੀ, ਆਹ ਦਿਓ ਉਹ ਦਿਓ। ਇਟ ਇਨ ਰੀਅਲ ਸੈਂਸ ਯੂ ਮਸਟ ਐਪਰੀਸ਼ੀਏਟ ਐਂਡ ਐਕਨੋਲੇਜ ਦੀ ਕੰਟਰੀਬਿਊਸ਼ਨ। ਸੋ ਡਾਕਟਰ ਕਲੇਰ ਸਾਹਿਬ, ਔਲਖ ਸਾਹਿਬ, ਡਾਕਟਰ ਕਰਮਵੀਰ,
गुड मॉर्निंग एवरीबॉडी। मैं डॉक्टर करमवीर गोयल। मैं जस्ट एक 2 लाइना ही कहूँगा कि जो डॉक्टर बाबा क्लेयर ने किया है वो एक्चुअली प्रैक्टिस कर देने इस चीज़। मैं तुम्हें अपनी परसनल एग्जांपल दूंगा, ये कोई फ्लैटरी नहीं है, कोई वो नहीं है कि सर दे सामने खड़े नहीं। मैं सर नूं एक बार फ़ोन किया, सर मैं तुम्हें मिलना चाहना है। संडे का दिन सी, ही कह करमवीर आ जा। फार्म हाउस से बुलाया, बिल्कुल फ्री उस दिन अपने आप नूं रखिया, 3 घंटे मेरे नाल बिताए, लंच कराया, मैनू अपने फार्म हाउस का पूरा गेड़ा दिवाया, और पूरियां गल्लां ये सारियां जिहड़ियां तुसीं दित्तियां ना मेरे दिल च धारियां कि हाँ, एंड आई एक्चुअली हैव सीन हिम प्रैक्टिसिंग ऑल these things. So once again, before we start the program, 3 cheers and standing ovation to him.
सर ये सारा क्लेयर साहब करके है यार, मैं कुछ नहीं है frankly. So it is because of the sport. बिल्कुल ठीक है जी। सो मैं थोड़ी जी सैरेमनी इस तो शुरू करदा कि वी एक्नॉलेज ऑल द 3 great people who motivate us to go further. We have announced the dates of our 13th annual conference also from 17th to 20th September next year. So I will request all the people go for early bird registration. ਬਾਅਦ 'ਚ 6,000 ਭਰਨ ਨਾਲੋਂ ਹੁਣ 3,000 ਹੋ ਰਹੀ ਹੈ, तो that will motivate us also ਕਿ ਸਾਡੀਆਂ ਹੁਣ ਤੱਕ 70 registrations ਹੋ ਗਈਆਂ. So we will be formulating the program up till December. So anybody of you interested in delivering a lecture, especially young people less than 40 years of age, give me your credentials, give me your topic, so that our scientific committee should choose out of those. So I acknowledge the presence of my dear friend, both from Max, from early years, Dr. Vikas and Dr. Dalbir. Thank you for coming. So we invited them as a special guest. ਬਹੁਤ ਵਧੀਆ ਕੀਤਾ ਯਾਰ ਤੁਸੀਂ ਆ ਗਏ. ਪੁਰਾਣੀਆਂ ਯਾਦਾਂ ਜਿਵੇਂ ਡਾਕਟਰ ਕਲੇਰ ਸੁਣਾ ਰਹੇ ਸੀ ਨਾ ਜੀ, ਸਾਡਾ ਬਹੁਤ ਵਧੀਆ ਗਰੁੱਪ ਸੀ ਜੀ. ਇਨ ਫੈਕਟ ਇਟ ਸਟਾਰਟਡ, ਉਹਦੇ ਡਾਕਟਰ ਦਲਬੀਰ ਆਏ, ਮੈਨੂੰ ਚਿੰਕੂ ਦਾ, ਰਾਜੂ ਦੇ ਛੋਟੇ ਭਰਾ ਦਾ ਫੋਨ ਆਇਆ ਕਿ ਯਾਰ ਦਿਲਪ੍ਰੀਤ ਆ ਰਹੀ ਹੈ, ਉਹਦਾ ਟੇਕ ਕੇਅਰ. ਸੋ ਆਈ ਵੈਂਟ ਟੂ ਸੈਪਲ ਹੋਟਲ ਕਿ ਮੈਡਮ ਕੁਛ ਚਾਹੀਦਾ. ਸ਼ੀ ਵਾਸ 4 years ਜੂਨੀਅਰ ਟੂ ਮੀ, ਕਿ ਕੁਛ ਚਾਹੀਦਾ ਹੈ, ਕੋਈ ਬਠਿੰਡੇ ਆਇਆ ਬੰਦਾ ਹੌਸਪਿਟੈਲਿਟੀ ਵਾਈਜ਼. ਅਤੇ ਮੈਂ ਜਦੋਂ ਉੱਥੇ ਗਿਆ, ਉੱਥੇ ਸਾਰਾ ਨਾ ਭਰਿਆ ਹੋਇਆ ਸੀ ਸੈਪਲ ਹੋਟਲ ਉਰੇ ਲੌਬੀ 'ਚ. ਮੈਂ ਪੁੱਛਿਆ, ਮੈਂ ਕਿਹਾ ਯਾਰ ਉਹ ਮੈਡਮ ਨੂੰ ਮਿਲਣਾ ਸੀ ਦਿਲਪ੍ਰੀਤ ਨੂੰ. ਉਹ ਕਹਿੰਦੇ ਜੀ ਅਪੋਇੰਟਮੈਂਟ ਲਿੱਤੀ ਹੈ. ਮੈਂ ਕਿਹਾ ਨਾ ਯਾਰ ਅਪੋਇੰਟਮੈਂਟ ਤਾਂ ਲਿੱਤੀ ਨਹੀਂ, ਮੈਨੂੰ ਪਤਾ ਹੀ ਨਹੀਂ ਸੀ ਵੀ ਅਪੋਇੰਟਮੈਂਟ ਲੈਣੀ ਹੈ. ਤੁਸੀਂ ਆਹ ਕਾਰਡ ਪਲੀਜ਼ ਦੇ ਦਿਓ, ਅਤੇ ਜੇ ਉਹ ਮੈਡਮ ਕੋਲ ਟਾਈਮ ਹੋਊਗਾ ਤਾਂ ਮਿਲ ਲੈਣਗੇ, ਨਹੀਂ ਤਾਂ ਮੈਂ ਤਾਂ ਪੁੱਛਣਾ ਹੀ ਸੀਗਾ, ਮੈਂ ਉਹਨਾਂ ਦੀ ਕੀ ਹੈਲਪ ਕਰਨੀ ਹੈ, ਇੰਨਾ ਧਾਮ ਝਾਮ ਉਰੇ ਹੈਗਾ. ਅਤੇ ਚਲੋ ਜੀ ਉਹਨਾਂ ਨੇ ਕਾਰਡ ਦਿੱਤਾ. ਉਹਨਾਂ ਨੇ ਕਾਰਡ ਦੇਖਿਆ, ਸ਼ੀ ਇਮੀਡੀਏਟਲੀ ਕਾਲਡ ਮੀ ਇਨ. ਉਹਨਾਂ ਦੇ ਵੱਡੇ ਸਿਸਟਰ ਵੀ ਸੀਗੇ, ਉਹਨਾਂ ਦਾ ਨਾਮ ਹੈ, ਮੈਨੂੰ ਪੁੱਛਿਆ ਬੈਠ ਕੇ ਜਦੋਂ, ਮੇਰਾ ਨਾਮ ਨਿਕਨੇਮ ਬਿੱਟੂ ਹੈ. ਅਤੇ ਉਹ ਕਹਿੰਦੇ ਬਿੱਟੂ ਮੈਂ ਕੌਣ ਹੈ? ਮੈਂ ਕਿਹਾ ਮੈਡਮ ਮੈਨੂੰ ਤੁਹਾਡਾ ਊਂ ਨਾਂ ਤਾਂ ਪਤਾ ਨਹੀਂ, ਮੈਨੂੰ ਤੁਹਾਡਾ ਬਬਲ ਦਾ ਨਾਂ ਪਤਾ ਹੈ. ਮੈਂ ਕਿਹਾ ਤੁਸੀਂ ਬਬਲ ਹੋ? ਕਹਿੰਦੇ ਇਹੀ ਸੁਣਨਾ ਚਾਹੁੰਦੀ ਸੀ ਮੈਂ. ਆਈ ਡਿਡ ਨਾਟ ਰਿਮੈਂਬਰ ਐਟ ਦੈਟ ਟਾਈਮ. ਮਤਲਬ ਹੁਣ ਵੀ ਤੁਸੀਂ ਕਰੋ ਨਾ ਕਿ ਪੁਰਾਣੇ ਦੋਸਤਾਂ ਦਾ ਨਾਮ ਹੈਗਾ. ਮੈਂ ਤੁਹਾਨੂੰ ਇੱਕ ਹੋਰ ਅੱਗੇ ਸੁਣਾਊਂਗਾ ਗੱਲ. ਅਤੇ ਅਸੀਂ ਬੈਠੇ ਗੱਪਾਂ ਛੱਪਾਂ ਮਾਰਦੇ ਰਹੇ. ਮੈਨੂੰ ਕਹਿੰਦੇ ਕੀ ਕਰ ਰਹੇ ਹੋ? ਮੈਂ ਕਿਹਾ ਜੀ ਮੇਰਾ ਕਲੀਨਿਕ ਹੈਗਾ, ਮੈਂ 11 ਵਜੇ ਜਾਂਦਾ, ਅਤੇ ਇਸ ਤਰ੍ਹਾਂ ਕਰਕੇ. ਕਹਿੰਦੇ 9 ਤੋਂ 11 ਤੁਸੀਂ ਜੁਆਇਨ ਕਰ ਲਓ ਮੈਕਸ ਹੌਸਪੀਟਲ. ਉਹ ਮੈਂ ਕਿਹਾ ਜੀ ਕਾਰਪੋਰੇਟ ਹੌਸਪੀਟਲ ਹੈ, ਜਿਵੇਂ ਸਰ ਨੇ ਕਿਹਾ ਵੀ ਕਾਰਪੋਰੇਟ ਹੌਸਪੀਟਲ ਹੈ ਜੀ, ਮੈਂ ਕਾਰਡੀਓਲੋਜੀ ਸੁਸਾਇਟੀ 'ਤੇ ਲੈਕਚਰ ਦੇ ਕੇ ਆਇਆ, ਅਨਐਥੀਕਲ ਪ੍ਰੈਕਟਿਸਿਸ ਇਨ ਕਾਰਪੋਰੇਟ ਹੌਸਪੀਟਲ. ਤੁਸੀਂ ਮੈਨੂੰ ਕਹੀ ਜਾਂਦੇ ਹੋ ਕਾਰਪੋਰੇਟ ਹੌਸਪੀਟਲ ਜੁਆਇਨ ਕਰ ਲਓ. ਉਹ ਨਹੀਂ ਸਾਡਾ ਕਾਰਪੋਰੇਟ ਅਲੱਗ ਕਿਸਮ ਦਾ ਹੈ, ਜਿਵੇਂ ਰੂਟੀਨ ਹੁੰਦਾ. ਚਲੋ ਜੀ ਗੱਲਾਂ ਬਾਤਾਂ ਕਰਕੇ ਕੌਫੀ ਕੂਫੀ ਪੀ ਕੇ ਮੈਂ ਉਹਨਾਂ ਨੂੰ ਕੀ ਪੁੱਛਣਾ ਸੀ ਵੀ ਤੁਹਾਨੂੰ ਕੋਈ ਹੈਲਪ ਚਾਹੀਦੀ ਹੈ, ਅਤੇ ਮੈਂ ਚਲਾ ਗਿਆ. ਨੈਕਸਟ ਡੇ ਮੇਰੇ ਕਲੀਨਿਕ 'ਤੇ ਉਹਨਾਂ ਦਾ HR ਦਾ ਬੰਦਾ ਆਇਆ, ਉਹਨੇ ਕੰਟਰੈਕਟ ਲਿਖਿਆ ਵਾ ਸੀਗਾ, ਅਤੇ ਮੈਨੂੰ ਕਹਿੰਦਾ ਜੀ ਮੈਡਮ ਨੇ ਭੇਜਿਆ ਅਤੇ ਸਾਈਨ ਕਰ ਦਿਓ. ਉਹ ਮੈਂ ਕਿਹਾ ਯਾਰ ਕੱਲ੍ਹ ਤਾਂ ਗੱਲ ਹੋਈ ਸੀਗੀ ਮੈਂ ਕਾਰਪੋਰੇਟ. ਕਹਿੰਦੇ ਨਹੀਂ ਜੀ ਉਹਨਾਂ ਨੇ ਕਿਹਾ ਸਾਈਨ ਕੀਤੇ ਬਿਨਾਂ ਨਹੀਂ ਆਉਣਾ. ਸੋ ਦੈਟ ਵਾਜ਼ ਐਨ ਓਬਲੀਗੇਸ਼ਨ. ਇਨ ਫੈਕਟ ਆਈ ਸਾਈਨਡ ਐਜ਼ ਏ ਵਿਜ਼ਿਟਿੰਗ ਕੰਸਲਟੈਂਟ ਇਨ ਮੈਕਸ ਹੌਸਪੀਟਲ ਫਰੋਮ 9 to 11 ਐਂਡ ਆਈ ਵੈਂਟ ਫਸਟ ਡੇ. ਮੇਰੇ ਖਿਆਲ 15 ਤਰੀਕ ਨੂੰ ਸ਼ੁਰੂ ਹੋਇਆ ਸੀ, 12 ਤਰੀਕ ਨੂੰ, ਕਿਦਨ 12 ਤਰੀਕ ਨੂੰ ਸ਼ੁਰੂ ਹੋਇਆ ਸੀਗਾ, 16 ਨੂੰ. ਸੋ ਆਈ ਵੈਂਟ ਫਸਟ ਡੇ and that was one of my luckiest day. I met excellent people. Dr. Vikas बैठे है, Dr. Dilbir बैठे है, Dr. Sharad पता नहीं आए है कि नहीं आए. Dr. Sharad was cardiologist, Anand Yadav was cardiothoracic surgeon, ते अपने neurosurgeon सीगे Dr. Jagmal. Excellent people and I still relish those 6 years spending there. ਟਾਰਗੇਟ ਦੀ ਗੱਲ ਹੈ ਜੀ, ਮਹੀਨੇ ਬਾਅਦ ਮੀਟਿੰਗ ਹੋਈ, ਉਹਨਾਂ ਦੇ ਮੈਡੀਕਲ ਡਾਇਰੈਕਟਰ ਆਏ ਉੱਥੋਂ, ਅਤੇ ਮੀਟਿੰਗ ਕਰ ਰਹੇ ਸੀ. ਕਹਿੰਦੇ ਜੀ ਤੁਹਾਡਾ ਰੈਵਨਿਊ ਬਹੁਤ ਘੱਟ ਹੈ. ਮੈਂ ਕਿਹਾ ਜੀ ਰੈਵਨਿਊ ਤਾਂ ਘੱਟ ਹੋਊਗਾ ਹੀ, ਤੁਸੀਂ ਮਰੀਜ਼ਾਂ ਦਾ ਇਨਟੇਕ ਦੇਖੋ ਕਿ ਜਿਹੜਾ ਮਰੀਜ਼ ਦਿਖਾ ਕੇ ਜਾਂਦਾ ਉਹ ਵਾਪਸ ਆਉਂਦਾ ਕਿ ਨਹੀਂ ਆਉਂਦਾ. ਹੁਣ ਜਿਹੜਾ ਪੇਸ਼ੈਂਟ ਆ ਗਿਆ ਅਨਕੌਂਸ਼ੀਅਸ ਹੈਗਾ, ਸ਼ਾਮ ਨੂੰ ਕੌਂਸ਼ੀਅਸ ਹੋ ਗਿਆ, ਬੈਠ ਕੇ ਰੋਟੀ ਖਾ ਰਿਹਾ ਹੈ, ਉਹਦਾ ABG ਜਾਂ RFT ਜਾਂ LFT ਮੈਂ ਨਹੀਂ ਕਰਵਾਊਂਗਾ ਜੀ. ਸੋ ਇਸ ਕਰਕੇ ਰੈਵਨਿਊ ਘੱਟ ਹੈ. ਬਾਕੀ ਤੁਸੀਂ ਦੱਸ ਦਿਓ ਮੈਂ ਕੱਲ੍ਹ ਤੋਂ ਨਹੀਂ ਆਉਂਦਾ. ਮੈਨੂੰ ਤਾਂ ਮੈਡਮ ਦਿਲਪ੍ਰੀਤ ਨੇ ਭੇਜਤਾ ਸੀ ਜੀ, ਮੈਂ ਆ ਗਿਆ. ਤੁਸੀਂ ਕਹਿ ਦੋਗੇ ਮੈਂ ਕੱਲ੍ਹ ਤੋਂ ਨਹੀਂ ਆਉਂਦਾ. ਉਸ ਤੋਂ ਬਾਅਦ 6-7 ਸਾਲ ਮੈਨੂੰ ਕਿਸੇ ਨੇ ਨਹੀਂ ਪੁੱਛਿਆ ਕਿ ਰੈਵਨਿਊ ਕਿੰਨਾ ਹੈ. ਸੋ ਇਟ ਇਜ਼ ਬੇਸਿਕਲੀ ਤੁਹਾਡੇ ਵਾਲੀ ਗੱਲ ਹੈ. ਡਾਕਟਰਸ ਆਪਣਾ ਟਾਰਗੇਟ ਕਰਦੇ ਆ, ਉਹ 2 ਬੰਦੇ ਬੈਠੇ ਆ ਮੋਟੀਵੇਟਿੰਗ ਫੋਰਸ. ਮਤਲਬ ਜੇ ਰੈਫਰ ਕਰਨਾ ਹੋਵੇ ਮੈਨੂੰ ਕੋਈ ਹੋਰ ਨਾਮ ਖਿਆਲ ਨਹੀਂ ਆਉਂਦਾ ਜੀ. ਸੋ ਦੈਟ ਇਜ਼ ਹਾਊ ਦੀ ਥਿੰਗਸ ਆਰ ਐਂਡ ਵੀ ਆਰ ਰੀਅਲੀ. ਤੁਹਾਡੇ ਜਿਹੜੇ 13 ਪੁਆਇੰਟ ਪ੍ਰੋਗਰਾਮ ਹੈ ਨਾ ਜੀ, ਅਸੀਂ ਉਹਨਾਂ ਨੂੰ ਹੋਰ ਚੰਗੀ ਤਰ੍ਹਾਂ ਇੰਪਲੀਮੈਂਟ ਕਰਨ ਦੀ ਕੋਸ਼ਿਸ਼ ਕਰਾਂਗੇ. ਤੇ ਦੂਜਾ ਜਿਹੜੀ ਨੂੰਹ ਸੱਸ ਵਾਲੀ ਗੱਲ ਹੋਈ ਸੀਗੀ ਵੀ ਸੱਸ ਕਹਿੰਦੀ ਹੈ ਨੂੰਹ ਦੱਸ ਕੇ ਨਹੀਂ ਜਾਂਦੀ, ਆਈ ਕੰਪਲੇਂਟ ਕੀਤੀ ਤੇ ਉਹਦੀ ਦੂਜੀ ਜਿਹੜੀ ਸਹੇਲੀ ਸੀ ਉਹ ਕਹਿੰਦੀ ਯਾਰ ਤੂੰ ਫੇਸਬੁੱਕ ਤੇ ਨਹੀਂ ਹੈ ਉਹਦੇ ਫਰੈਂਡ ਲਿਸਟ 'ਚ? ਕਹਿੰਦੇ ਨਾ, ਕਹਿੰਦੇ ਤਾਂ ਹੀ ਨਹੀਂ ਨਾ ਤੈਨੂੰ ਪਤਾ ਲੱਗਦਾ, ਕਹਿੰਦੇ ਫੇਸਬੁੱਕ ਫਰੈਂਡ ਬਣ ਜਾ ਤੇ ਤੈਨੂੰ 2 ਮਿੰਟਾਂ 'ਚ ਪਤਾ ਲੱਗ ਜਾ ਕਰੂਗਾ ਤੇਰੀ ਨੂੰਹ ਕਿੱਥੇ ਚੱਲੀ ਹੈ ਕਿੱਥੇ ਨਹੀਂ ਚੱਲੀ, ਤੈਨੂੰ ਪੁੱਛਣ ਦੀ ਲੋੜ ਹੀ ਨਹੀਂ ਹੈ। ਸੋ ਚੱਲਦਾ ਹੈ ਜੀ ਕੰਮ। So now we are ready for our program, and I invite to acknowledge your presence, token of love, my wife Dr. Sonia and my daughter Meghna Gupta, to please give token of love to Dr. Claire. And these two people are most important people in my life as well as organizing MAPICON. The book I talked about is edited very meticulously by Dr. Meghna Gupta, and she is pillar of our strength in organizing MAPICON. Thank you, sir. Thank you for coming. ਤੇ ਪਾਈ ਰੱਖਣੀ ਹੈ ਜੀ ਜਿੰਨੀ ਦੇਰ ਪੂਰੀ ਮੀਟਿੰਗ ਨਹੀਂ ਹੁੰਦੀ। So now I call upon Dr. Rajesh Jindal and Dr. K.K. Noria to present token of love to a great friend, Dr. Baldev Singh Aulak. Baldev Singh Aulak, he was the best volleyball player of GOMCO, and all 5 years he was best athlete of GOMCO. He was 1 year junior to me. We had honor to accompany, मतलब ਅਸੀਂ ਇਕੱਠੇ ਜਾਂਦੇ ਸੀ ਖੇਡਣ ਵਾਸਤੇ ਪਲਸ ਤੇ great personality. Now also he is doing a great job in Ludhiana in organ transplant as well as in clinic, Akai Hospital for renal issues and multi-specialty hospital. Thank you Dr. Baldev for coming. ਬੜੀ ਦੇਰ ਦੀ ਸੀਗੀ, ਅਸੀਂ walkathon ਵੀ ਕਰਨੀ ਸੀਗੀ ਅੱਜ ਸਵੇਰੇ, ਪਰ it was because of floods we had to postpone. So we did not do it. Thank you, Dr. Baldev, for coming.
We will do it in winter months.
हाँ ਜਦੋਂ ਕਹੇਗਾ ਯਾਰ, ਗੱਲ ਹੀ ਕੋਈ ਨਹੀਂ ਹੈ। ਇਹ ਮੈਪੀਕੌਨ ਨਾਲ ਥੋੜੀ ਜੋੜਨੀ ਔਖੀ ਹੋ ਜਾਂਦੀ ਹੈ ਕਿਉਂਕਿ ਇੱਧਰੋਂ ਬਹੁਤ ਜ਼ਿਆਦਾ ਹੋ ਜਾਂਦਾ ਹੈ ਇਸ਼ੂ। So now I'll invite our organizing committee members, Dr. M.R. Gupta and Dr. Rakesh Kakkad, to please present. नहीं पार्टी रखनी है। आओ जी डॉक्टर कक्कड़ साहब, M.R. गुप्ता जी। नाली आ जाओ। So since the certificates are not signed by the scientific authority, so we will just acknowledge the presence and have a photograph here from all the dignitaries, starting from our organizing committee, Dr. K.K. Noria. Photo ले चले यार, certificates ਅਸੀਂ ਬਾਅਦ ਚ ਦਵਾਂਗੇ। So we are 6 people in organizing committee under the leadership of Dr. D.K. Singh. He is indisposed, he is sick, so he has his blessings for the committee. Dr. K.K. Noria, Dr. K.K. Goyal, Dr. M.R. Gupta, Dr. Rakesh Kakkad, Dr. Sonia Gupta. Dr. Meghna Gupta. And me as organizing secretary. Now I'll invite the members of ਹਜੇ ਰੁਕ ਜਾਓ ਜੀ ਤੁਹਾਡੇ ਤੋਂ ਤਾਂ 1 ਘੰਟਾ ਕਰਾਣਾ ਜੀ ਫਿਰ ਤੁਹਾਡਾ ਭਾਸ਼ਣ ਕਰਾਣਾ ਦੁਬਾਰਾ ਤੋਂ Now our organizing committee, the non-medical organizing committee, who are here from 7 in the morning till the end of the function. So I invite Mr. Anil Pola, my childhood friends, as well as he's a great organizer. Mr. Ashwini Malhotra, he always ducks out when we announce his name, and Mrs. Vinita Malhotra, Mr. Sukhmeet Paseen, Mr. Nishu, Ashu, Mr. Rajinder Setia, please. So these are the people, 2, 3, Ashwini aaja yaar, aaja fatafat. Mr. Tony from Seppel Hotel. ਇਹ ਵੀ ਆਂਦਾ ਨਹੀਂ ਫਿਰ ਕਹੂਗਾ ਯਾਰ ਮੈਨੂੰ ਸਰਟੀਫਿਕੇਟ ਕਿਉਂ ਨਹੀਂ ਦਿੱਤਾ ਟੋਨੀ ਆ ਜਾ ਯਾਰ ਅੰਦਰ ਬੈਠਿਆ ਕਰ ਤੂੰ So all the facility you see here, he is the owner. ਤੇ ਚਾਰੇ ਪਾਰਟਨਰਸ ਤੋਂ ਸਭ ਤੋਂ ਜ਼ਿਆਦਾ ਵਧੀਆ ਬੰਦਾ ਹੈ ਇਹ ਜਿਹਦੇ ਨਾਲ ਅਸੀਂ ਨੈਗੋਸ਼ੀਏਟ ਕਰ ਸਕਦੇ ਹਾਂ ਐਂਡ ਹੀ ਹੈਲਪਸ ਅਸ ਟੂ ਦੀ ਐਕਸਟੈਂਟ ਕਿ ਡਾਕਟਰ ਸਾਹਿਬ ਆਹ ਬਿੱਲ ਬਣਾਤਾ ਜੀ ਜਿੰਨੇ ਮਰਜ਼ੀ ਦੇ ਦਿਓ ਆਈ ਇਸ ਵਾਰੀ ਕਰਨਾ ਐਂਡ ਹਿਸ ਸਨ ਇਜ਼ ਦੇਅਰ ਇਨ GMC ਚੰਡੀਗੜ੍ਹ ਡਿਪਾਰਟਮੈਂਟ ਆਫ ਸਰਜਰੀ ਸੋ ਜਿੱਥੇ ਕਿਤੇ ਗੱਲ ਹੋਵੇ ਉਹਦੀ ਸਿਫਾਰਿਸ਼ ਕਰ ਦਿਓ ਜੀ So Ashwini Malhotra, Mr. Nishu, these two people are the pillars. Kal bahut zyada kam siga. We had to go to the airport, come here. Uron di fir Dr. Patia sahab tusi bhi aa jao. So Dr. Mukesh Patia for Patia Centers. ਜਿਹੜੀ book ਪੜ੍ਹਦੇ ਆ ਸਾਰੇ PGs ਉਹ ਸਰਦੀ ਹੁੰਦੀ ਆ ਉਹ So most ਹੋਰ ਕੌਣ ਰਹਿ ਗਿਆ ਆਗੇ ਸਾਰੇ ਇਹ ਬਾਅਦ ਚ ਬੁਲਾਉਂਦਾ ਸੁਖਮੀਤ ਕਿੱਥੇ ਰਹਿ ਗਿਆ ਉਹ ਯਾਰ ਉਹਨੂੰ ਬੁਲਾ ਲਓ ਸੁਖਮੀਤ 2-4 ਹੋਰ ਫੋਟੋਆਂ ਖਿੱਚ ਲਾ ਯਾਰ ਵਧੀਆ ਵਧੀਆ ਸਭ ਤੋਂ ਇੰਪੋਰਟੈਂਟ ਬੰਦੇ ਆ ਇਹ नहीं सर सब तो इम्पोर्टेंट बंदे हैं जी आई रियली थैंक माई नॉन मेडिकल ऑर्गेनाइजिंग कमेटी So he is Sukhmeet Paseen, Principal Correspondent Tribune. But he is helping us a lot. Thank you very much. Now I invite the pharma people who have 4 companies who are there to support us for last 12 years and we request you to give us more sponsors ਕਿਉਂਕਿ ਸਾਡੇ ਕੋਲ ਪੈਸੇ ਘਟ ਜਾਂਦੇ ਆ ਯਾਰ ਥੋੜੇ ਜਿਹੇ। ਸੋ ਇੰਟਾਸ, ਟੀਮ ਫਰੋਮ ਇੰਟਾਸ, ਟੀਮ ਫਰੋਮ ਮਾਈਕਰੋ। ਜਿੰਦਲ ਸਾਹਿਬ ਨੋਟ ਕਰ ਲਓ, ਮੈਂ ਨੋਟ ਕਰਾ ਦਿੰਦਾ ਨਾ ਸਿੱਧਾ ਕਹਿਣ ਨਾਲੋਂ। ਹਾਂ, ਟੀਮ ਫਰੋਮ USV, team from Torrent, and now I invite Mr. Jaswant, Mr. Jagdev, and Gary also. So what you see here, the audio visual, the daily mails, the online registration is by Mr. Gary, and most humble person I have ever met as far as audio visual aid is concerned, always ready. Jaswant nahi aaya. And I am thankful to Dr. Kakkad, who was instrumental in making me meet Mr. Jaswant. He is not here. So he puts up the screen and all the things. Again, every time I say कि जसवंत आ करना यार हो जाऊगा सर, and it is done. पिछली बारी ਅਸੀਂ ਸਕਰੀਨ ਲਗਾਈ ਤੇ ਉਹਦੇ ਤੇ ਸਪੌਟ ਸੀਗੇ ਕਾਲੇ ਕਾਲੇ, ਉਹ ਜਿਵੇਂ ਮੌਕੇ ਜੇ ਹੁੰਦੇ ਉਵੇਂ ਆਉਂਦੇ ਸੀਗੇ, ਤੇ ਮੈਂ ਕਿਹਾ ਯਾਰ ਜਸਵੰਤ ਕੈਸੀ ਸਕਰੀਨ ਲਾਤੀ, ਇਹ ਤਾਂ ਪਤਾ ਨਹੀਂ ਲੱਗਣਾ ਵੀ ਫੁੱਲ ਸਟਾਪ ਹੈ ਕਿ ਉਹ ਹੈ। ਕਹਿੰਦਾ ਸਰ 15 ਮਿੰਟਾਂ 'ਚ ਕਰਾ ਦਿੰਦਾ ਮੈਂ, 15 ਮਿੰਟਾਂ 'ਚ। ਸੋ ਕਮਿਊਨੀਕੇਟ ਕਰ ਦਿਓ ਜਗਦੇਵ ਜੀ ਜਸਵੰਤ ਨੂੰ ਕਿ ਤੁਹਾਡੀ ਤਾਰੀਫ ਹੋ ਗਈ ਸੀਗੀ। ਸੋ ਵੀ ਆਰ ਰੀਅਲੀ ਥੈਂਕਫੁਲ ਐਂਡ ਵੀ request pharma to increase their support so that we can have more of national faculty here. So this time the Bathinda flight was cancelled, 4 flights were cancelled out of 6 what we booked. So we were unable to host 10 national faculties from outside, and next time I have decided not to book. मैं पूछ लिया करना कि सर ट्रेन ते आ सकते हैं तो आ जाओ जी, फ्लाइट ते तो बड़ा पंगा है। So thank you very much for all the So I can see Dr. Gill here. Please Dr. Gill. Gill साहब आ जाओ जी, अगे आ जाओ। So we are honored with your presence. अगे उरे आ जाओ जी। ना 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 ना, आए तक काम नहीं चलना। Please come with Dr. Clare. So really great to have you here, sir. So thank you very much, and make efforts to promote MAPICON for next year. Thank you. So now I'll request, होता नहीं को रह गया. Now I'll request Dr. Clare, Dr. Baldev and Dr. Karamveer to address the audience for 5-7 minutes. ये अलग तो है सर थोड़ा address. हाँ, नहीं दिल दी गल तो हमेशा रहूगी ही.
I think it's a great occasion, great pleasure. For me, it's always some or the other. I get very happy to come to Bathinda. क्योंकि Bathinda में patients भी बड़े हैं. अब तो खैर local facility हो गई. You know, I've been associated with Dr. Noria for last donkey years, and there was a time when there was no facility at all. So it's always a pleasure, and I think people like Vittal who are carrying on the job of the CMEs is very important. Unless you have the knowledge, latest updates, you know, you cannot deliver your best to the patient. It's not only our moral duty to be updated about medical knowledge and expertise. It is also legal issue. You know, if you don't know what is happening in the world. For example, I tell a small example. If somebody has a myocardial infarction, he's stable, but his ejection fraction is 30%. Okay. Now the guidelines are very clear that any person who has got EF below 35%, he needs ICD to prevent sudden cardiac death. So if a doctor does not advise him and this fellow dies suddenly, the family can sue the doctor didn't advise us. So अगर अफोर्ड नहीं भी कर सकता फिर भी आपका फर्ज बनता है कि बताओ कि ये ऐसा होता है, पर अभी भी नहीं बताते लोग because they don't have the knowledge. So knowledge gap is also a system. So great. Thank you very much, Vittal.
Thank you, sir, for your encouraging words. Dr. Baldev Singh Aulak, please.
I don't know, ਵਿਤਲ ਨੇ ਮੈਨੂੰ ਸਡਨਲੀ ਬੁਲਾ ਲਿਆ ਸਾਡੇ ਇਹ ਮੇਰੇ ਤੋਂ ਸੀਨੀਅਰ ਹੁੰਦੇ ਸੀਗੇ ਲੇਕਿਨ ਸਾਡੀ ਦੋਸਤੀ ਇੱਦਾਂ ਸੀ ਜਿੱਦਾਂ ਕਲਾਸ ਫੈਲੋ ਦੀ ਹੁੰਦੀ ਆ ਜਿੱਦਾਂ ਇਹਨਾਂ ਦੱਸਿਆ ਸੀ ਪਲਸ ਟੂਰਨਾਮੈਂਟ ਤੇ ਜਾਣਾ ਦਿੱਲੀ ਜਾਣਾ ਤੇ ਇਹਨਾਂ ਨੇ ਇੱਕ ਨਾ ਨਾਰਾ ਲਾਣਾ ਲੋਕਾਂ ਨੂੰ ਫਸਾਉਣ ਵਾਸਤੇ ਕਾਕੀਨਾਡਾ ਜਿੰਦਾਬਾਦ ਸ਼ਰਾਰਤਾਂ ਆਪ ਕਰਦੇ ਨਹੀਂ ਆ ਤੇ ਕਾਲਜ ਕਾਕੀਨਾਡਾ ਦਾ ਕਿਹੜਾ ਕਾਕੀਨਾਡਾ ਹੀ ਸੀ ਨਾ ਜੀ ਕੁਛ ਹਨ ਉਹਨਾਂ ਦਾ ਨਾਮ ਲੱਗ ਜਾਣਾ ਸਟੂਡੈਂਟ ਉਹਨਾਂ ਦੇ ਉਹ ਸਸਪੈਂਡ ਹੋ ਜਾਣੇ ਕਿ ਇਹਨਾਂ ਨੇ ਜੀ ਸਾਰਾ ਇੱਥੇ ਰੌਲਾ ਪਾਤਾ ਨਾਓ ਦੇ ਆਰ ਡਿਬਾਰਡ ਫਰਮ ਪਾਰਟਿਸਿਪੇਟਿੰਗ ਇਨ ਪਲਸ ਟੂਰਨਾਮੈਂਟ ਇਨ ਦਿੱਲੀ ਤੋ ਇਟ ਵਾਜ਼ ਲਾਈਕ ਦੈਟ ਅਸੀਂ ਟ੍ਰੇਨ 'ਤੇ ਵੀ ਬੜਾ ਸਫ਼ਰ ਕਰਨਾ ਕਿਉਂਕਿ ਮੈਂ ਵੀ ਬਠਿੰਡੇ ਤੋਂ ਅੱਗੇ ਮੇਰਾ ਪਿੰਡ ਹੈ ਇੱਥੇ ਮਲੋਟ ਦੇ ਨੇੜੇ ਤੇ ਅਸੀਂ ਕਈ ਵਾਰੀ ਬੜੀਆਂ ਯਾਦਾਂ ਆਉਣੀਆਂ ਇਹਨਾਂ ਦੀ ਸਿਸਟਰ ਮੇਰੀ ਕਲਾਸ ਫੈਲੋ ਆ ਸਾਡਾ ਉਹ ਰਿਸ਼ਤਾ ਵੀ ਇੱਕ ਹੋਰ ਹੈਗਾ ਹੈ ਨਾ ਤੇ ਬੜੀਆਂ ਐਸੀਆਂ ਗੱਲਾਂ ਪਰ ਮੈਂ ਤੇ ਡਾਕਟਰ ਕਰਮਵੀਰ ਰਸਤੇ 'ਚ ਆਉਂਦੇ ਅਸੀਂ ਗੱਲ ਕਰ ਰਹੇ ਸੀ ਕਿ ਡਾਕਟਰ ਵਿਤਲ ਦੀ ਬੜੀ ਵੱਡੀ ਐਫਰਟ ਹੈ ਜੀ ਟੂ ਆਰਗੇਨਾਈਜ਼ ਐਨੀ ਕਾਨਫਰੰਸ ਹੀ ਰਾਈਟਲੀ ਸੈਡ ਟੂ ਗੈਟ ਫੰਡਸ ਫॉर द conference now it is a big task even if we organize sitting in central place in Ludhiana it is very very difficult company people stop coming and meeting you when they see that you are going to host one conference it is really credit goes to him that he has wholeheartedly carried on this legacy and this is now 12th and we wish this should touch at least 100th. So thank you so much for calling us and we are really privileged. ਬਠਿੰਡੇ ਆਣਾ ਹਮੇਸ਼ਾ ਹੀ ਆਨਰ ਰਹਿੰਦਾ ਜੀ ਪਿੱਛੇ ਜੇ ਅਸੀਂ ਸਾਈਕਲ ਰੈਲੀ ਵੀ ਕੀਤੀ ਇਕੱਠਿਆਂ ਨੇ ਬੜੀ ਆਰਗਨ ਡੋਨੇਸ਼ਨ ਤੇ ਹੋਰ ਬੜੇ ਕੰਮ ਕਰਦੇ ਨੇ ਅਸੀਂ ਤੁਹਾਨੂੰ ਸਾਰਿਆਂ ਨੂੰ ਇਨਵਾਈਟ ਕਰਦੇ ਹਾਂ ਪਰ ਤੁਸੀਂ ਸਾਰੇ ਬਿਜ਼ੀ ਹੁੰਦੇ ਹੋ ਫਿਰ ਅਸੀਂ ਕੰਮ ਕਰਕੇ ਚਲੇ ਜਾਂਦੇ ਹਾਂ ਵੀ ਰੀਅਲੀ ਰਿਸਪੈਕਟ ਆਲ ਆਫ ਯੂ ਬਿਕਾਜ਼ ਦਿਸ ਇਜ਼ ਮਾਈ ਕਾਈਂਡ ਆਫ ਹੋਮ ਟਾਊਨ ਕਿਉਂਕਿ ਮੈਨੂੰ ਲੱਗਦਾ 15-20 ਤਾਂ ਮੇਰੇ ਕਲਾਸ ਫੈਲੋ ਇੱਥੇ ਹੋਣੇ ਆ ਮੇਰਾ ਬ੍ਰਦਰ ਵੀ ਇੱਥੇ ਸੈਟਲ ਹੈ ਮੇਰਾ ਕਿਉਂਕਿ ਪਿੰਡ ਨੇੜੇ ਆ ਪਿੰਡ ਦੇ ਸਾਡੇ ਮੇਰੇ ਖਿਆਲ 'ਚ ਕਾਫੀ ਫੈਮਿਲੀ ਮੈਂਬਰਸ ਕਹਿੰਦੇ ਜੀ ਬਠਿੰਡਾ ਵੱਡਾ ਸ਼ਹਿਰ ਹੈ ਅਸੀਂ ਮਲੋਟ ਨਹੀਂ ਬਠਿੰਡੇ ਸੈਟਲ ਹੋਣਾ ਸੋ ਆਈ ਹੈਵ ਦਿਸ ਇਜ਼ ਅ ਹੋਮ ਟਾਊਨ ਐਂਡ ਇਟ ਇਜ਼ ਆਲਵੇਜ਼ ਅ ਵੈਰੀ ਵੈਰੀ ਗੁੱਡ ਫੀਲਿੰਗ ਕਿ ਜਦੋਂ ਵੀ ਲੁਧਿਆਣੇ ਇੱਥੇ ਬਠਿੰਡੇ ਸਾਨੂੰ ਕੋਈ ਬੁਲਾਵੇ ਤੇ ਹਾਂ ਯਾਰ ਅਸੀਂ ਜਾਣਾ ਹੀ ਜਾਣਾ ਕਰਮਵੀਰ ਦਾ ਮੈਨੂੰ ਫੋਨ ਆਇਆ ਬਲਦੇਵ ਆਪਾਂ ਇਕੱਠੇ ਚੱਲੀਏ ਮੈਂ ਕਿਹਾ ਵਾਇਨਾਡ ਇਹ ਤਾਂ ਹੋਰ ਵੀ ਵਧੀਆ ਹੋ ਗਿਆ ਸੋ ਵੀ ਟਰੈਵਲ ਟੁਗੈਦਰ ਥੈਂਕ ਯੂ ਆਲ ਆਫ ਯੂ Dr. Vittal da hai hai, but all of you for really giving us so much affection and love. We keep seeing when we are sitting in Ludhiana. Thank you so much.
Thank you, Dr. Baldev. It is always a pleasure to be with him during the college also, after the college also, because that refreshes your mind. ਸਾਨੂੰ ਨਾ ਲੋਕ ਬੁਲਾ ਕੇ ਲੈ ਜਾਂਦੇ ਸੀ ਕਿ ਸਾਨੂੰ ਚੀਅਰ ਕਰੋ ਜੀ ਕੋ ਸੀਟੀ ਸੂਟੀ ਬਹੁਤ ਵਧੀਆ ਮਾਰਦੇ ਸੀ ਅਸੀਂ ਸਾਡੇ ਬੰਦੇ ਵੀ ਤਕੜੇ ਹੁੰਦੇ ਸੀ ਵੀ 6 ਘੰਟੇ ਰੌਲਾ ਪਾਈ ਜਾਣਾ ਤੇ ਬਿਲਕੁਲ ਠੀਕ ਹੈ ਜਦੋਂ ਸ਼ਰਾਰਤਾਂ ਕਰਨੀਆਂ ਉੱਥੇ ਪੂਲ 'ਤੇ ਚਲੇ ਜਾਂਦੇ ਸੀ ਤਾਂ ਪੂਲ 'ਤੇ ਉਹ ਵੜਨ ਨਹੀਂ ਦਿੰਦੇ ਸੀ ਕਿਉਂਕਿ ਉਹ ਕਹਿੰਦੇ ਸੀ ਕਾਸਟਿਊਮ ਲਿਆਓ ਤੇ ਸਾਡੇ ਵਾਲੇ ਮੁੰਡੇ ਕਹਿੰਦੇ ਸੀ ਕਾਸਟਿਊਮ ਸਾਡੇ ਕੋਲ ਹੈ ਹੀ ਨਹੀਂ ਉਹ ਦੂਜਾ ਵੀ ਲਾ ਦਿੰਦੇ ਸੀ ਤੇ ਮਾਰਦੇ ਸੀ ਛਾਲਾਂ ਤੇ ਉੱਥੋਂ ਦੂਜੇ ਦੇਖ ਕੇ ਭੱਜ ਜਾਂਦੇ ਸਾਡੀ ਤਾਂ ਰੈਗਿੰਗ ਰੂਗਿੰਗ ਹੋਈ ਵੀ ਹੁੰਦੀ ਸੀ ਤਾਂ ਕੋਈ ਇਨਹੀਬਿਸ਼ਨ ਨਹੀਂ ਸੀ ਕਿ ਐਂ ਵੜ ਜਾਓ ਭਾਈ ਤੇ ਫਿਰ ਇਹਦੀ ਗੱਲ ਠੀਕ ਆ ਅਸੀਂ ਉੱਥੇ ਕਹਿੰਦੇ ਕਾਕੀਨਾਡਾ ਕਾਲਜ ਵਾਲੇ ਆ ਅਸੀਂ ਹਿੰਦੀ 'ਚ ਬੋਲਣਾ ਟੁੱਟੀ ਫੁੱਟੀ 'ਚ ਤੇ ਉਹ ਸਸਪੈਂਡ ਹੋ ਜਾਂਦੇ ਸੀ ਅਸੀਂ ਭੱਜ ਜਾਂਦੇ ਕਹਿੰਦੇ ਕੌਣ ਸੀ ਜਦੋਂ ਇਨਕੁਆਇਰੀ ਹੁੰਦੀ ਕਹਿੰਦੇ ਕਾਕੀਨਾਡਾ ਮੈਡੀਕਲ ਕਾਲਜ ਵਾਲੇ ਸੀਗੇ ਚਲੋ ਜੀ ਉਹ ਸਸਪੈਂਡ ਹੋ ਜਾਂਦੇ ਸੀਗੇ So rightly said, it is refreshing memories. And now I'll request Dr. Karamveer Goyal. He is instrumental in getting us the approval for awards 2 months earlier than the yesteryears. ਇਸ ਵਾਰੀ ਅਸੀਂ ਰਿਕੁਐਸਟ ਕੀਤੀ ਕਿ ਸਰ ਤੁਸੀਂ ਜਲਦੀ ਕਰਾ ਦਿਓ ਹੀ ਇਜ਼ 1 year senior to me ਅਸੀਂ ਹਾਊਸ ਜੋਬ ਇਹਨਾਂ ਦੇ ਅੰਡਰ ਕੀਤੀ ਹੈ ਪੀਜੀ ਸੀਗੇ ਤੋ ਵੀ ਹੈਡ ਅ ਵੈਰੀ ਕਲੋਜ਼ ਰਿਲੇਸ਼ਨਸ਼ਿਪ ਅਕੈਡਮਿਕਲੀ ਆਲਸੋ and after that because of PMC and promotion of MAPICON so this year we had 150 online registrations this is just because of his efforts ਕਿ ਇਹਨਾਂ ਨੇ ਪ੍ਰੈਸ਼ਰ ਪਾ ਕੇ ਸਾਨੂੰ 2 ਮਹੀਨੇ ਪਹਿਲਾਂ ਕ੍ਰੈਡਿਟ ਆਰਸ ਇਸ਼ੂ ਕਰਵਾਤੇ ਤਾਂ ਅਸੀਂ ਐਡਵਰਟਾਈਜ਼ ਕਰ ਸਕੇ। ਅਤੇ ਨਾਓ ਦੀ ਥਿੰਗਸ ਆਰ ਲਾਈਕ ਦੈਟ ਕਿ 3 ਦਿਨ ਸਾਡੇ ਮੋਰ ਦੈਨ 750 ਡੈਲੀਗੇਟਸ ਹੈਗੇ YouTube 'ਤੇ ਜੁੜੇ ਹੁੰਦੇ ਆ, ਅਤੇ 150 ਡੈਲੀਗੇਟਸ ਹੈਗੇ ਸਾਡੇ ਔਨਲਾਈਨ ਰਜਿਸਟਰਡ ਹੈ ਜਿਨ੍ਹਾਂ ਨੂੰ ਪੰਜਾਬ ਮੈਡੀਕਲ ਕਾਊਂਸਲ ਨੇ ਸਰਟੀਫਿਕੇਟਸ ਇਸ਼ੂ ਕੀਤੇ ਹੈ। ਸੋ ਆਲਮੋਸਟ 900 ਆਡੀਅנס ਹੈਗੀ ਹੈ। ਤੋ ਦੈਟ ਵਾਜ਼ ਦੀ ਰੀਜ਼ਨ ਵੀ ਕਾਸਟ ਕਟਿੰਗ ਵੀ ਸੀਗਾ ਕਿ ਵੱਡੇ ਹਾਲ ਤੋਂ ਅਸੀਂ ਛੋਟੇ ਹਾਲ 'ਤੇ ਆ ਗਏ ਕਿ ਅਸੀਂ ਔਨਲਾਈਨ ਪ੍ਰਮੋਸ਼ਨ ਹੋ ਗਈ। ਡਾਕਟਰਸ ਜ਼ਿਆਦਾ ਔਨਲਾਈਨ ਦੇਖਣਾ ਪਸੰਦ ਕਰਦੇ ਆ, ਆਫਲਾਈਨ ਉਹ 1 ਦਿਨ 2 ਦਿਨ 3 ਦਿਨ ਆ ਕੇ ਚਲੇ ਜਾਂਦੇ ਆ। ਸੋ ਥੈਂਕ ਯੂ ਡਾਕਟਰ ਕਰਮਵੀਰ, ਐਂਡ ਵੀ ਆਰ ਰੀਅਲੀ ਓਬਲਾਈਜ਼ਡ ਅਤੇ ਐਕਸਪੈਕਟ ਕਿ ਹੁਣ ਮੈਂ ਦਸੰਬਰ ਦਾ ਟਾਈਮ ਦਿੱਤਾ ਹੈ ਕਿ ਦਸੰਬਰ 'ਚ ਅਸੀਂ ਨੈਕਸਟ ਕਾਨਫਰੰਸ ਵਾਸਤੇ ਸਾਡੀਆਂ 100 ਰਜਿਸਟ੍ਰੇਸ਼ਨਸ ਆਲਰੇਡੀ ਹੋ ਗਈਆਂ। ਤੋ ਨੈਕਸਟ ਈਅਰ ਵਾਸਤੇ ਅਸੀਂ ਤੁਹਾਨੂੰ ਰਿਕੁਐਸਟ ਕਰਾਂਗੇ ਕਿ ਇਸ ਵਾਰੀ ਹੋਰ ਜਲਦੀ ਦਵਾ ਦਿਓ ਤਾਂ ਕਿ ਅਗਲੇ ਵਾਰ ਅਸੀਂ 500 ਔਨਲਾਈਨ ਰਜਿਸਟਰ ਟਾਰਗੇਟ ਕਰੀਏ ਫਰੋਮ ਆਲ ਓਵਰ ਇੰਡੀਆ। ਨਾਓ ਪੀਪਲ ਹੈਵ ਰਜਿਸਟਰਡ ਫਰੋਮ ਆਲ ਓਵਰ ਇੰਡੀਆ। ਡਾਕਟਰ ਕਰਮ।
Very good morning to all of you, respected Dr. Claire, Dr. Baldev, Dr. Noria, dignitaries in the audience, and of course, my dear friend Dr. Vitul. I congratulate you all for organizing such a wonderful conference here. As we were discussing earlier also, Dr. Sahab bol rahe sige, such Dr. Claire was saying that such conferences are very important for the updating of the knowledge, for our own benefit, for the patient benefit, for ethical practice, and as well as for our own safety as from the medico-legal point of view also. So, Dr. Vitul has been doing a great job along with his team. Every year I am invited here. This time I am coming, I am representing from Punjab Medical Council, and as already announced, declare 16 credit hours for this conference. Sir, Dr. Claire was saying that it's very important to be updating yourself, and in the earlier Dr. Jindal was quoting that cardiology is a very difficult branch. So I will just take a few minutes. What we see in Punjab Medical Council day at every meeting, we have number of complaints, genuine ones, non-genuine ones. But why I am trying to take a few minutes from you is because we should be very, very responsible in our, I will say, dialect or meeting with the patients or patient attendants when we are counseling them or seeing any reports. I'll just quote you the latest case which was there with me in Ethical and Disciplinary Committee. I won't the name, but it was from this town only. Patient area ACS de vich hai acute coronary syndrome. He's landing up in the emergency in the hospital. Pain chest hai ECG kiti evolving STEMI hai. They do a angiography. 100% LED blocked hai, 70% circ blocked hai. Severe LV systolic dysfunction है, 25% EF है, IABP लगाना पे उन्होंने, उदी angioplasty किती है, patient ultimately lands up in recovery, stabilizes, and then goes into VT. There is a cardiac arrest, revived. He had, I think, maybe cerebral anoxia, had some features and all. Ultimately, patient was referred to a higher institution. Maybe he was saved or not, that was not there in the file. Now, why I am telling you the whole story is the certain doctor relation of that patient or attendant in a very irresponsible statement tells them ਤੁਹਾਡੇ patient ਦਾ ਕੁਝ ਨਹੀਂ ਸੀ ਤਾਂ ਉਹਨਾਂ ਨੇ ਪੈਸੇ ਬਣਾਉਣ ਵਾਸਤੇ ਐਂਜੀਓਗ੍ਰਾਫੀ ਐਂਜੀਓਪਲਾਸਟੀ ਕਰਤੀ. You see, just one irresponsible statement of a friendly so-called doctor spoiled the whole game, whole show. Patient the 100% LED blocked है, 70% circ blocked है, severe LV systolic dysfunction है, 25% EF है, IAVP लाना पे उन्होंने, and he is saying कि थोड़े पैसे बनाने वास्ते उन्होंने करता. I had to spend almost 1 hour because my seat over there is a sort of semi-judge with a quasi-judicially powers and all. Whatever verdict I will give, it will go to the High Court and ultimately Consumer Court also, and give the same decision which I give will be replicated in the court and as well as in the Consumer Court. I had to spend 1 hour with the patient and attendants. कि मैंने दोस्तों की everything. I'm not a doctor, the friend, or I don't know the name of the doctor against whom the complaint is. But ultimately he had a lawyer with him कि जी doctor the doctor दी favor ही करूँगा. So what I mean to say is, please, while doing your day-to-day practice, wherever you are practicing, private practice, medical college, corporate hospital, be very, very affirmative and responsible in your statement dealing with the patients and patient attendants. So, because of such problems, I land up with so many complaints sitting with me, and which I have a very tough time in saving my doctors. On the other hand, certain doctors are there, I will not name again, a doctor doing a job, cut on the little finger, making it dangerous to life, or this thing on the letter pad also. Against whom he has made, they were government employees, they were jailed for 6 months, he lost the job, you see, and ultimately the case lands up with me in the medical council. You have to punish the culprit doctor just because he made us lose our job and made it suspended. So please, such conferences, again, I will say, are again, you will say, leading us to do our ethical practice in discipline and to be updated with the latest things, as Sir Dr. Clare was saying. Keep on going, Dr. Bitul, with such conferences and educating all the doctors in our fraternity and the, I will say, whole state. Not taking much of your time, once again, again congratulate and give you best wishes for the wonderful rest of the conference. Thank you very much.
Thank you, Dr. Karamveer. So it is real great pleasure to have your support. So, and it is assured for next years also. Yes.
Only one minute, sir.
Come, please.
Dear friends, most of the faculty which we are here, we are being invited by the conferences for the faculty. But I can say with a great proud, the best hospitality that I have ever received here is in this center. Congratulations to Dr. Vittul and the entire organizing team. This is not only my statement, it's by all the faculty who have come from far-off cities. Thank you very much for your kind hospitality and all the best. Thank you very much.
Thank you, sir. So I take the opportunity to welcome most, inspiring, motivating figure with Olympic gold medal. Asita Deta ji. Madam Avneet Sidhu. So we invited her as a special guest, as a motivating figure. Inspiring ਤੇ motivating ਤਾਂ ਹੈਗੇ ਹੋਣਾ ਜੀ. ਤੁਹਾਡੇ ਮੈਡਲ ਜਿੱਤਣ ਤੋਂ ਬਾਅਦ ਕਿੰਨੇ ਬੱਚੇ ਕਰਨ ਲੱਗ ਗਏ ਸ਼ੂਟਿੰਗ, and they have gone far ahead in international standards, and we are really thankful to have you here. And I take the opportunity to acknowledge the contribution of 2 more delegates. So I invite Dr. Clare, Ms. Sidhu, Dr. Baldev Aulak, Sir Tusi. So the most dedicated delegate, and you find him 9 dot in the morning till all the lectures are finished from day 1 to day 4. Koi guess? Dr. Pramod Goyal, none other than principal of Adesh Medical College. ਆਪਾਂ ਸੋਚ ਲਈਏ ਨਾ ਕੋਈ ਵਿਹਲਾ ਬੰਦਾ ਹੋਊਗਾ ਯਾਰ, ਉਰੇ ਬ੍ਰੈਕਫਾਸਟ ਕਰਨ ਆ ਜਾਂਦਾ, ਲੰਚ ਕਰ ਲੈਂਦਾ, ਉਰੇ ਸੌਂ ਜਾਂਦਾ, ਚਲੋ ਏਸੀ 'ਚ ਬੈਠੇ ਆ, ਚਲਾ ਜਾਂਦਾ. ਸੋ ਹੀ ਇਜ਼ ਸੋ ਡੈਡੀਕੇਟਿਡ ਪਰਸਨ that he is here. Sir, photo vaste ji. And next I invite Mr. Manoj. So he is with Omron. He is scientific. Sir, ek minute khad jo ji, koi gal nahi. Scientific aid. We conducted a few studies, grand studies on home blood pressure monitoring, and he has come all the way from Bangalore to attend this conference. and apprise the delegates about ongoing study which is on home blood pressure monitoring. Thank you, Manoj, for coming. Thank you very much. Thank you, ma'am. Please. And now I'll request Fulkari. Our guest, Dr. Kaler, Dr. Baldev Aulak, Dr. Karamveer, to acknowledge the presence of Ms. Sidhu. Sir, I request Dr. Rajesh Jindal and Dr. Gill to please come and have a photograph. So all inspiring figures together. So thank you very much. Thank you. So I'll request you, ma'am, to please say a few words to motivate doctors for exercise, you know, to go for sports, ताकि थोड़े ये टिड्डियाँ घट जान जी.
Esteemed guests, doctors, and all the other dignitaries, first of all, a very good afternoon to all of you. I am also truly honored to be here today, to be honoring you people. Dr. Bitul came to me that we'll be facilitating our doctors and we want you there. So it's a proud privilege for me also to honor those who save lives, who heal people. And I feel equally grateful and blessed to be here. While I was coming from home right now, I was thinking that we have a lot of similarities also. I'm a police officer, for introducing myself. Apart from being a sports person, I'm serving as AIG Intelligence in Bathinda right now. So I found a lot of similarities. You heal people, we also heal people, but we heal society. We protect people from, you protect people from diseases, and we protect people from crime. And you work with stethoscopes, we work with handcuffs. So I think we have a lot of similarities. We are working, our passion for working is same, our purpose is same, to make the society a better place. You want to make it disease-free, you want to make it healthy, we want to make it crime-free and mentally healthy, and a society which thrives and lives. So as I feel proud to honor you here and be a part of you, all the doctors, I must say that there is also another common thing, being a doctor and a police officer, which is common for us. That is the integrity which people expect from us. The integrity with which we work in our respective fields, which is very, very important, and which somehow, in today's time, we feel some of us are losing, whether it's any profession, I must say. I'm not pointing anyone, just talking generally. So I really feel that we need to stick to the professions which we once chose, because I remember even long back, 25 years ago, there was a time when I was also pursuing medicine to be a doctor. No offense, but I'm thankful I'm not one today, because that was not my cup of tea. So I'm very glad in the profession which I'm working today. But I think the passion with which we chose our professions, somehow in the long run of life, I believe we tend to lose it, or we tend to forget it. So I just feel that every single day we need to remind ourselves. Most of you are so much senior to me, but I think from whatever experience I have, I can only say that every day I feel honored and grateful to be where I am today. And so I think it stands true for all of you also. But every day we need to remind ourselves also, why are we here? Why are we sitting on the chair? Why are we wearing this uniform? You wear white coats, we wear khaki. So the purpose is same, and let's not forget the purpose we are here for. And as doctor said, motivating for sports, I think many of you are here are already quite active. I know Dr. Jindal, and many of you are quite active, who maintain a very fit and healthy lifestyle. But yes, it feels very awkward, you know, telling doctors to be fit and healthy. I mean, yeah. Yeah, yeah. Our memory needs refreshing also. Yeah. So I think, you know, we are so busy because both our professions are same. We have to be available 24/7. So I also felt this when I was working as SSP in 3 districts. I ignored my health like anything. So I put on a lot of weight during those 2 years. So I think we tend to forget ourselves that our health is also equally important. So I think the best motivation for us is that if we have to do justice to our job, first we have to maintain our own health, we have to be happy ourselves, then only we can give happiness, we can heal others if we are healed inside, whether it's a physical healing or mental healing. So I think this is the best motivation, because if we are not feeling good, then we can't do justice to our jobs. So I believe this stands true for all of us, and this is the best motivation which drives me also, because I felt that I ignored my health and that affected my working also, my policing also. So I think ये सारे ਲਈ true है कि ਜਦੋਂ ਆਪਾਂ ignore कर ਦਿੰਦੇ हैं, so it's important कि हर रोज़ ਆਪਾਂ ਨੂੰ याद रखना है जो what we are teaching others, what we are giving others, we have to take care of us also. Self care, I think पिछले ज़माने में self care, I think concept ना ਹੁੰਦਾ नहीं सी use, but in today's generation we give a lot of importance to self care. So it's very, very important. If we are able to take care of ourselves, then only we can take care of others. So I must motivate everyone to doctors die koi run marathon वगैरह करा लेने हैं पुलिस वाले नाल मिलके. So that would be really good. And with these words, I express my wholehearted gratitude to all of you. As a common citizen also, I really respect and admire your profession, the work which you do for society, and I just wish that you keep doing this noble work with all the integrity and professionalism. Thank you so much.
Uneet, there are more similarities between police and doctors. Both are 24/7 job. It's a stressful job. Believe me, because I have relations, I have friends who are in police. I told you Dinkar Gupta is a good friend of mine. और मैं समझता हूँ कि पुलिस पे हमारे से ज़्यादा स्ट्रेस है. I tell you why. कि nobody in the whole world, no politician, including any chief minister or Modi or anybody, can ever tell me कि इस बंदे को मार दो. कभी नहीं बता सकते ना, कह नहीं सकते. इनको तो बेचारों को ये भी देखना पड़ता है कि ना इट्स ए रियलिटी कि पुलिस वालों से गलत काम भी पॉलिटिशियन कराते हैं जो नहीं करना चाहते, उनकी आत्मा नहीं चाहती. अंदर कर दो, ये कर दो, वो कर दो. बड़ा स्ट्रेसफुल है. आई एग्री विद यू. बट द सेकंड थिंग विच शी सेड वेरी नाइसली इज कि हमारे कंट्री में यू नो वी हैव टू ब्रिंग ए कल्चर ऑफ स्पोर्ट्स. कल्चर होना चाहिए, बल्कि वो नहीं है. एंड इफ़ आई एम रीबॉर्न, आई डोंट नो, I would like to be a sports person rather than a doctor. I would like to be a sports person, maybe plus minus doctor. But sports, I think we look at Australia, look at this country, छोटे छोटे country कितने मेडल लेके जाते हैं. हमारा 1460 मिलियन पीपल हमने भी जिसको बोलते हैं बहुत ही, क्योंकि कल्चर नहीं है हमारा. कल्चर होना चाहिए, वो लाने की जरूरत है. एंड पीपल लाइक यू, एक्चुअली यू नो पीपल लाइक यू शुड, पुलिस तो करो ही करो, वो तो काम करना ही है. नहीं, ये आपका यू नो यू कैन इंस्पायर millions of girls of this country to do something better in आप अपना पॉडकास्ट करो, जो भी करो, मेरे को नहीं पता कैसे करना है, बट नहीं, you can contribute really.
Thank you. This was the proper, you know, that is why we invited her as a icon, Indian icon, to motivate and involved in doctors meeting. And as she has said, it was just in my mind कि next year थोड़ा सी lecture रख दांगे जी, police and doctors. Is there any relationship, whether good or bad? ठीक है जी. ठीक है जी. So thank you very much, all the dignitaries, special guests. थोड़ा भी Dr. Gill, मेरे दोस्त आए सी 2 मैक्स तो. We are really honored to have you here. ਤੁਸੀਂ ਸਾਡੀ ਪਹਿਲਾਂ ਬਹੁਤ ਹੈਲਪ ਕਰਦੇ ਸੀ, ਨੈਕਸਟ ਈਅਰ ਵੀ ਮੈਂ ਚਾਹੂੰਗਾ ਕਿ ਪ੍ਰੈਗਮਾ ਦਾ ਇੱਕ ਅਸੀਂ ਸੈਸ਼ਨ ਕਰਵਾ ਦਈਏ। ਯੂ ਗਿਵ ਅਸ 4-5 ਲੈਕਚਰਸ ਐਂਡ ਸਪੋਰਟ ਮੈਪੀਕੌਨ ਆਲਸੋ। 5-4 ਸਾਲ ਬਹੁਤ ਇਹਨਾਂ ਨੇ ਕੀਤੀ ਹੈ, ਕਿਟਸ ਕਰਦੇ ਸੀ। ਹੁਣ ਥੋੜ੍ਹਾ ਜਿਹਾ ਮੇਰੇ ਖਿਆਲ ਵੱਡੇ ਹਸਪੀਟਲ ਕਰਕੇ ਥੋੜ੍ਹਾ ਇਕਨੋਮਿਕ ਸਟ੍ਰੈਸ ਵੀ ਹੋ ਜਾਂਦਾ। ਸੋ ਬਟ ਆਈ ਵਿਲ ਰਿਕੁਐਸਟ ਯੂ ਟੂ ਬੀ ਇਨਵੋਲਵਡ ਇਨ ਨੈਕਸਟ ਮੈਪੀਕੌਨ ਐਂਡ ਵਾਟ ਐਵਰ ਯੂ ਫੀਲ ਲਾਈਕ you can communicate. So thank you very much. Now we will start our regular scientific session, and I request Dr. Noria to please moderate the next session with lecture of Dr. Baldev Olak. Sports ਦੀ ਗੱਲ ਕਰ ਰਹੇ ਸੀ ਮੈਮ, ਸਾਡੇ ਬੈਸਟ ਐਥਲੀਟ ਬੈਠੇ ਆ ਜੀ ਕਾਲਜ ਦੇ।
Thank you, Dr. Vittal. After the registration and the award ceremony, so we'll come back to our scientific program again. So the next speaker is Dr. Baldev Olak. Again, I don't think he needs any introduction. You see, he's one of us. You see, he belongs to this area only, as he already told you, all of you. So his lecture is on laser for prostate and stones, a very, very common problem. And I think he's going to highlight in the next 20 minutes about laser for prostate and stones. Dr. Baldev Olak.
I must thank organizers, especially my friend Dr. Vittal, Dr. Noria, and all others, to invite me to this 12th MAPICON to deliver talk on this lasers. Laser is well known for kidney stones and prostate, and now the horizon is widening. We use it for bladder cancer also and many other conditions. You know, if you see a person, 60-year male with BPH symptoms or 40-year male with multiple stones, and you want only one technology, and that is a laser. You can, treat all the conditions. And everyone knows what is laser. It is a light amplification by stimulated emission of radiation. It absorbs the energy in one form and then delivers the energy, light energy, which can be used for various purposes. So I will not go too much detail into this physics and all that, but let's see what are the advantages. It is very precise and accurate, less invasive. Patient can go home the same day. Pain is less, bleeding is less. So wherever there are very vascular prostates, lot of bleeding, the laser helps us. Or there are many comorbidity conditions like Dr. Kaler is sitting, he say this is a cardiac patient taking a lot of anticoagulants, you don't operate upon that patient. So we can do laser surgery for these kind of patients. Hospitalization, operating time, that is short. Most of the procedure can be done on outpatient basis. So these are the advantages which has brought laser into practice of urology, and even into some transplant patient also we have used laser, I will show you. So for BPH, for stones, even for bladder neck contracture, we can give incision. Endopilotomy, where there is a UPJ obstruction. Optical internal ureterotomy, like stricture urethra, infundibulotomy. And now the recently en-bloc resection of bladder tumor. This is a very good trend, and which I will show you a small video on this, because this is the latest addition in urology. Bladder tumor, all of you know, arise from the bladder mucosa. As it grows inside the lumen, pointer hai? So as it grows inside, it can invade. No, I want that. No, I want that. Anyway, so it grows inside. So when you are resecting the bladder tumor with traditional procedure, you have to remove the mucosa and then the deep biopsy to include the muscle, so that we want to see whether this is a muscle invasive or it is a superficial limited to mucosa only. This with laser, we remove the bladder tumor en bloc, taking the mucosa and not moving. Oh, it is not moving. So you have removed the whole of the bladder tumor and block, including the mucosa and the muscle, so the histopathologist can tell you whether it is limited to mucosa only or it is deeply in muscle invasive tumor, and then you can plan the treatment. We have started first time in Punjab, and lot of newspaper gave us the coverage. Then laser is well established for the treatment of kidney stones. Kidney stones can be of various types. It is not a simple one stone is equal in all the patients. They can be very hard stones, which are very difficult to break with the current pneumatic lithotripsy or ultrasonic lithotripsy. They can be very soft. They can be of different compositions like uric acid stone, calcium oxalate, phosphate, which are harder stone. Then there are different struvite stones and cystine stones, which are fluffy kind of thing, cotton kind of thing, which cannot be broken with the contemporary treatment modalities, energy modality. Then their location varies, whether they are inside the kidney calyces or they are in the ureter or they are in the bladder. Laser is one versatile, energy source which can be passed through the flexible ureteroscope. Flexible ureteroscope can be passed anywhere in the kidney, and with that help, we can remove the stones from anywhere. So this is the versatility of the lasers. So as all of you know what stone cause, what kind of pain they cause. They can cause pain, fever, blockage of the kidney, and many other things. And simply we can detect the stones with the examination of the urine and the X-ray abdomen, which can be then corroborated whether the kidney is damaged or not with the help of intravenous urography. All these involve the contrast in anything. If the person is pregnant or person is having kidney failure or other things, then this kind of modality cannot be used. And now the non-contrast CT scan of the kidney, ureter and bladder tell you everything about the urinary system, and you can see stone whether it is in the kidney or whether it is in the ureter or they are in the bladder or even the stone stuck up in the urethra. Yesterday I got a patient suddenly having a retention of urine. We saw on ultrasound there is a stone in the urethra. We just passed ureteroscope, laced it, and the patient went home passing the urine. So this is the versatility of the laser. They can be used for stones anywhere in the system, and the patient can be made stone-free. Stone-free rate with the laser treatment is the highest compared to any other energy source system. This is again advantage. This not really make you understand. This will become too hypothetical, if I keep on speaking from here. So anyway, stone can be in the ureter, which can be, rigid ureteroscope can be passed up, which is called contemporary ureteroscopy, URS, and the laser can be passed through it and stone can be removed. When the stone is in the calyces, the system is bent like this, then you need to use the flexible ureteroscope. No energy system can pass through flexible ureteroscope except the laser. Then the size of the laser also matters. The contemporary laser, they were very thick. They were more than 300 micrometers. But now we have got the latest advanced laser system, most powerful system. Okay. No, it is coming? Yeah. So, if the stone is lying in the calyces, none of your rigid contemporary instrument can go up to that. So we have flexible ureteroscope. Again, advancements keep on coming in the flexible ureteroscopes. Then we have the laser fiber, which can also bend like this. And it can lay the stones lying anywhere in the kidney, and you can make the patient stone-free. So, if the stone is in the ureter, URS, if stone is in the kidney, retrograde intrarenal surgery, which is RARS. These days, patient will come, they don't know what is stone, where is the stone. Doctor Sahab, RARS karoge? What do you know about RARS? Patient come and they command, tell us, Doctor Sahab, I want only RARS, I don't want any other procedure. So he is heard from somewhere, And he just wants this procedure only. Okay, it depends where is your stone, what is the composition of your stone, how hard it is, and what it is blocking, and what instrument we will use. That depends on us. Leave that, if you have faith in us, leave that decision to us. And so RIRS has become very common otherwise, because this makes the kidney free of stones lying anywhere. With one, instrument, you can go to any part of the kidney. Earlier, we used to do percutaneous nephrostomy and then PCNL, removing the stones. I will show that diagrams also, from puncturing the kidney from the back side. But if there were multiple stones lying in the multiple cases, we need to do multiple punctures. With this procedure, RAS, you can avoid all those kinds of punctures and remove the stones. But then limitation is size. If the stones are too big, you cannot remove all the stones by RIRS. Now the patient will come, he'll say, no, I want RIRS only. For that, we have now another advancement. I'll come back to you with that. So this was contemporary extracorporeal shockwave lithotripsy, which has now faded. Very few patients need this kind of thing. And this is a very expensive machine, and now not many hospitals are having it. These are the bigger stones in the kidney, which can be removed with PCNL, as I told you, by puncturing the back of the patient like this, what we are doing. But stones cannot come out like that. You have punctured the kidney and you stone. You have to use some energy source to break the stone and then remove the stone. As I told you, for breaking the stone, the laser is the most powerful energy system. It is not that the patient will say, Doctor, laser kar do ji. So you will see कि laser कित्थे ओदी ज़्यादा फायदेमंद है, कित्थे वो नहीं है, कित्थे वो तोड़ेगा भी कि नहीं, पहुंचेगा भी कि नहीं पहला. So contemporary nephroscope used to be used in 30 French sheath. Now we have mini PCNL and then micro PCNL, where the smallest instruments are passed into the kidney with very small puncture. There the laser is very, very useful because the size of the laser fiber is in microns. There you cannot use contemporary energy systems like ultrasonic or pneumatic lithotripsy because their size is bigger. You need then bigger scope and bigger puncture. And then now we are doing with mini PCNL. Now this is again taken over by next procedure, as I told you, RIRS. This is a flexible scope which can bend and which can go into any part of the kidney. This is the excess sheath which we pass into the ureter. Through this scope, you can see this is a very miniature, very small. This is a 5 or 6 French diameter. And through this, the laser fiber is 150 micron. That is passed through this flexible ureteroscope, and that can be used to trace any part of the kidney. And this is the advanced laser system, thulium fiber laser, TFL. Earlier it used to be holmium laser. For stones, the thulium fiber laser is the most powerful laser system which we have acquired in our setup. And here, as I told you earlier also in earlier diagram, your scope goes into any part of the kidney and you can laser any stone lying anywhere. This is the most difficult patient. This is the transplanted patient, kidney transplant patient, develop the kidney stones. Now reaching in the kidney which is transplanted, where all the anatomy has been disturbed, is a very, very difficult and Herculean task. Because the now ureteral anastomosis is anterior to the bladder. It is not a contemporary that you enter the bladder and you enter the ureteral orifice and can go up to the kidney, as I have shown you in earlier diagram. Here the orifice is anteriorly. To identify the orifice first is again very, very difficult task, then pass guide wire, then pass access sheath, and then your nephroscope and reach up to the transplanted kidney is very difficult. But we decided that we have to do the laser only because puncturing in this kidney is also very, very difficult. It is a very hard fibrotic kidney. So we pass the access sheath through bladder into the transplanted ureter, reach this stone and lays it like with thulium fiber laser. As I told you, this is the most powerful laser. You just touch the stone and stone will just become powder. And for the bigger stones, as I told you, the laser, there's a limitation for laser to break the bigger stones. But then the advancement has come, fans, flexible and navigable ureter access sheath, where we keep on lasing the stone, making it powder, fragmenting it, and sucking it with the system so the bigger stones can be removed. And this is such a big stone which was removed with the latest technology fans available in Ekai Hospital. And again, the paper gave us a lot of coverage for this. The initial experience of about 300 patients of stone diseases revealed that we had more kidney stone patients than ureteral stone patients. And most of these patients, they were removed and patient was stone free without much complication rate in these patients. So this is the advantage of laser system because energy is more. Lasing time is less. Removing the kidney or ureteral stone from the patient takes just 10 to 15 minutes once you have reached the stones. This is such a powerful laser system. And then another application is in prostate. All of you know when the prostate enlarges, it causes either irritative symptoms, urgency, nocturia, frequency, or urge incontinence, or it causes obstructive symptoms like urinary hesitancy, intermittency, post-void dribbling, straining, not able to empty the bladder completely, and ultimately retention of the urine. So when there are too much bothersome systems or there is obstruction in the urinary flow, that more post-void residual urine and recurrent urinary tract infection, or there are back pressure changes like diverticular formation or hydronephrosis like this, or there is gross hematuria, then these kind of patients, they need surgical therapy. Before that, you can treat these patients with various medical therapies. All of you know your Dr. alpha blockers or 5-alpha reductase inhibitors. So that's not part of my talk, but you can treat them medically. Dr. Noria has been treating a lot of patients. I keep on seeing those patients. And then once that stage is gone, as I told you, 5-6 indication, then there is a need for surgical therapy. And contemporary and the gold standard used to be transurethral resection of the prostate, TURP. Experienced person doing good TURP gives the best results. Though now the recent advancement in the form of laser enucleation of the prostate is just coming near to that, but still today also, if somebody asks you what is the best procedure, good TURP, whether unipolar or bipolar, done in good surgical hand, gives you the best results in my experience. So this is a gold standard, where we remove the prostatic tissue with the help of unipolar cautery or bipolar. Bipolar gives you the advantage that you can use the saline only and the patient doesn't get, fluid overload syndrome or something like that, which I have never seen in my life. We keep on reading in the books only. But then people say there can be bleeding in transurethral section of the prostate. If patient is taking some anticoagulant, so patient is comorbid, then the technology has come that we must use the lasers for these patients. This is the high-powered thulium fiber laser. It's not moving. थोड़ा स्लो, यहाँ तो डाउनलोड नहीं हुई. Not. वो तो डाउनलोड नहीं हुई. बैक जाइए. बस ये नहीं होता, मैं आगे नहीं हो रहा. Anyway, this is a laser enucleation of the prostate with the thulium fiber laser. And as you have seen, I don't know, this video is not playing over there. And you have seen once we are cutting the prostate, there is no bleeding. Chalo. ਦੇਖਣੀਆਂ ਸੀ ਪਹਿਲਾਂ। So here again you keep on cutting and you enucleate the prostate as you were doing earlier in open prostatectomy. These all lobes, they will go back into the bladder, and then with the help of morcellator you just morcellate and suck that whole of the prostate out, and the patient can be discharged the next day. Now a little bit it is showing. So this whole fossa will become wide fossa without any bleeders. So this is the morcellator. The video is not playing, but this is the morcellator. The whole lobes are, pushed back into the bladder, and then they are morcellated and sucked out, and, whole of the prostate is removed. But this was the only, video which was to be shown. Anyway, so the laser is now used for bladder cancer, for stones, as I have shown you, and then prostate. So these are the main indications for laser in urology. And of course, for prostate now, the recent advancement has come. If the patient is, having too many cardiac problems, Dr. Gill is not giving you the clearance. You can, just lift the prostate lobes like this. They're like stapling in devices available, and which is called a Urolift. And again, we are the first hospital to start this Urolift procedure in Punjab. And that gives good result. Patient belongs to Bathinda only, and he's sending me more patients. So this was again covered in, paper. And thank you so much.
Thank you, Dr. Alec. Touching very sort of important topic about the renal or kidney stones and cancer prostate. This part of the country, you see, Punjab probably has the highest incidence of renal stones, you see. And there are a lot of myths and misconception about in the mind of the people. ਸਾਡੇ ਕੋਲ ਲੋਕ ਆਉਂਦੇ ਆ ਜੀ ਮੇਰੇ ਕੋਲ ਜਿੰਨੇ ਬੰਦੇ ਮਿਲੋਗੇ ਤੁਹਾਨੂੰ ਸ਼ਾਇਦ ਉਨੀਆਂ ਦੇਸੀ ਦਵਾਈਆਂ ਮਿਲ ਜਾਣਗੀਆਂ ਸਟੋਨ ਕੱਢਣ ਵਾਸਤੇ ਯੂ ਟਾਕ ਟੂ ਐਨੀਬੋਡੀ ਹੀ ਵਿਲ ਸੇ ਜੀ ਆ ਸਾਡੇ ਘਰੇ ਆ ਦਵਾਈ ਹੈਗੀ ਹੈ ਤੁਸੀਂ ਖਾ ਲਓ ਤੇ ਸਟੋਨ ਨਿਕਲ ਜਾਣਗੇ ਅਨਫੋਰਚੂਨੇਟਲੀ what I feel, what we experience, that the people come very late when their kidney is damaged. There's a very bad hydronephrosis. You see, they have a pyelonephritis, and at times you see it becomes very difficult to save the kidney. I think we must diagnose them early to save the kidney. That is very important, and that's what I feel personally. That we must tell the patient at right time, you see, to get it operated. Sorry. Yeah, they are silent killers because there are a lot of myths about stones. No? People don't, they usually come very late. And again, what about Urolift? You see, even yesterday I saw a patient, he had done his Urolift from PGI Chandigarh. You see, again, this process is becoming very, very common for the simple reason that you don't have to do any cut or anything else. You just have to put a few implants there, and slowly and gradually that takes away your prostate. That's how it helps, you see. Any other questions, please?
Gloria has brought very important point. These stones are very, very easily treatable condition. But many of patients will come to you, they will say, Doctor Sahab, mainu kadi pathri da pata hi nahi lagya. If I do 100 transplants in 1 year, 5 of them are sufferers of stones which could have been saved from kidney transplant. Again, as I showed you the one slide, prostate enlargement with hydronephrosis and hydroureter. Almost I do 3-4 transplants in a year where simple prostate, which could have been tackled in time and avoided kidney damage, I have to do the transplant for these patients. So prostate and kidney stone, they are avoidable condition to save your kidney. It is better to treat early. As Dr. was saying, I call this silent killer. Because the stone which is not causing pain is the silent killer of your kidney. And majority of the patients who develop kidney failure, they die of cardiac disease. Dr. Jindal and Dr. Gill.
Sir, I wanted to ask a question. Good afternoon, sir. Sir, when we do TURP, generally we used to see that there is hyponatremia and other complications afterwards. Does that happen even after laser? now we don't see those much, but earlier we used to read in books that is one of the most important.
Yeah, we read in the, that's why I told you, we read in the books, but I have never seen in my life any, hyponatremia, or we call it syndrome. I've even forgotten the name of the syndrome we used to teach to our students.
So, but we as physicians have seen 1 or 2 post TURP, but does that happen after laser and block also?
Why hyponatremia will happen? It will happen when the fluid is absorbed.
Exactly.
In laser, you seal the blood vessel as soon as you see them. But sometimes there is also some bleeding. This is a very nice photograph which I showed. But sometimes in laser also there is bleeding, some fluid absorption. But some fluid absorption does not cause hyponatremia if your kidney function is all right. Because your speed matters. As I told you in experienced hands, you should finish your TURP within 60 minutes. You should not take longer time. I have removed even more than 100 gram prostate less than 40 minutes. So your speed matters. You have to speed up. Sometimes, of course, it is a learning curve. Sometimes when the beginners do, they resect one bite and there is a bleeder. They keep on, touching that, spending a lot of time. Then another bite. And I have seen, my trainees. Then when you keep on spending that much time, fluid is going on, that is getting absorbed. Because prostate venous channels are big channels. And the fluid keeps on getting absorbed. If you are not careful, if you have done that, tell your anesthetist to give the Lasix immediately so that extra fluid will come out. So you will not see any hyponatremia syndrome. So,
but Lasix will also cause hyponatremia. Lasix se bhi to hyponatremia
No, that will remove the extra fluid also. That's right, you're right. That will happen when extra fluid is not there. But now here we are giving Lasix to remove the extra fluid. And all of our teachers used to give Lasix after 60-50 minutes of their resection time. So your resection time should not increase and you should be fast enough to remove the bigger prostate. I was telling Dr. Karamveer one example on the way when we are coming. If prostate is big and you are the beginner, don't touch it. Because you will then do more harm to the patient than, somebody touched the prostate, he removed the few lobes and the patient was bleeding after that, going into complication and all that. Then patient came to me and I had to resect that prostate. Whole of the prostate was inside, it was bleeding. I had to resect hurriedly within 40-50 minutes and the patient was, all right. So if you are a beginner, the prostate is big, kindly don't touch it. Learn how to remove the prostate in a quick and faster manner with hemostasis. The more hemostasis you will achieve, the less there will be absorption of the fluids.
So, and one more question, sorry. How to convince patients for TURP? Because many patients, we see patients, like there was one patient who I saw, I think day before yesterday, where there was significant PVRU of 340 milliliters. And they were not convinced for even visiting a urologist.
Yeah, this is what I told you. They
elder age, they'll say, nahi ji, dawai de do, ye kar do. So how to convince? Because that was
इसलिए ਤੁਹਾਡਾ ਰੋਲ ਬਹੁਤ ਜ਼ਿਆਦਾ ਸਰਜਨ ਕੋਲੇ ਪੇਸ਼ੈਂਟ ਆਂਦਾ ਡਰਦਾ ਹੈ. So physician, you must tell them.
I had to catheterize that patient because the PVRU was very much significant.
Very high.
I gave him that catheter trial, but I told him, I have convinced him that if that catheter-free trial fails, he has to go to a urologist because it will not heal.
Bilkul, that's right. These are the sure shot indication where the surgical intervention is must. You must tell them if you are not going ahead with your surgery or consulting your urologist, now you are having increased post-void residual urine, slowly you will start trabeculation, the bladder, diverticuli, hydronephrosis, hydroureter, and your kidneys will damage and you will undergo dialysis. Once you scare them off telling all the real picture, not unnecessary scaring, then they probably will get convinced. Otherwise, some people difficult to convince, they come to us also. But as I told you yesterday, the patient came, he came with a retention stone in the prostate urethra. He was asking again me, Doctor, dawai do, main kaha tera bladder phat jayega. Just I have to tell him like that. Then he said, Doctor, hone remove karo. And I removed and patient went home.
So that is what happens now. We have to tell them that indwelling catheter will cause more of infections than the surgery. So that is
no, you can't keep the catheter long time. Sometimes I keep on getting one patient. I came, he was having his catheter for last 6 months or 1 year. Then he came to me, why don't you undergo prostate surgery and why you get rid of this? Doctor, mainu kisi ne dassya hi nahi. I admitted that patient did the TURP and he went home without catheter. कहना डॉक्टर साहब मैं जिंदगी च पहली बार यूरिन पास किया है जिसे साल हो गया सी.
डराना ही ऐसा पैंदा भी सारी उम्र लिए catheter लग जाऊगा फिर ही मानते हैं.
No, you are very good physician. And you must, I'm sure you will be able to convince, but tell them the sequely. And correct sequely that you will get this if you are not going to go to your urologist. Yeah.
Thank you once again, Dr. Alec. I think the next two lectures are dedicated to the Lipid Association of India. And the first lecture is the latest recommendations for the management of dyslipidemia by Dr. Karamveer Goel. He is one of a friend, younger brother, member Medical Council Punjab. So Dr. Karamveer Goel, please.
Good afternoon, everybody. Once again, we have been talking about sedentary life, sportsman, sports culture in India, everything for fitness, especially for the doctors and all. So I think they all are focusing down to ultimately, scientific part of it. What ultimately it lands up with. If you are not keeping yourself fit, you are not doing exercises, you are not taking care of weight and all, what you are going to land up with is dyslipidemia. And before we start with the dyslipidemia and the recommendations of the Lipid Association of India, why it's important? Because India is in the middle of atherosclerotic cardiovascular epidemic. If we see in India, we Indians are almost 3 or 4 times more prone to cardiac disease than Americans, 6 times more prone to cardiac disease than Chinese, 20 times more prone to cardiac disease as Japanese. So as such, by birth, we are more prone to cardiovascular disease. Plus, coronary heart disease manifests almost a decade earlier in India than Western countries. Almost 25% of the major MIs occurring in India are in the age of group of less than 40 years. And all the more 50% of the deaths occurring due to MI are less than 50 years of age. So such is the burden of cardiac atherosclerotic cardiovascular disease, which is in India, and it is increasing most rapidly in the younger people, especially in the age of 40 years. So what is the culprit? Dyslipidemia, cholesterol. Cholesterol is a basic cardiovascular risk factor. As we were talking about the silent killers, about the stones and whatnot, it is the major silent killer which is slowly, progressively going to take to you the death with the cardiovascular problems and all. So, going in with a scientific way, the role of LDL cholesterol and other ApoB containing lipoproteins in the development of atherosclerotic cardiovascular disease has been demonstrated by genetic, observational and interventional studies. So we have to be very careful in dealing with the cholesterol levels and dyslipidemias. In day-to-day practice, daily we see reports of the lipid profile. We see that somebody's LDL is about 110, HDL 210, total cholesterol 223. We just pass it off. Okay, no problem. You take care of diet and this thing, that thing. But I think as practitioners, as physicians, as cardiologists, as endocrinologists, or even any specialty we are dealing with, we have to be more scientific and more dogmatic in our directions to the patient. If we see this diagram or the map of India, in this ICMR study, Punjab, we can see that is it working? No. Almost 25% of the people are in Punjab are having hypertriglyceridemia. More than 25% are having high LDL. And most importantly, 60% of the people in the Punjab are having very low HDL. This is a very important thing which is generally ignored. And almost more than 15 to 25% of the people are having dyslipidemia, triglyceridemia. So for that, in general, what we were saying or what we reiterate again and again, lifestyle modification is the main thing to control the dyslipidemia or manage dyslipidemia, and Lipid Association of India also goes for that as the first line of management in the form of adoption of a Mediterranean diet pattern like vegetables, fruits, whole grain, low dietary products, poultry, fish and legumes. Combination of oils rich in MUFA and PUFA rather than trans fats we should be taking, and limiting that intake of sweets, sugars, sweetened beverages and meat. Physical activity, as we were saying, 150 minutes per week of moderate intensity or 75 minutes of vigorous intensity aerobic physical activity or equivalent or combination of both is required or is advocated spread throughout the week. Muscle strengthening exercises also at least 2 days per week. As far as the alcohol intake is concerned, should preferably be avoided by Indians. Maximum up to 1 drink for females and 2 for males. Here, again a rider for males who are having age more than 65 or any comorbid conditions or diabetes, we shouldn't be advocating even 2 drinks for males per day. Complete abstinence from tobacco containing products, and above all, stress management and adequate sleep. So I always say 5 pillars are important when you are dealing with the non-pharmacological measures as far as your fitness is concerned. Weight control, diet control, stress control, proper sleep, and adequate physical activity. And in diet, low carb, low fat, fat with a high MUFA and PUFA, and of course 7 to 8 hours sleep, as was advocated by Dr. Claire also in the earlier talk. So that was in general for all people. But once we are dealing in our day-to-day OPD practice or otherwise, as anybody walking to your OPD as patients, we will be wiser, or we should be making them wiser by doing risk stratification with respect to the possibility or risk of the cardiovascular disease which they are going to have. So the major risk factors or markers are age more than 45 in males or 55 in female, family history of premature atherosclerotic cardiovascular disease, current cigarette smoking or tobacco use, high blood pressure, and low HDL cholesterol. So these are the 5 major risk factors. And in India or in our day-to-day practice or in Punjab, we can easily see, any person who is having the middle age or a 55 old male person coming to you is a smoker or is having hypertension. So straightway falls into the high, major risk category of developing cardiovascular disease or coronary disease. Apart from the major cardiovascular factors, we have other high risk features, diabetes with 1 or 0 to 1 or other major factor, CKD stage 3B to 4, familial hypercholesterolemia, extremes of a single risk factor which we were talking in the 5 risk factors, coronary calcium score of 300 or more HI units, non-stenotic carotid plaque, or lipoprotein A more than 50. Desirably is less than 30 or 30, but it is more than 50. So these are the other high risk factors. And certain modern non-conventional risk factors are coronary calcium score of 100 to 299, increased coronary carotid intermedia thickness, lipoprotein level of 20 to 49, impaired fasting glucose, increased waist circumference up to more than 90 in males and more than 80 centimeter in females, ApoB more than 110, desirable limit is less than 90, and HSCRP more than 2 on different occasions. So these are the moderate risk factors, high risk factors and major risk factors. Now once we know the risk factors, we categorize people whether they fall in the low risk or the moderate risk or the high risk or very high or extreme risk factors. So any person who is in the having only 0 to 1 major risk factors and has a lifetime risk factor of CVD of less than 30% is at low risk. Any person who is having 2 major risk factors and 1 low risk factor and lifetime CVD risk is more than 30 is of moderate risk. In the high risk category, 3 major factors, like I was telling earlier also, any person who comes to you with the age of 50 plus, is a smoker or is a hypertension, already has 3 major factors, or any of the 2 major risk factors, or 1 high risk factors, is in the high risk category of developing coronary artery disease. And in very high risk factors, if the person is already has had a coronary artery disease earlier, or is diabetic, with 2 or more major risk factors, falls into that category, or has a family history of homozygous hypercholesterolemia. In the extreme risk group, we have category A and B. Any person who is having CAD with more than 1 feature of the high risk group, and other category is having CAD with very high risk of the ACS with one LDL cholesterol less than 50. So these are the 5 groups which we divide. We can divide the population or the people in our practice, whether anybody is in having extreme risk or moderate risk or high risk of developing coronary artery disease, and accordingly guide the person or manage his future life and prevent him going from the silent killers. So now once we have achieved we have stratified the risk categories, we have our targets. These are the targets which will help you and your patients to adopt that lifestyle, and also if needed be any medication to get the ultimate goal of better quality of life and ultimately longevity of life in the later years of life in the age. So anybody who is at the low or moderate risk, we have the targets of LDL cholesterol less than 100 and non-HDL cholesterol less than 130. Anybody who is in the high risk group, we have the targets of LDL cholesterol 70 and non-HDL 100. Further, we have in the very high risk category, LDL 55 and non-HDL 85. And in the extreme group, it is as low as LDL cholesterol 40 and non-HDL as 70. So these are the goals of all the 5 categories. And frankly speaking, I will also confess, in our day-to-day practice, we ignore these guidelines and we ignore these targets. We just tend to tell, you see the prescription, okay, anybody you are getting already atorvastatin or you are getting rosuvastatin, okay. We dare not tell the person, no, you are not achieving the target, you are getting the underdose, or you are not observing lifestyle modifications to achieve the target, which will actually benefit you from developing the coronary artery disease or atherosclerotic cardiovascular disease in the later years of life. So now, how to achieve it? Once we have known which are the risk categories and what are the risks and what are the targets for different groups, how to achieve that? On one hand, we have repeatedly said, reinforce lifestyle measures in the form of diet, exercise, weight reduction, smoking, quitting, and alcohol restriction, control of diabetes and hypertension on the other side. Plus, now comes the role of medication. The high intensity statin we have to start, and if the LDL cholesterol is more than 50 after 3 weeks or up to 3 months, apart from the lifestyle modification and dietary restriction and control of diabetes and hypertension, it is advocated that we add the ezetimibe along with the statin and achieve the target. Still, if the patient has still LDL cholesterol more than 50, we should consider addition of bempedoic acid or PCSK9 inhibitor, monoclonal antibodies like inclisiran and all, so that ultimate goal is achieved and the patient gets a really benefit. And you all know what are the statins available in India. High intensity are atorvastatin in the dose of 40 to 80 milligram. I don't think in our day-to-day practice, anybody in the audience is prescribing 80 milligram atorvastatin. No. And you will see so many patients or people, ladies coming to you, sir, मैं तो कुछ खाती नहीं जी, मैं तो ਘਰ ਦਾ ਸਾਰਾ ਕੰਮ ਕਰਦੀਆਂ ਜੀ, ਇਹ ਪਤਾ ਨਹੀਂ ਕਿੱਥੋਂ ਵਧੀ ਜਾਂਦੀ ਹੈ। ਆਈ ਟੈਲ them in ਪੰਜਾਬੀ plain language ਕਿ ਕੋਲੈਸਟਰੋਲ ਹਵਾ ਜਾਂ ਪਾਣੀ ਨਾਲ ਨਹੀਂ ਵੱਧਦਾ। It should be very simple and in clear curt manner you should tell the people कि it is either your diet or lack of physical activity or lack of exercise which is increasing this. In spite of the fact you are taking the medicine, you have to step up the medicine, otherwise there is no fun of continuing with the medicine with the underdosage. Okay? And same is true about the rosuvastatin. Not 20 to 40 milligram is the actual height intensity dose if you really want to achieve the results for the patient. So management of dyslipidemia ACS is the next lecture. I won't go into the details of it. A word about the triglycerides and atherosclerotic cardiovascular disease. It has been seen from randomized trials that individuals with mixed dyslipidemia, that is elevated triglycerides, elevated LDL and low HDL, which is the typical lipid profile of Indian patients, have the highest risk of cardiovascular events. Also, elevated triglycerides more than 150, even if LDL cholesterol is less than 50, have the more risk of MI as well as a mortality. You have achieved LDL cholesterol less than 50, but if your TGs are high, still you have the high risks. So, in Indian population, we have to take care of the triglycerides also. And we all know from our residency times that optimal value is less than 100, normal is less than 150, borderline is 150 to 199, and 200 to 499 is the high TG levels, and more than 500 are very high TG levels. And it has been seen for triglycerides, it may be fasting or non-fasting. You may achieve get the fasting value or non-fasting value, because in most patients there is a clinically unimportant increase of triglyceride concentration by 18 to 30, 60 milligram per deciliter 2 to 6 hours after the feast. So just to repeat, Indian have atherogenic dyslipidemia in the form of high TG, high LDL, cholesterol and low HDL cholesterol. LAI recommends both fasting and non-fasting lipid profile in Indian subjects for, as I told you, fasting for LDL cholesterol and non-fasting for postprandial hypertriglyceridemia. And most of the common agents which they are responsible for lowering hypertriglyceridemia are fibrates. They cause 30 to 50% reduction, niacin 20 to 25% reduction, omega-3 fatty acids up to 20%, statins of course 10 to 30% reduction, and GTMide they cause 5 to 10% TG reduction on the long-term basis. So now how to, once again, this is a very beautiful diagram, flow chart showing the management of hypertriglyceridemia. And patients with a more than 150 TG levels try to achieve the non-HDL goal and implement lifestyle modification. Just to repeat, increase physical activity, diet control, weight control, stress control, proper sleep, and treat secondary causes like diabetes and hypothyroidism. If we achieve the normal HDL, non-HDL and TG levels, continue with the lifestyle interventions. Or if the person continues to have high TG or atherosclerotic prevention and there is no diabetes, we still lifestyle modifications plus lower the triglycerides with statins or non-statin drugs like niacin or fibrates. But if they are still, in spite of the lifestyle interventions, statins and fibrates and all, we still don't get that result, we can add further latest non-statin drugs that is ecospent ethyl IPE we call it. Okay? But if the person has high or familial hypertriglyceridemia, more than 105, here we are countering or trying to achieve the prevention of pancreatitis in such patients along with the cardiovascular problems. So apart from intensive lifestyle modifications, low-fat diet, fibrates, omega-3 fatty acids, seraglutazar has been have been showing good results in a couple of few years to achieve better results for prevention of pancreatitis with the lowering of triglyceride levels. If still the results are not achieved, the person can be referred to the lipidologist or the latest NG-3 antagonists, they cause lipoprotein lipase and endothelial lipase activity, by clearing the more lipoproteins from the liver. They are the latest drugs in our armamentarium. So I won't go into the detail of comparing the different guidelines of the different associations. Just to conclude that healthy lifestyle should be emphasized across the course of life. All guidelines strongly advocate LDL should be our primary target, and the intensity of treatment should increase as the risk of the patient increases. Lower the better, and earlier the better reduction of LDL cholesterol, and no threshold is adverse. So as far as the Lipid Association of India is concerned, it lay emphasis upon early screening. After 20 years of age, every year annual screening should be there. We should be identifying the Indian type of lipid profile pattern, that is high cholesterol, high LDL, and low HDL, and high triglyceridemia. We should be knowing about it. Premature atherosclerotic cardiovascular disease in the family history is important. Lipoprotein level estimation and ApoB lipoprotein estimation may be important in Indian patients. Achievement of non-HDL cholesterol targets is as important as the achievement of LDL levels. And there are no adverse side effects of very low LDL cholesterol. So we should go for aggressive management of LDL management and non-HDL management in Indian subset of patients as compared to the Western counterparts. Thank you very much.
Thank you, Dr. Karamveer, for apprising us of LAI guidelines. I think every Indian doctor should at least read or follow the Lipid Association of Indian guidelines, because they are India specific. Yes. We cannot percolate the data of Western population into Indian guidelines. So LAI guidelines under the leadership of Dr. Ramanpuri gains much importance. So thank you very much for apprising us the Indian Lipid Association guidelines. Thank you very much.
Thank you once again for giving me an opportunity to talk.
Thank you. Any questions, please? Thank you, Dr. Karamveer. Next in the line, again about dyslipidemia. Dr. Karamveer has just spoken on the dyslipidemia as a whole. But the next speaker, Dr. Manikant Singla, he is running his own clinic at Ludhiana. He is secretary to Punjab chapter of Lipid Association of India. He is limiting his talk to dyslipidemia in relation to diabetes. Dr. Manikant, please.
Good afternoon, everyone. So first of all, I would like to thank Professor Vitul Gupta and the organizing committee for inviting me for this talk. So as Dr. Karamveer already highlighted the importance of lipid control in the general population, so I will be speaking mainly about dyslipidemia in the diabetes. So actually it is lipids are very, very important to treat in a diabetic patients, but practically if we see, so whenever any doctor prescribes statins to the patients, so first treatment which patient stops is statins. They themselves stop after some time. So our duty is to tell them the importance of lipid medication, so that they otherwise they come up with all the cardiovascular disease and other MI and other things. So now I will be speaking about LAI guidelines for the management of diabetic dyslipidemia. So India is one of the diabetes capital of the world, and estimated in 2021 there were 74 million population suffering from diabetes. And why Indians are different? We are having from the Western population, we are having earlier age of onset of diabetes, higher frequency of metabolic syndrome, and more risk factor for ASCVD and more aggressive course of ASCVD complications. So we are different from Western population. That's why under the leadership of Dr. Ramanpuri, the LAI guidelines were formulated for diabetes, and there were more than 165 webinars were done to formulate these guidelines. So I am one of the co-authors in these LAI guidelines. So after so much of uh, efforts, these guidelines were made. So what are the objectives for LA recommendation? Why we made these recommendation? Because we are different from the Western population. So our main aim was to reduce the cardiovascular morbidity and mortality in Indian patients, because the main cause of mortality in diabetes is CAD. And there is a lot of under treatment of dyslipidemia from the doctor's point of view also, and from the patient point of view also, because patients think that this is the unnecessary medication. So they tend to stop the statins. And for the unique features of diabetes, dyslipidemia, these guidelines were made so that we can reduce the morbidity and mortality. And we are having younger age of onset of diabetes, and more than 90% of Indian patients are having less than 50 age, and the risk factors, hypertension, obesity, dyslipidemia and ischemic heart disease are quite prevalent. And according to ICMR study, typical age of onset of diabetes in Indians were in between 25 and 34 year of age. And Asian Indians are having higher prevalence of metabolic syndrome. If you see this masala study, that is mediators of atherosclerosis in South Asian living in America. So South Asian Indians were having prevalence of metabolic syndrome to the tune of 20 to 32%. And we are having elevated body fat mass, often with normal body weight, which is the classical YY paradox if you see in the Indian patients. And despite normal BMI, we are having higher fat mass, visceral fat, higher insulin resistance, dyslipidemia and heightened risk of type 2 diabetes, and also having higher waist and higher waist to hip ratio. And we are also having higher abdominal and ectopic fat and lower lean body mass. And if we see the higher prevalence of atherosclerosis, it was to the tune of 21% as compared to non-diabetics, where it was 11%. And in Indian patients, diabetic patient, 3 to 4 times higher risk of cardiovascular disease is there. And dyslipidemia precedes the diagnosis of diabetes. So the prevalence of atherogenic small dense LDL, even if LDL is normal, this atherogenic small dense LDL 18 to 20 nanometer size, which can be seen by NMR spectroscopy. So this is risky for the development of cardiovascular disease. So in the diabetic patient, it is the characteristic dyslipidemia, that is hypertriglyceridemia, low HDL and small LDL particle without elevation of LDL, but elevated non-HDL cholesterol. Non-HDL cholesterol is also one of the important parameters for the development of cardiovascular disease. And mostly non-HDL is not given that much of importance. Most of the people are focusing on triglyceride and LDL, but non-HDL is also one of the important parameters which is more predictive of risk than the LDL. So how to calculate this? You subtract HDL from the total cholesterol, that comes the non-HDL cholesterol value. So this is rather more important parameter than the even LDL cholesterol. So if we go about the studies of effect of lipid lowering medication on CVD risk in diabetes, that is statins and ezetimibe. So heart protection study, it was seen that if you treat lipids, the protection with simvastatin was more in diabetes as compared to patient without diabetes, and similar findings were seen in 4S study, that is Scandinavian simvastatin survival study. So benefit in diabetic patients were more as compared to non-diabetic patients. Even treating to new target study, that is TNT, if you compare 80 mg dose of Atorva versus 10 mg, so the patients who were given 80 mg dose, there was much better improvement as compared to the 10 10 mg dose. And improve IT trial in which simvastatin was combined with ezetimibe, and there was event rate was better improved if you combine simvastatin with ezetimibe. So there was definitely much better improvement in patients with diabetes and established ASCVD. So the main finding from all the trials were lower you go for the LDL, the better the protection for the development of cardiovascular disease. So atherogenic triad we have already discussed. So lipid association of India guidelines say that even if you control the LDL, still there remains the risk of cardiovascular disease. 30 to 40% risk still remains. So SGLT2 inhibitors are one of the drugs of choice for the prevention of cardiovascular disease in diabetic patients, so which can help in the prevention of cardiovascular disease. So SGLT2 inhibitors are the one of the adjunct therapy, and similarly GLP-1 receptor agonists are coming in a big way. They improve the CV mortality, but they don't improve the non-fatal MA and heart failure, and also they help in prevention of cerebrovascular disease, and they are also renoprotective. So LI recommendation says that SGLT2 inhibitors and GLP-1 receptor agonists are one of the adjunct therapy for prevention of cardiovascular disease in diabetic patients. So now coming the role of the PCSK9 inhibitors. So which are the injectable drugs? So Odyssey outcome trial and Fourier trials, these were two trials in which persons with pre-existing ASCVD, of which 40% of patients had diabetes, they were treated with evolocumab 140 mg subcutaneously twice a week, and LDL was lowered to 30 milligram per deciliter. So there was a 15% relative risk reduction of composite primary endpoints at 2 years. So you just see that LDL was lowered up to 30 milligram per deciliter, still there was much improvement. So as Dr. Kanavir also already told, so lower the LDL, the better it is for the patient. And in patients of diabetes with dyslipidemia, PCSK9 inhibitors can be useful option for management of refractory hypercholesterolemia. Sometimes you are not able to control LDL with statins or ezetimibe or bempedoic acid. So PCSK inhibitors, although these are costly treatment, but they are one of the good options in patients in whom you are not able to control the LDL levels. And if you combinedly treat dyslipidemia, hyperglycemia and hypertension, you can reduce the risk of CVD by 62%. And so there are a lot of gaps in global guidelines. That's why the rationale was there for recommendation for the treatment of dyslipidemia in diabetes in Indian patients by the Lipid Association of India, because we are unique, we are different from the Western population. So if we see the LI 2020 guidelines, so diabetes with less than one major ASCVD risk factors without target organ damage. Our aim is to lower LDL to less than 70, non-HDL less than 100, and ApoB should be less than 80, and diabetes with more than 2 risk factors and no evidence or and evidence of target organ damage, LDL should be less than 50, non-HDL should be less than 80, and ApoB should be less than 65. And extreme risk group category A, ASCVD and diabetes with less than one major risk factors without target organ damage, LDL should be less than 50, and non-HDL less than 80, and ApoB should be less than 65. And extreme risk category, category B, which is CAD and diabetes with more than 2 major ASCVD risk factors or target organ damage. So LDL should be less than 30, and non-HDL should be less than 60, and ApoB should be less than 50. So just see that in a diabetes patient with ASCVD, our target should be at least LDL should be less than 50. So if you see in your practice also, many patients already having MI or any stunting, CABG, our target of LDL should be less than 50 or less than 30 if patient is having more than 2 risk factors. So such is the stringent criteria of lipid association of India in the Indian patients. So this risk stratification, Dr. Karamveer has already told, so I am not going into the details of this. And one of the trials in Improve IT trial, they achieved LDL less than 30 in 6% of patients. So there was 29% lower risk of CV events. So just imagine that LDL less than 30, still you are having around 30% improvement in the cardiovascular events. And similarly, Osler studies and Odyssey trial in which PCSK9 inhibitors were used. So LDL was maintained less than 50 and there was much more improvement. So evolocumab, which is a PCSK9 inhibitor, so it can lower the LDL to any level, less than 30, 20, up to that. So these PCSK9 inhibitors, these are the drugs of future. So they will be used in future quite extensively when cost comes down. And one of the meta-analysis of non-statin trials, it was seen that if you lower LDL up to even 20, so further you can reduce the CV risk, and there was not much of harm to the patient. So even if you go up to 20 also, there was no harm, rather there was a improvement in the parameters. And if we see Odyssey outcome trial, ultra low at LDL level of less than 15 was achieved in 7.7% patients, and there was a risk reduction to the tune of 29%. So one of the most important parameter is lifestyle modification, which is the cornerstone of ASCVD prevention. So diet, Dr. Karamveer has already discussed, diet should be rich in PUFA and MUFA. And mustard oil and canola oil is the oil which is most suitable oil for routine use in Indian cooking. So this point was specifically highlighted in the Lipid Association of India. So if patient comes and asks you, mustard and canola oils appear to be the one of the best oils for routine use in the Indian kitchens. And cold pressed oils are better because they retain the antioxidant and micronutrients. So nowadays lot of trend is there, cold pressed oils are used. So these are better than the conventional oils. And alcohol should not be used much in the patients for prevention of hypertriglyceridemia. Physical activity, 150 minutes per week of moderate physical activity should be there. So now coming to the guidelines of LAI. I will be discussing this thing in 2-3 slides, last 2-3 slides. So diabetes, how to manage diabetic dyslipidemia in Indians, diabetes without ASCVD. So first of all, you have to see whether any target organ damage is there or not, or less than one risk factor is there. So patient becomes the high risk. So LDL is less than 70. So diabetic patient as such is a high risk patient. So any patient without any damage, without any risk factor, any diabetic patient coming to you, you should maintain LDL level less than 70. If patient is having target organ damage like any heart problem, retinopathy, or any CVA, or any microalbuminuria, smoking, etc., risk factors are there, more than 2 risk factors are there, patient becomes very high risk. So LDL should be maintained less than 50 in such patients. So in our practice, in our diabetic patient, most of our patients fit into high risk or very high risk category. So our aim is to maintain LDL at least less than 50 in such patients. And if patient of diabetes is already having ASCVD, and you have to see associated comorbidities, that is diabetes without target organ damage less than one major ASCVD risk factor, that patient becomes extreme risk group category A. LDL should be maintained less than 50 and optional is less than 30. And if patient is having diabetes plus polyvascular disease or target organ damage more than 2 major ASCVD risk factor, that becomes extreme risk group category B. So LDL should be maintained less than 30. So first category is diabetes without ASCVD, which is the general everybody, physicians, endocrinologists, everybody sees. And diabetes with ASCVD, which is mostly cardiologists see such patients. So there you have to maintain LDL either less than 50 or less than 30. Otherwise, in the general practice, LDL less than 70 and less than 50. So that should be our goal in the majority of the patients. So this is the summary of the Lipid Association of India guidelines. Then comes the triglyceride targets. So triglyceride, if in between 150 to 199, 200 to 500, 500 to 1000 and more than 1000. So how to treat? So you have to measure LDL level, calculate known HDL, assess the ASCVD risk, lifestyle modification in the form of low fat diet, avoid refined carbohydrates, weight reduction, exercise, avoid alcohol, no smoking, and first of all, if patient is having increased LDL, increased non-HDL and high ASCVD risk, you have to treat with statins and ezetimibe and achieve LDL target. If you are not able to achieve the triglyceride target like more than 135, then you can add omega-3 fatty acids or fibrates. If triglycerides are more than 500 to 1000, so straightway you can add fibrates or omega-3 fatty acids. And more than 500, if TG is there, risk of pancreatitis is quite high, and if it is TG is more than 1000, then there is marked increased risk of pancreatitis. So we don't wait. If TG is more than 500, straightway you can add fibrates, and standard treatment should be continued, that is statins plus ezetimibe, that should be continued. Sometimes if triglycerides are quite high, 3000, 4000 or 5000, so plasma apheresis also in some centers in Delhi they are doing. So that is one of the options for that also. And lie recommendation for non-HDL is like whenever any patient comes to in OPD and you don't require a fasting lipid profile. Straightway you can do the lipid profile and you can measure the non-HDL cholesterol. And the target of non-HDL cholesterol is 30 milligram higher than the LDL. So according to that also you can put the patient on statin. So fasting lipid profile is not mandatory. It is better to do a lipid profile rather than not doing it, because many times you write the lipid profile, patient won't come back to you. So straightway you can go for lipid profile estimation without fasting also. And statins remain the first drug of choice, and addition of ezetimibe can be considered if you are not able to control HDL or non-HDL. So ezetimibe, I think it is a good molecule. It is underused, but now again people have started using ezetimibe. In between people were not using it much, but this is one of the good molecule for lowering the LDL cholesterol levels, because sometimes patients don't tolerate the high dose of statin, so you can add ezetimibe and you can achieve the LDL cholesterol. And icosapent ethyl is available in India now for the management of higher triglycerides. And our aim is to maintain triglyceride less than 150. So I am not going into much of the details of triglyceride, because that we already discussed. And one of the important parameters is ApoB concentration also, so that should also be lowered. It is also one of the important parameters. And ApoB should be measured in high risk and extreme risk groups after LDL and non-HDL goals have been achieved. And lipoprotein little a also should be measured in extremely high risk and high risk patients. And there is not much of treatment available for treatment of LPA, and PCSK inhibitors can be one of the good choice for treatment of LPA. Otherwise statins and ezetimibe, they don't lower the LPA too much. So PCSK9 inhibitor can be a good choice for prevention of cardiovascular disease. So now I will end my presentation by this summary. So diabetes with no ASCVD and diabetes with ASCVD. So this we already discussed, that high risk group LDL should be less than 70. Very high risk group, LDL should be less than 50. Diabetes with ASCVD with no risk factor, LDL less than 50. And diabetes with ASCVD with more than 2 risk factor, LDL should be less than 30. So lower the LDL, the better it is for the patient. So thank you all for your patient listening.
Thank you, Dr. Manikant, for a very nice talk and emphasizing all the latest recommendations by the Lipid Association of India. I think my worry is, say, it's about all the time about the triglycerides, you see, because I find it very difficult, you see, to take control of the triglycerides in spite, because there are not too many drugs, you see, to control the triglycerides, except for the, again, statin plus lifestyle management, you see, that is the part. Then comes to the part of LDL. How often you see you use PCSK inhibitors?
In my practice, myself, I have never used PCSK9 inhibitors. Most of the means cardiologists, they use it. In our patients, diabetes without ASCVD, most of the times we are able to achieve our LDL target with the statins and ezetimibe only in most of the patients. But cardiologists, they need more stringent LDL loading. That's why they are using it quite extensively in Delhi, etc. Means PCSK9 inhibitor in patients who have recurrent MIs or CAD attacks. So they are using it. But personally, I have never used it.
Probably they have most of them probably they have a very strong family history.
Yes.
You see. And I think those patients are vulnerable for all these problems.
Yes.
And second worry is, you said high dose of statins. Unfortunately, in our area, people do not tolerate the high dose of statins, you see.
Yeah.
And most of them then complain about the leg pains and muscle pains and all that, you see. So there we find it very difficult. Then we have to, along with lifestyle management, you see, try to add lower dose of statin plus add some other non-statin sort of thing to control it, you see. Yeah. Otherwise, they will stop taking statins at all, you see, because of the side effects.
Definitely. So that's a very good point. Actually, if you see, many patients do not tolerate the high dose of statin. So you can just give them the low dose of statin. Along with that, ezetimibe plus bempedoic acid also you can add. So you can add 3 drugs. So low dose statin plus ezetimibe and bempedoic acid. So that is also proved by even in LA guidelines also they have clearly mentioned statin intolerant patients, statin, ezetimibe and bempedoic acid, so that triple drug combination will take care of most of your patients.
I think the time will tell, probably GLP-1 probably may be another sort of a drug in our sort of armamentarium, because not diabetes per se, they are helping lot of conditions like reducing weight and obesity and all that, and maybe they do help the lipids also.
Yeah, GLP-1 agonists, definitely they help in the lipid parameters.
Yeah.
Actually, like nowadays for obesity also GLP-1 agonists like semaglutide injectable is approved. So those drugs can help also in certain patients. Cost is there, definitely that is there. Yeah.
Okay, anyway, thank you very much.
Thank you all.
Just bear with us for next 2-3 minutes, because he is going to change the. Okay. The last session is dedicated to All India Institute of Medical Sciences. So all our speakers are from AIMS, Bathinda. The first speaker is Dr. Manjeet Kaur. She is head of the Department of Pathology, AIMS, Bathinda. And the topic is molecular subtyping of CA breast, present and future. Dr. Manjeet Kaur.
Good evening, everyone. I'm Dr. Manjeet. I study pathology, AIMS Bathinda. And I have been working in this area from last 13 years, and this topic is near to my heart, and I had been working in this area. So I'll try to express rather my feelings to my lecture. So I'll start with my lecture. So it's a molecular subtyping of carcinoma breast, the present and the future of the typing. So starting from the basic of the carcinoma breast, as we know, it's the most common carcinoma worldwide now, and arising from the ducts of the breast or can be from the lobules. So sometimes we say it's from the lobular carcinoma arising from the lobules, but actually the terms are misnomer. Duct carcinoma, lobular carcinoma can arise from any part of the breast. And in 2020, before that, we were thinking about like CA cervix is more common in the female. But now, CA breast has surpassed all the carcinomas, and it's a worldwide most common carcinoma in the female now. So global burden, you can see that it will cross the limits. It will cross almost 2 million by 2030. And initially, we used to say that it's a carcinoma of the developed countries and because of their lifestyle, but now maybe we are adapting that lifestyle in the developing country also, and carcinoma is now first most common amongst all carcinoma in female. But in addition to that, what we have seen that there is tumor heterogeneity also, because there is a difference in the presentation, there is difference in the molecular origin of the carcinoma, molecular presentation of the carcinoma. So that may be the reason in addition to westernization of the culture. So that's why molecular profiling, molecular typing of the breast carcinoma is more important nowadays, and everyone should know about this. And before I discuss the molecular typing or profiling of the carcinoma, we know that in this carcinoma, please. Okay. Approach should always be multidisciplinary, and although in some outside the institute sometimes it's not possible, but should be multidisciplinary with the combination of oncologists, radiologists, surgeons, surgical oncologists, and pathologists. And when we talk about the treatment part or the management part under the tumor board, these are the traditional prognostic markers that currently exist. So the traditional prognostic or predictive markers are histological type. If it is IDC, then definitely high grade is more risky. If it is mucinous carcinoma, histopathological type, prognosis is good, patient will have good survival, so depending upon that. If in the carcinoma breast, there is more extensive component of DCIS, when we see the report of CA breast, if we see extensive component of DCIS, then also the prognosis is bad in the patient. And lymphatic invasion, vascular invasion, whenever see this in the histopathological report, even without metastatic deposits in the lymph node, the prognosis of the patient will be bad in this case. And microcalcifications definitely will lead on to the bad prognosis. And next important part is the breast biomarker reporting that will report molecular profiling. So under this, what commonly we should see in the CA breast, because the CA breast is related with the hormonal expression, so we will look for the it's very normal, everybody is knowing this, that we will look for the ERPR, and we look for the HER2, we look for the Ki67 expression. So when we talk about the ER expression, so we have 5 grades depending upon the number of cells stained with the ER, or number of cells expressing the ER expression amongst whole of the tumor along with the staining of the cells. So in clinicians' knowledge, you can see from left to right, we have tumor cells in the blue color. And with the increase of the expression of the ER, we are seeing in the third number, there's little expression of the ER. In the 4, there's more, 5, then ultimately whole of the tumor is showing expression of the ER. Same is with the PR. So what is the meaning of this? So currently we are using this. So what is the meaning of this? It means that if we talk about the last one, 100%, so patient will have 100% response to the tamoxifen. That is the meaning of the profiling, what we do for the molecular profiling. The patient will respond 100% to the ER. In the zero expression, patient will not respond at all to the ER expression, and patient will have a bad prognosis. Same is with the expression of the stain. So this is section has been taken from the tumor of the tissue. We can see that all the tumor cells are showing brown expression in the A, and in the B there are lesser number of cells. Approximately 60 to 70% cells are showing expression for the ER. Means on the A side, 100% chances are there for response to the tamoxifen, and on the B side, patient will have 60 to 70% chances for response to the tumors, tamoxifen. Next is the HER2 new testing. So this is the present of the molecular profiling, present scenario of the molecular profiling. HER2 new testing, we know that HER2 is important for the breast carcinoma. If it is HER2 positive, we have to go for the FISH testing. FISH amplification is very, very important. Although it's a costly test, needs expertise, and it should be done. And FISH is gold standard for this. If HER2 is 3 positive, that means patient is again can have a medicine targeted therapy, and patient will respond to the treatment. So this is just to show how color of the or scoring of the HER2 will be done. But the important is the molecular profiling. This is the 5 intrinsic molecular classes of the breast carcinoma. Luminal A, starting with the luminal A to the triple negative. I'll not repeat all those what I have discussed, but there are 5 different classifications for the molecular classification or molecular profiling for the breast carcinoma. Starting with the luminal A, when ER/PR is positive, patient will have a good prognosis, and Ki67 is the proliferation marker. This should be applied. Sometimes we get reports done from the outside. We see that there is no Ki67 applied. So that should be applied, and molecular classification should be done in the patient of carcinoma breast. So low expression of Ki means good prognosis, means proliferation is less, prognosis is good. When we go downwards, in the second last, there is HER2 enriched molecular profiling. Definitely patient is ER/PR negative and HER2 positive. Last one is very dangerous, that is triple negative, and approximately 50 to 20% of the patient lie in this area. There is no ER expression, there is no HER2 expression, there is no any other treatment than simple chemotherapy. So in this, patient will definitely have a very bad prognosis. So this is the present scenario. We have to go for ER, we have to go for PR, we have to do HER2 new, Ki67. If HER2 is 2+, we have to go with the FISH. So this is a simple explanation of the molecular profile, what we see under this molecular profile. There are 5 types of classification of carcinoma breast under molecular profiling. This is what we have to do in future. Currently we are working on this. As we see in the first row, currently we know that ER/PR positive, give tamoxifen. If patient is HER2 positive, give medicine, okay? But what will happen to the triple negative breast patients? The triple negative patients in the second last row, you can see that this one, the genomic subtypes. This genomic subtypes depends upon the what type of gene is present in the patient. BL1 basically stands for the basal-like. BL1, BL2, M, MS, IM, immunomedullary type, LAR, and UNS. So from this, in the genomic profiling, further, in the BL1, BL2, we have basal-like carcinoma in the triple negative. So chemotherapy is being given to these patients. M and MS, there are metaplastic carcinoma. This metaplastic carcinoma can be identified even on the histopathological examination, and prognosis is bad. So prognosis is bad in BL1, BL2, M and MS in case of triple negative breast carcinomas. Okay, so in the IM and LAR, medullary carcinoma, luminal AR. Luminal AR is androgen receptive. Means this type of breast carcinoma is responding to the male hormones. So luminal AR is also there. Adenocystic carcinoma. So these carcinoma, they have less aggressive prognosis under the category of TNBC. So more problematic is UNS. UNS is unstable type of genome. So this should be the future of breast carcinoma. This should be the area of research in case of breast carcinoma. So what are the new lesions? People are working on these genomes, but as you can see that there are two type of factors are there always in carcinoma. One is prognostic, one is predictive. In prognostic, we can say that, okay, B1, BL2, they have aggressive prognosis. IM and LAR genome, if patient will have bad prognosis or good prognosis than, BL1 and BL2. But what about the prognostic markers? Predictive markers. Predictive marker means, can we develop treatment for these patients? Can we modify these factors? So yes, we can modify the factors for UNS patients, these patients, and also some other patients who are triple negative. So new addition was done by the American College of Pathologists. They have given now new classification because in case of low positive, ER positive tumor cells. Because when we classify ER positive tumor cells of breast carcinoma, we always give negative when there is only 1 to 10% expression of the ER in a breast cancer. Okay, now they have done the trial and they got to know that even in case of 1 to 10% of the cells staining positive for ER or giving expression of the ER, we can label that patient as low positive for ER, and we can give tamoxifen or we can modify the targeted therapy. So this is the future of the molecular profiling. And these patients are eligible for the endocrine treatment, means hormonal treatment. And in addition to that, very nice addition is in the Destiny clinical trials. So these the sixth trial now is going on, and under this, currently even in the present scenario, what we are doing is HER2 positive, 3 positive, 2 positive. Isse zyada we are not doing anything, but the patient who were score HER2 positive or FISH negative, we were ignoring those patients and we were categorizing those patients in the triple negative. But now the Destiny trials, they have said that we can categorize these HER2 low patients under HER2 low. We can categorize HER2 ultra low. So we can give now therapy to these patients also. So this is the addition in the current molecular profiling of the carcinoma breast, and this will be soon come under the NCCN guidelines and will be applied to the patients, and this will save the patient further, especially triple negative carcinoma breast patients. So this is about the unstable type of genome that comes under the triple negative. So PARP therapy, it's a PARP, sorry for the mistake. Inhibitors are being developed and that will be given to these patients, and trials are going on and showing good response. So this is just our experience, because whenever you are doing molecular profiling, you must have some external quality assurance program. You have to get registered somewhere. so that you can get to know that the profiling what you are reporting is good or not. So our department is enrolled under National Cancer Grid under TMH Mumbai by Government of India. And as I told you that I have been working in CA breast, and I had explained many a times to ICMR that there is huge tumor heterogeneity in this area. So because of that, they have given some funds to us, and we are working on this. And this is the data currently what we have got to know about this area. And good thing is that in our area, patients are presenting in stage 2, in the early stage. And patients currently, in comparison to rest of the India, our recurrence rate is now less because patients are getting treated well. So this is just to show the histopathological examination. If any pathologist is there, that person can appreciate. So luminal A type of carcinoma. This is luminal B type of carcinoma. And the different profile under luminal B, HER2 positive. And this one is luminal B, non-invasive, non-luminal type. And this one is triple negative. But in the D, you can see high proliferation positive for the Ki67. So definitely there will be bad prognosis. In these kind of patients, we can go for the low ER positivity. We can check HER2 low, we can check HER2 ultra low, and we can check unstable genome. So 3 possibilities are now available for triple negative breast carcinoma patients. So this is the new addition. This is being done in our department because FISH is a costly test in the HER2 cases and need expertise also. So we have one automated equipment, and with the help of that, we can do DISH. DISH is an alternative of the FISH. So this is our data in comparison with the other studies done in India and in joining countries. So in our scenario, we have more luminal B type type of carcinomas, and we have relatively lesser number of triple negative breast cancer patients in respect to other parts of India. So in addition to new additions, we can go with BRC, BRCA gene testing, NGS, Oncotype DX also. This is currently in use. Oncotype DX is just a simple test. With this, we can check that this patient will have metastasis in future or not, whether this patient requires chemotherapy or not. So on the basis of this, radiation oncologist or oncologist, they can decide that whether chemotherapy is required or not. And liquid biopsies are under trial only. So these are the future directions. So the personalized medicines, they can tailor the healthcare strategies to individualize the genetic profiling, increasing the effectiveness and efficacy of the treatments. So currently, we have new additions in the molecular profiling, ER low positive, HER2 low positive, and HER2 ultra low positive, along with unstable genome. Thank you. Thank you very much.
Thank you, ma'am, for the talk. If there are any questions?
Any question, please?
Thank you, ma'am.
Thank you.
It was very informative. The next talk will be by Dr. Rakesh Kakkar, Head of the Department of Community and Family Medicine, National Guidelines for Snakebite Management.
So very good afternoon to all. First of all, I would like to thank the organizers, especially Dr. Vidul sir, for inviting me for this important August gathering. And I will be discussing about the National Snake Bite Management. As on 18th and 19th, we have just done these sessions on snake bite awareness. The 19th is celebrated every year as a snake bite awareness day, and AIMS Bathinda is a regional center for One Health under National Program for Control of Zoonosis, and we have developed a capacity of diagnosing many zoonotic diseases like brucellosis, leptospirosis, scrub typhus, and we are expanding our horizon for detecting many more such diseases. And this is a regional center, so whole Punjab, Haryana and Rajasthan will be covered under this center. So as a part of this, now NCDC has included snake bite management also under this regional center. So earlier in 2009, it was snake bite was included in NTDs. Later it was removed, and again in 2017 again it was included. Now there is a target and of WHO worldwide, there is a target of reducing the death and morbidities due to snake bite by 50%, and India is also abiding to that. So there are 3 phases, and now we are in the last full rollout phase, and under this snake bite is a notifiable disease. Earlier it was not included, now it is included, and all the efforts are made to make this anti-venom available at all healthcare delivery level, that is PHC, CHC, district hospital and at tertiary care hospital, so that we can save life and by providing the anti-snake venom in a timely manner. So basically there are 4 type of snakes, or 4 type of venom. One is neurotoxic or neuroparalytic, which causes neuroparalytic effects like cobra or krait. Another is a vasculotoxic or hemotoxic effect, that is due to the Russell viper. Sea snake causes a myotoxic effect in our body, and rattlesnake causes a hemolysis, that is the RBC lysis and edema. So basic 4 type of snake venoms are there. So these are the common snakes which are found in our country. That is common krait, which is found all across India up to Assam, and this common krait causes a neurotoxic effect in our body. Russell viper is hemotoxic, and it is found all across Indian subcontinent. Then third one is the raw-scale viper, which is also again has a hemotoxic venom, which is found across Indian subcontinent except in West Bengal and northeast India. And the fourth is cobra, which is well known, found across Indian subcontinent except northeast India, and it has a neurotoxic venom. So many a times, around 70% time, even due to the non-venomous snake, sometimes death occurs due to the nervousness, due to the fear of snake bite. So it also depends on the amount of venom injected to a person. Sometimes even a venomous snake also doesn't inject sufficient venom to cause a death. So it depends on the time, and it depends actually on the many factors. So different species have a different type of venom, and it depends on the species of snake, geographical location, habitat, climate, and 3 type of venom, that is neurotoxin, causes a nervous system, mainly systemic symptoms of nervous system, and which lead to paralysis, respiratory failure, potentially fatal consequences are there. another hemotoxin mainly affect the our CVS, central vascular system, cardiovascular system. It affects the blood and causes coagulopathy, hemorrhage, and tissue damage. And third type is a cytotoxic, which damages the cell and tissues and causes local pain. So the common symptoms include, some are non-specific symptoms related to anxiety, and the other common symptoms include the palpitation, sweating, tachycardia, tachypnea, blood pressure and lowering, cold extremities, dilated pupil. So all these are related to the nervous system, and usually due to lot of anxiety and fear, these symptoms are easily evident. Now, sign and symptom depends on amount of inoculum added by the snake. So if the exposure is much, then amount will be more. It also depends on the site where the bite actually happened. It depends on the age of the patient, weight of the patient, and biochemical variability of the venom. So there are different type of venoms. And it also depends on the person to person, that is the response of a person, the behavior of a person, as well as the body composition, or the actually different people react to different thing. So now we'll cover these main poisons, that is what are the local features and what are the systemic effect. So coming first to the neurotoxic effect. So first we can see the bite of fang marks can easily be seen in a patient. Then there is a acute burning pain at the site or adjacent area. There is a swelling and discoloration, and serous sanguineous discharge from that area. Now there are again the two stages, the pre-paralytic stage and paralytic stage. In pre-paralytic stage there is a vomiting, headache, giddiness and weakness. So this stage is important for the identification. If we can identify the type of snake, if a person is having a photograph of a snake, or it is advised not to catch the snake or not to waste the time in catching the snake. So if the specific snake is identified, so we can give a specific antivenom. So in paralytic stage we can see there is ophthalmoplegia, drowsiness, convulsion, bulbar paralysis, and respiratory failure and death. So basically we can divide this symptom into 5 Ds and 2 Ps. 5 Ds, that is dyspnea, dysphonia, dysarthria, diplopia and dysphagia. And 2 Ps, that is ptosis and paralysis. Now coming to the next, vasculotoxic or hemotoxic effect of venom. So local features include rapid swelling at the bite site, and discoloration, blister formation, and bleeding from the bite site. So if there is a excessive oozing of blood, then the person has been bitten by the vasculotoxic venom. So systemic effect include generalized bleeding, that is epistaxis, hemoptysis, hematemesis. So you can see, well appreciate in the picture, that is gum bleeding after the snake bite. There is acute shock, and person ultimately lands up into the renal failure. Then the third type is myotoxic effects, that is local features include local swelling and pain, and systemic feature include myalgia, muscle stiffness, myoglobinuria, and renal failure. These are the common manifestations, that is local effects. If we cannot identify the type of snake, but these are the common sign and symptoms, that is pain, swelling, bruising, and tissue necrosis at the bite site, leading to complications such as compartment syndrome, and later there are chances of secondary infection. And systemic effect include range of symptoms including neurotoxicity, hemotoxicity, cardiovascular instability, coagulopathy, renal impairment, and respiratory failure. So these are the certain investigations which are recommended, but there are some very easy investigation which can be done at any site. I'll discuss those investigations also beside these. So prognosis depends on the time of bite, that is how much time has elapsed, and it is recommended that within 2 hours if the antivenom is provided, then it will be very beneficial. It improves the prognosis of a patient. Then activity at the time of bite of a person. First aid action provided, taken since the bite, clinical examination, and this is the 20-minute whole blood coagulation test. So in this test we simply place 2 ml of freshly sampled blood in a glass container, not in a plastic container. Otherwise there are chances of false test positivity. So we have to simply place the 2 ml of freshly sampled blood and leave undisturbed for 20 minutes at ambient temperature till the vessel warms. If the blood is still liquid after 20 minutes, then it is a sign of hypofibrinogenemia, that is it is an incoagulable blood as a result of venom induced consumption of coagulopathy. So in Southeast Asian region, incoagulable blood is diagnostic of viper bite, and it rules out lapid bite. So now coming to the management part. So we can manage the snake bite in 3 ways, that is by providing a local management, specific management, and supportive management. So the important and the key messages are by providing a first aid treatment. So it is not recommended to wash the bite site, rather than we have to transport the patient immediately to the hospital by immobilizing the bitten part. So it is not now recommended to apply the ligature. बहुत strict वाला compression नहीं देना, so we have to avoid that. Just wrapping the site and immobilizing the site is important. Then rapid clinical assessment and resuscitation. So ABC management rules we can follow. Detailed clinical assessment and specific diagnosis we have to make. Laboratory tests we can do. And the most important thing is providing an anti-venom treatment in a timely manner. Then observing the response to anti-venom. So it depends on the bite to bite. So we can categorize the bite in mild, moderate, and severe type, and depending on that we can give the amount of anti-venom vials. So deciding whether further doses of anti-venom are needed or not, supportive treatment, treatment of bitten part, follow-up, and rehabilitation. So these are the key broad guidelines. Now coming to the snake venom specific treatment, that is there are overt bite and there are occult bite. So in occult bite, if there is person has not seen the snake and there is no history evident that whether it is a snake bite or not, so chances are there that it is due to the crate bite if we see neurological symptoms. So if neuroparalytic symptoms are there, with no local signs, severe abdominal pain and vomiting. So we can give anti-snake venom, atropine, neostigmine, and ventilation. So these are recommended for such cases. For asymptomatic bite, if there is only anxiety, palpitation, tachycardia, and paresthesia, so we have to observe the patient for 24 hours, and if everything goes well, then we can discharge the patient. Same is in dry bite cases. But if there is a symptoms are developing, so we have to categorize the person on the basis of certain features, like if it is having a progressive painful swelling, then chances of viper bite is there. That is local necrosis, ecchymosis, blistering, painful swelling, and compartment syndrome. Then we can give anti-snake venom. And if the bite is by cobra, then there are chances of neuroparalytic syndrome. That is again 5 Ds and 2 Ps. That is ptosis, diplopia, dysarthria, dysphonia, dyspnea, dysphagia. So again, anti-snake venom, atropine, neostigmine, and ventilation we have to give. In case of Russell viper or saw-scaled viper, there is a vasculotoxic symptoms are there. So there is excessive bleeding from the bite site, demonstrable coagulopathy, shock, acute kidney injury. Again, we have to give anti-snake venom, supportive treatment, dialysis, and blood transfusion is also required in many cases. Due to snake, flat-tailed snake, sea snake, chances of myotoxic symptoms will be noticed. That is muscle ache, muscle swelling, compartment syndrome. So again, anti-snake venom, supportive treatment, and dialysis will be required. So there is another mnemonic, that is do it right. So right stands for R is reassurance of the patient. So 70% of the snake bite are due to the non-venomous snake. So grossly reassurance is required, and only 50% of bites by venomous species actually we have to envenom, we have to give the anti-snake venom. Other I stands for immobilization. So we have to immobilize the patient, and we have to send the patient to the hospital immediately, and do not waste time in traditional therapies. And then tell the doctor of any systemic symptoms while coming from site where the snake venom, where we have the person who is bitten by the snake, to the physician. So we have to notice what are the symptoms are being developed. So it will help in selecting the what kind of snake anti-snake venom we have to provide to the patient. So certain dose, that is assure the patient, immobilize. Traditional remedies have no proven benefit, and do not attempt to kill or catch the snake. Do not wash wound or interfere with a bite wound. No incision, suction, or rubbing. Like we have seen many movies where person try to suck it from the mouth. So those type of practices are actually not required. No ligation is required. No application of ice, massage, or any chemical treatment is required. So do not tie with a tourniquet, or as it can cause gangrene. So reassure, immobilize, go to hospital, and tell to the doctor. So this is how we can immobilize the site. So ligatures may be dangerous. So we can do not put all these dressing in a soft wrapping. So, and it due to tight ligature, possibility of gangrene is there. So, no ligatures are required. And such type of laryngeal mask airway can be used. In such type, there is no need of no laryngoscope is actually needed in such cases, so we can use laryngeal mask airway. So after applying the basic management for in ABC, that is airway, patency, breathing and all, then we can administer atropine and neostigmine before transferring the patient to the hospital. Then tetanus toxide is required for both venomous and non-venomous snake. And then if there is no symptom in 24 hours, patient can be discharged. So discourage the use of ineffective and potentially harmful drugs like corticosteroid, antihistaminics or heparin. So now specific treatment of anti-snake venom. So what are the indications of anti-snake venom? If there are spontaneous systemic bleeding or the whole blood clotting time is more than 20 minutes, there is a thrombocytopenia or shock or paralysis or acute renal failure, rhabdomyolysis or local swelling and rapid extension of swelling. So in such cases, anti-snake venom should be used promptly. So these are the 4 snakes where anti-snake venom has a definitive role. It was first, the first anti-snake venom was developed by the Albert Calmette against the Indian cobra. And the primary purpose of anti-snake venom is to neutralize and eliminate the venom's toxic components from victim's bloodstream. So in mild cases, only 5 vials or 50 ml is required. In moderate cases, 5 to 10 vials, and in severe cases, 10 to 20 vials. And addition of additional infusion depends on the response. If person is responding well to the snake venom, and we can add more vials if we see improvement. So anti-snake venom can be administered slowly IV through IV injections or infusion at the rate of 2 ml per minute. So ASV should never be given locally at the site of a snake bite like we do in rabies. So it should not be given locally. So there are different type of anti-snake venom, that is polyvalent, that is covering a broad spectrum of snake venom. If we are not sure that what type of venom is there, so we can use polyvalent. If we are specific, then we can use a monovalent antivenom. If there are chances of confusion, then we can use bivalent. So it depends on the availability. So in healthcare delivery system where we have limited resources, then we can use a polyvalent antivenom. Or it also depends on the region specific. If we have more of vasculotoxic or hemotoxic, then we can keep such type of venoms available. So anti-snake venom sensitivity is now not recommended. Earlier we used to do first anti-snake sensitivity, anti-snake venom sensitivity. Now it is not recommended. There are certain local adverse reaction and due to anti-snake venom, but if we weigh, then we have to save the life, so we can very well address these adverse reaction. So early anaphylactic reaction which were seen within 10 minutes to 3 hours It includes urticaria, diarrhea, tachycardia, fever and hypotension, and late serum sickness syndrome which develop 1 to 12 days after the snake bite. So it includes fever, nausea, vomiting, diarrhea and arthritis, nephritis and myoglobinuria. So for covering the treatment of early snake venom reaction, we can give adrenaline 0.5 milligram in adult in 1:1000 dilution. Antihistaminics and IV hydrocortisone can be given for treatment of early snake venom reactions. So anti-snake venom, antihistaminics and prednisolone can be used in late anti-snake venom reactions. So there are certain challenges about the availability of these anti-snake venom across our healthcare delivery system. There are certain side effects and even in certain cases we have noticed a resistance, that is development of resistance to anti-venom. So supportive therapy include the certain like for coagulopathy, if not reversed after the snake venom therapy, then fresh frozen plasma has a role, or even the cryoprecipitate can be used, fresh whole blood can be used, or platelet concentrates can be used. For bulbar paralysis or respiratory failure, where anti-snake venom is not sufficient, then we have to give a supportive therapy in the form of tracheostomy, endotracheal intubation, or atropine and neostigmine, or the glycopyrrolate in place of atropine before giving neostigmine. Or antibiotic prophylaxis or anti-tetanus serum can also be used in a bit, for providing the care of bitten part. So finally, conclusion is snake bite pose a significant threat to the human health, requiring prompt and appropriate intervention. The administration of anti-snake venom remains the most effective and life-threatening treatment for envenomation. So timely access to medical care, proper identification of snake species. So all actually clinicians, if there are a very easy sign of identification of snakes, so there are 3-4 cardinal signs, but if we'll not get the opportunity of seeing the snake, then we have to depend mainly on the sign and symptoms which are developed after the venom. So public awareness and education is very important, and in recent national guidelines it has been recommended to make public aware of such early measures and do not waste time in tantrics and all. So continued research and development is required. So be confident to manage the snake bite. Most of the snake bites can be managed at primary healthcare levels also. Do not kill time before anti-snake venom administration. So thank you.
Rakesh Kakkad for highlighting the national guidelines for snake bite in a very, very simplified way. And my question is, you see, what is the basis for immobilization the part, you see? Why you want to immobilize the part?
So that अगर हम इसको बहुत ज़्यादा टाइट कर देते हैं तो गैंग्रीन,
टाइट तो करना
अगर
नहीं है।
लूज करने से वो है कि ब्लड सर्कुलेशन बना रहेगा, बट फास्ट सर्कुलेशन, पॉइजन जो है वो फास्टली नहीं फैलेगा
बाय इमोलाइजेशन।
हाँ, इमोबिलाइज करने से।
The second is how the criteria mild, moderate and severe you see at the time of admission.
It depends on the severity, कितने सिस्टमिक इफेक्ट डेवलप हो रहे हैं, मतलब जो पेशेंट है
Are there any parameters or just you see by the clinical sort of a thing?
Clinical judgment we can, depending on the type of venom, that is what type of symptoms person is developing. There are certain stages that pre-paralytic and paralytic. So pre-paralytic में पूरे signs symptoms evident नहीं है, so it is a mild case we can assign.
Because I'm asking you this question is, so how you calculate that this patient needs further dose, you see? Again, that
So,
depends on the...
Anti-snake venom has a definitive role. So if we have started administering the anti-snake venom and patient is responding to it, then until all these symptoms subside, we can give. अगर respond नहीं कर रहे हैं, so there are chances कि वो जो anti venom है उसमें resistance है या it is due to some bite which is we do not have specific treatment to that venom, so we have to give some alternative treatment.
Do you have only one single this snake venom thing, antidote for all the snake bites, or you have a different?
There are different type of snake.
But you have only one here at AIMS, or you have different ones?
Right now we state government is helping us for providing that, and it is broad spectrum type of, so it is covering entire.
Irrespective of type of snake, which is...
Yeah. So NCDC is expanding its guidelines, and maybe if we'll get more specific treatment to that or more specific antivenoms, then it will be more helpful.
So how many sort of patients you see per week, per month you see of snake bite at your sort of institute?
At present it is not very frequent.
But otherwise it's quite common.
Yeah.
You go into the interior of the villages and all that, you say.
So now recently we have started keeping antivenom and all treatments for this. So record keeping will be done, and later we will come with definitive epidemiological things.
Any other question, please?
One simple thing which I came to know that by venom we can identify what specific venom, anti-snake venom we can provide. So if it is washed, then it will be difficult if patient has not brought any picture or snake with it. So it will be difficult for the clinician to identify with what type of anti-snake venom to be provided to that person.
Do vitamin K has any role?
Yeah, for
coagulopathy.
Coagulopathy, where there is a coagulopathies are there, and definitive means supported treatment we have to provide.
There are a lot of medicines being sort of manufactured or extracted from snake venoms. About 10 years ago is the first injection streptokinase used for thrombolytic therapy, again comes from snake venom only. So they do have a positive part also.
And there are other roles of this anti-snake venom also, beside snake bite.
Thank you very much. Thanks. Hello friends, somehow Dr. Kamaljeet Singh Koda couldn't make it, so in place of Dr. Koda, from their own department of urology, Dr. Abhishek Chabda. He is going to talk about the Transplantation of Human Organs and Tissue Act 1994 implications in Punjab. Dr. Chabda, please.
Thank you. I am Dr. Abhishek Chabda. I will be presenting the Transplantation of Human Organs and Tissue Act on the behalf of Dr. Kawaljeet Singh Koda. Sir is unable to come due to some unknown reasons. Now, coming to the numbers, approximate 1.5 lakh the annual deaths are there from road traffic accidents per year in India. They can be the potential organ donors in the India, but unfortunately we have less than one donor per million population. Organ donation rates are there, and the Spain's rates are highest in the world with the 48 per million organ donors per population. And fortunately we have improved our statistics from 2012 from four times higher than the initial rates, which was 0.16 per million population to 0.64 in 2023. The legal framework evaluation, this act was originally initiated in 1994, started as a Transplant of Human Organs Act, which enacted in 1994 to regulate organ removal, storage, transplantation, while preventing commercial dealings. It was adopted by all states except Jammu and Kashmir and Andhra Pradesh, which maintained their separate state legalization for same. But the major amendment which came in 2011 and become effective in 2014 renamed it as THOTA, the Transplantation of Human Organs and Tissue Acts. It's expanded the scope to include the tissues apart from the organs, and it included the expanded donor definition, and it enhanced the penalties for the illegal organ trading. The key amendments under the 2011 scope was expanded scope. It includes the tissues along with the organs, and the definition of near relative was expanded to include the grandchildren and grandparents also. And the new provisions and operational improvements were there, like if there is no facility of, if the hospital is not having facilities to start a transplant surgery, they can still register for being a retrieval center. And swab donation was also approved, and there was a provision of transplant coordinator in all the registered hospital. It was mandated. And under this act, national network was established, and there was a national registry for all the transplant recipients and donors. And enhanced protection provisions were there, higher penalties for organ trading, simplified brain death certifications, and greater cautions for minors and foreign nationals were included. Key provisions of the acts are infrastructure, equipment requirement, and guidelines and SOPs was defined. Qualification of the transplant surgeon and tissue retrieval technicians were defined. Appointment of transplant coordination with defined qualification is mandatory now in the all transplant centers. NGOs, trust, and the societies working for the organ and tissue removal now have to register with the National Organization for Transplantation Act. Another new provision of the act is it identifies the brain as a death or form of death. It outlines the process and criteria for brain death certification. It also allows the transplantation of human organs and tissue from the living donors and the cadavers after cardiac and brain death. Living donors can be defined as the near relative living donors, spouse, children, grandchildren, siblings, parents and grandparents needs the permission of doctor in charge of the transplant centers to donate his organs. And a non-related donors needs the permission of authorization committee established by the state of the organ, donate his organ. Now the next thing is swab transplantation. When a near relative living donor is medically incompatible with the recipient, the pair is permitted to do a swab transplant with another unrelated matched or donor and recipient pair. Now comes the authority, appropriate authority, which is in most cases a regional or organ transplant approval committee, inspects the grants registration to the hospital for transplantation and forces the required standards for hospital, conducts regular inspection to examine the qualify the quality of transplantation. It may investigate the complaints regarding breach of provision of the act, and has the power of a civil court to summon any person request documents, issue search warrants. An advisory committee is consisting of experts in the domain who shall advise the appropriate authority. Next is authorization committee, which is usually an institutional committee which regulates the living donor transplant by reviewing each case to ensure that the donor or the family of donor is not exploited for monetary consideration and to prevent the commercial dealing in the transplantation. This proceeding has to be video recorded and the decision should be notified within 24 hours. Appeal against any decisions of the committee may be made to the state or central government at any point of time. Next is the medical board. The panel of doctors responsible for brain death certification in case of a non-availability of a neurologist or neurosurgeon, now any surgeon, physician, anesthetist or intensivist nominated by the medical administration in charge, which is usually medical superintendent of hospital, may certify the brain death. And authorization of organ donation after brain death, if a person wants to donate his organs after the brain death, that he himself or herself can give his consent before in his living state, or this consent can be obtained by the person in the legal possession of the body, and the doctor shall ask the patient or relative of every person admitted in ICU whether any prior authorization has been made. If not so, patient or his relatives should be made aware of the option to authorize such a donation. And sources of the donors, sources of the transplant are, number one is living donor, which most of the donations in India is happening by living donor only. There are three categories: near relative donors, non-relative donors. Near relatives includes mother, father, son, daughter, grandparents, or brother or sister, suppose. Non-related donors must demonstrate affection, attachment, or special reason without authorization, with authorization committee approval, and swab donors. And next is deceased donor transplant, which can be a brainstem death donor, which is most practical or option. Victim of accidents where brainstem is dead, organ remain functional through life support systems. Cardiac death donors are limited to certain tissue in current scenario like blood vessels, heart, cardiac walls, skin, or cornea. The living donation is actually a immediate solution, but the deceased donor have a greater potential for meeting organ needs without receiving living donors. What are the critical challenges in organ transplantation in India? There is massive supply demand crisis, huge burden of organ failure cases versus the poor availability of donors, infrastructure gaps, especially in the government sectors, transplantation challenges, especially in the interstate organ transportations, awareness barriers are there, lack of understanding of public about the brainstem death concept, also the poor certification practices by the hospitals. Systemic issues, organ trading concerns, state reluctance to adopt the amendments, and gaps in data reporting and owner registry entry. Economic barriers are there, high cost, especially the uninsured and for the poor population, and maintenance of transplant standards. This is a complex web of issue. It requires coordinated solution across legal, medical, and social dimensions. And the Government of India has launched the National Organ Transplant Program in 2021 to systematically address the organ shortage through comprehensive institutional mechanisms. According to this program, there are 3-tier institutional network has been set up. The apex body, which is in Safdarjung Hospital, New Delhi, is called as NOTO, National Organ and Tissues Transplant Organization. And the regional bodies, there are 5 regional bodies covering multiple states, and there are 22 SOTOs have been sanctioned, state level organization for local coordination. This network creates from national policy making down to state level implementation, ensuring coordinated organ donation and transplantation services across India. These 5 regional organizations are Western region Mumbai, Southern region Chennai, Eastern Kolkata, Chandigarh Northern region, and Guwahati Northeastern region, and each was receiving 81 lakhs annual grant, which is increased to 1.6 crores in 2014 amendment. And there have been 22 state organizations have been sanctioned, and the comprehensive functions of this network is regional coordination, training program, institutional activities, technical guidance, and biomaterial center establishment across all the networks. This program addresses the huge bridge and supply gap improve access, efficient procurement of the tissue retrieval from the deceased donor and distribution, and also addresses the infrastructure developments for the new facility and strengthen the existing facilities and transplant centers. And also there is a provision of training of the manpower and monitor services for the continuous improvements. These are the various forms available on the NOTO website for different purposes, including consent from the near relative, suppose, other than near relative, consent for the psychiatric evaluation, HNA DLA profiling. Everything is now digitalized and all can be accessed on the website, and these all consents are also available in the regional languages on the respective state organizations' websites. This is a prototype form which any hospital, if wants to register as a retrieval center, they can apply, duly signed by the head of the institution. This is the basic prototypical form. And NOTO have enhanced the digital infrastructure, national registry, and policy development. The functions of NOTO are policy guidelines and protocols development, web-based networking, national registry maintenance, advocacy, awareness and training coordination, research and information dissemination, and national biometal center operations. The key achievements till date are dedicated website for transplant, 24/7 helpline number, and national registry has been maintained digitally with number of pledged donors and waiting list, and organ allocation policies have been approved, SOPs have been drafted, which all data is available through the website. These are the 5 regional organizations. Western Roto is situated in the Seth GS Medical College, Mumbai, covering Maharashtra, Gujarat, Goa, UT, Dadar Nagar Haveli, Daman, Diu, MP and Chhattisgarh. Southern Roto is Government Multi-Speciality Hospital, Chennai, covering Tamil Nadu, Kerala, Telangana, Andhra, Karnataka, Puducherry, and Andaman Nicobar Islands and Lakshadweep. In eastern side, IPGMR Kolkata is the regional center, covering West Bengal, Jharkhand, Sikkim, Bihar and Orissa. In the northern side, PGI Chandigarh is the regional center, covering Punjab, Haryana, Himachal Pradesh, JNK, Chandigarh, Rajasthan, UP and Uttarakhand. And northeastern side, Guwahati Medical College, covering Assam, Meghalaya, Arunachal Pradesh, Manipur and Nagaland. These are the state organizations which have been sanctioned and funded by the national organization. Total 22 have been sanctioned so far. The status report, a living in 2023, the living donor after the age of 18 years or above can donate either one kidney or a part of liver only, but one brainstem donor can donate up to 8 organs, namely heart, 2 lungs, liver, 2 kidneys, pancreas, small intestine, and many tissues like cornea, bone, skin, and heart valves. A donor after natural cardiac death can donate only tissues like cornea, bone, skin, and blood vessels. These are the organ donation trends in the NOTO's annual status report 24. The number of transplants, total transplant in India, have rise from 4,990 to 18,378 over the past 10 years up to 23, with a dip in 2020 and 2021 due to COVID pandemic. And total living transplants rise from 4,153 to 15,435 over the past 10 years. Number of deceased donors, which was 340 in 2023, rise from 340 to approximately 1100 in 2023. Total deceased transplant which happened out of these deceased donors was 837 in 2013 to approximate 3000 in 2023. Number of deceased donor, total deceased transplant is in 2023, number of total deceased donors was 1099, and total transplant made out of these donors was approximate 3000, which was average transplant per deceased donors was 2.67. This is the transplant status report from the different organs, and total transplant done was 18,378 in 2023, and out of which 1600 was deceased kidney transplant and 11,000 was live kidney transplant, and 840 was deceased liver transplant, and 3600 were live liver transplant, and with 8 Domino's liver transplant. We are very far behind in cases of heart, lungs and pancreas transplant from the global average. In the gender distribution of living organ transplant in 23, the majority of donors were female, and one transgender was there as a donor. In deceased donor transplant, majority are males, comprising 77% out of total transplant made in a 2023. Coming to the organ-wise data, kidney transplant happened in 2023, total 13,426, out of which majority were living transplant. And number of kidney transplants happened in 2023. The Delhi NCR was the highest number of living kidney transplants, and with our state Punjab scored on the 10th, comprising 602 transplants happened in the 2023. Liver transplant, total 4,400 were done in Pan India, out of which majority were living transplants. Pancreas, there are very few cases done in our country, with Maharashtra doing maximum transplant. Lung, Telangana outscored every other state in 2023 with maximum number of transplant. And heart transplant, also Tamil Nadu outnumbered every other state with total number of 70 transplant in India. Coming to the state-wise score, Delhi NCR top scored in 2023 in living donor transplant. Number of deceased transplants were highest in Tamil Nadu. And future vision of this policy, the government of India is committed about the one nation, one policy. The reforms have been made and sent for the implementation to the state. Condition of state domicile for registration of recipient to receive deceased donor organ for transplant has been removed in this new amendment. Upper age limit for the registration of recipient for receiving deceased donor has been removed. Now a person of any age can register for receiving deceased honored organ, and no fees has to be charged by the hospital for registration of the patient receiving deceased donor organ. And uniform organ transport policy has been laid down by the government. 7 ministries coordinated by the Niti Aayog, Ministry of Civil Aviation, Housing and Urban Affairs, Railways, Transports and Port and Shipping, Waterways, Home Affairs and Defence. Each concerned ministry will have a nodal officer, and the state organ transplant organization will coordinate with that nodal officer to facilitate the transplant program. And there will be no screening of, under this act in amendments, there will be no screening of organ done at the airport, and metro rules have been revised to allow the transplant of human organs in May 2023. These are the financial grants which is given to the regional societies or state societies by the national organization. Approximate 1.6 crore for the regional societies annually, approximate 80 lakhs for the state societies annually, and for setting up the retrieval center, 75 lakh grant have been sanctioned annually for retrieval center, and for transplant center 1.5 crore annually, and so on. And financial support, current financial support to being given to the patient is 10,000 per month for BPL transplant recipient, 4 immunosuppressant drugs, 1 lakh per deceased donor maintenance, 50 to 100 lakh for new or upgraded transplant center and transplant coordinator hiring support, and 1 crore for the biometal centers. Awareness initiative, we must focus on poster competition, walkathons, media campaigns, corporate outreach, schools and educational institutional outreach. And everybody can pledge for organ donation on the website. There is a single website available nowadays, noto.gov.in. Till now, this is the yesterday's data, 4,32,227 donors have pledged for their organs. Thank you.
Thank you, Dr. Chabra. To me, I think it's more of a legal thing rather than the medical part, you see. I mean, all of the 20 minutes, I couldn't make much out of it. The other thing, I think there are too many sort of ifs and buts in our this Act of 1994, Organ Transplantation Act. I think it should be made more simplified, and probably there are so many lacunas in it. You see, the government should look into it rather. Being medicals or people who are behind this all sort of advisory committee, because I know 2 families, one lady and one gent. You see, the lady's husband, he was ready to donate his kidney. It took almost 1 year at PGI for all the formalities to complete. I think, you see, it is very difficult, you see, to just go there every day or every sort of a week, you see, to complete all these formalities. Same way, there was another man, you see, and his wife was ready to give the kidney, and it took 1.5 years for all the formalities to complete before they went for the organ transplant. I think these are all the problems you see we are facing for the organ transplant. The other thing is, I think the government should give a license for the cadaveric transplants. And to be honest with you, the cadaveric, this issue of organ transplant will not be solved very easily. Because living donor transplantation, I think organ transplantation is very, very difficult. That's my feeling. Any question from the audience, please? Thank you. So we have come to the last lecture of today, and that is by Dr. Oh, sorry. आप आ गए, मुझे पता नहीं. Next lecture is by Dr. Monica Kakkar. As we all talk about artificial intelligence in these days, so the artificial intelligence has gone to the labs also. So she is the additional professor in the Department of Pharmacology at AIIMS. So she is going to talk about AI in labs, a revolution in inclusion. Dr. Kakkar, please.
Thank you, sir. At the offset, I would like to thank Professor Vitul sir for giving me and the organizing team, of course, for giving me the opportunity to present here today. Well, I'm Dr. Monica Kakkar. I'm additional professor at AIIMS Bathinda. I am working in Department of Biochemistry, and that is why I took this opportunity to look at the contributions and as to how AI can contribute in the positive sense towards better functioning of the laboratories. AI has come up with a big bang. That's one thing, but it is also like a double-edged sword. You know, part of the academia thinks it's a boon because we have seen it can ease out on our work. It can help us do our things faster, more efficiently, and prioritize where we can escape from the daily routines and concentrate more on where the expertise is really required. I, from the laboratory, just citing one example, with the equipments in, like, we are doing potassium estimation. So the present day equipments will only tell you that when the sample is put in, that the potassium is high for this particular patient sample. However, it will not tell you why. So when it is integrated to AI, it will tell you whether it is because of hemolysis, whether it is due to contamination, or if it has access to the history of the patient, can also give you a correlation to the history, whether it is relating to the history. So that's a boon. Having said this, it can be a bane as well. So a part of academia also believes that it can be troublesome, especially since it's a new thing. We don't have really too stringent guidelines in place. Rather, we don't have many guidelines. And especially looking at countries like us, where we tend to follow others. So once we started using ChatGPT, Google, so the patients would simply look at, go to Google search, put up their symptoms, come up with medications, start self-treating themselves, and there are cases being reported where they have ended up into harming themselves, maybe even costing their lives. So yes, it has its limitations as well. So I would put that in perspective, in the sense that whether it's a blessing or a curse, it depends on how we are using it. So with that background, I would start my presentation. In that, I would be touching on introduction to AI, what AI has a role in the laboratory, what are the pros and cons, and end of it, I would summarize. So first of all, the history, we have to know where the whole thing started. So if we actually look at references of AI, it has dated back to ancient times, wherein there are references and myths and folklores where people have mentioned of some artificial objects which are related to similar, showing similar results as to human intelligence. However, it was only in the 50s where Alan Turing, he first gave the Turing test, wherein he provided a method to study to prove that machines can have intelligence also. They can show intelligent behavior. So what he did was basically he was giving same kind of questionnaires to a person and the machine, and then the results were being compared. So he was able to demonstrate that the machines can show intelligence similar to that of humans. However, it was only in 1956 that the first time artificial intelligence word was coined. That was coined by John McCarthy and his colleagues. And from there on, the journey started. There were times known as the first and the second winters, wherein it was on the work on AI was on its low, majorly because of probably the investment, because it requires a lot of investment into it, and people didn't have much understanding as to what to do with it. So since then, it has picked up and never looked back. So today we have reached a stage where we have, Tesla has self-driven cars, and we have ended up having superhumans. So much of information, what to do with it. So first, an understanding of what is AI. So artificial intelligence, it refers to computer systems that are designed to perform tasks that are typically requiring human intelligence, such as learning, problem solving, and decision making. So artificial intelligence, artificial and intelligence. So we have created intelligence artificially put together, and that's known as artificial intelligence. So intelligence means the capacity to learn and solve problems. And when it is simulated, that becomes artificial intelligence. So artificial intelligence is the simulation of human intelligence by machines, the ability to solve problems, act rationally like humans do. So are we suggesting that AI is just another software? Well, the answer is no. So what is the difference between artificial intelligence and the traditional softwares which already exist in place? So if we go by definition, AI, it can learn and adapt. So it's pretty dynamic. Whereas the traditional softwares, they follow the fixed rules. As regards to AI, learning, it improves over time. Whereas in traditional softwares, they need manual updates, like we have on our phones every time they are requiring updates, whereas that doesn't happen when you're using AI. Decision making, for decision making, it can think and predict, whereas traditional softwares do what they are already told to do. The AI can adapt to new data, so as and when a new data is coming, it is getting intelligent, and it is able to use that data, translate it into, every time it's growing, it's updating by itself. Whereas in traditional softwares, it stays the same unless it is updated. Examples are ChatGPT, which most of us are using, ChatGPT, Siri, etc. Whereas in traditional softwares like Excel and web browsers. So now type of artificial intelligence, it is broadly divided into capability-based and functionality-based. So capability-based are further divided into narrow or weaker AI. So basically, how much close or how much higher in terms of intelligence it is, that gives its name. So narrow or weak AI is better than human intelligence, but not that good. whereas general and strong AI is better than the human intelligence for sure, but it has its own limitations, whereas super AI is meant for superhumans, so they are far more better than human intelligence. Coming to the functionality-based types of AI, could be reactive machines wherein it does not store much data, it doesn't understand, so the reaction is very quick, within seconds it gives you the information. Limited memory AI, it can give you certain understanding and can store data to some extent. Theory of mind AI goes a little step further. It can give you an understanding and it can upgrade the results and provide you the data. Whereas self-aware is a newer inclusion, it is a futuristic approach where in the self-awareness component has also been incorporated, still under study. Just two slides on machine learning. So what we are looking at is, we have data. Now, so we want somebody else to process that data for us. So that's what machine is doing it for us. It's learning and processing that data. So that would include learning, improving on that, bringing in algorithms, data mining, then analyzing that data, classifying as to which kind of data are we getting and how the algorithms are to be developed, and finally creating those neural networks. Those neural networks are used for deep learning. So just a few newer terms we have come across. Artificial intelligence is a broader spectrum which covers the general terms for machines capable of perception, logic, and learning. When they are using algorithms to learn from the data to make predictions and decisions, then it becomes machine learning, and the performance will increase when the data input is increasing. So essentially it is depending on the data input. Like in laboratories we say, we work on GIGO principle, garbage in, garbage out. So whatever, how much ever good the data is, the results would be good, irrespective of course, you have to maintain the laboratories. In the flip side, if I say, how much ever the laboratory is good, if the data, if the input is not good, if the sampling is not good, how much ever we do, we will not be able to produce good results. So machine learning essentially would also depend on the data which is being provided to it for its learning. And deep learning, it develops those algorithms. So it uses multi-layered neural networks to build algorithms to find the best ways to perform the work. So this would involve inputs, then multi-layered areas wherein deep learning is happening, there are neural networks, and finally the output. With this, I will come to the area I am from. I'm a biochemist, so I'm essentially concerned with the laboratory services, and that is the topic for discussion today. So in the laboratory, we divide the functioning of the laboratory into three phases, rather 5, I would say. Pre-analytical, analytical, post-analytical, and post-analytical. Now, if you're looking at the broader terms, pre-analytical, analytical, and the post-analytical phase. Most of the errors which happen in the laboratory are in the pre-analytical phase. That pre-analytical phase would include, would include actually preparing the patient for the said test, selecting the right kind of test, and then doing the test, I mean in the sense, taking the sample, transporting it to the laboratory. Once it is taken up by the laboratory, then the analytical phase starts. So before that, it is the pre-analytical phase. Then once the laboratory takes the sample, it sends it for processing. Once the processing is done, the results are there, it is the analytical phase. What happens to the result thereafter is the post-analytical phase. So post-analytical phase would be would include whether if you have done some dilutions, there are some calculations involved, whether they were done or not, whether the physician did took the history of the patient in perspective, whether the interpretations were done right, whether the TATs were followed for that part, whether timely, if there were alerts, they were informed to the concerned physician or the patient, since they are the major stakeholders here, and time. So that would become the part of the post-analytical phase. Now looking at the functioning of the laboratory, we can very well appreciate that 62 to 76% of the errors happen in the pre-analytical phase. Around 6 to 15% of the errors happen in the analytical phase, and 18 to 30% of the errors in the post-analytical phase. Not that there are the number of errors are less or the work is less in the analytical phase. It's only because the number of errors are less because maximum automation has happened in the analytical phase. So pre-analytical phase essentially lacks automation, and that is why there is room for higher percentage of error happening. Now this is where AI can help. If we can automate those areas, target them, target our felt needs, address them, and use AI, we can probably reduce the error rates in total of the laboratory services, besides providing timely results to the patients. So I would just go one by one as to what would be the concerns and what can AI offer. So coming to the pre-analytical phase, the problem is physician would order the test, samples are taken by the nurses and the interns. The samples, concern is whether the samples are taken at the right time, the right way. It should have been. So how to check that? Because like for example, I don't know if you have faced those problems in your workplaces, but we do. The samples, it becomes an emergency if you forget to send the lipid profile early in the morning. So by afternoon it becomes an emergency, though it would not be. So who decides? If the patient is supposed to be fasting, whether we have ensured that the patient, how are we going to ensure that the patient is fasting or not? The common answers will be, bhool gaye. So bhool gaye, can AI help us in that? So AI can suggest what test is to be ordered. As I said, the pre-analytical phase also includes these type of test selection. So the AI can suggest what test is to be ordered based on the history of the patient, when and how it is to be taken for every patient. That means we would move a step towards personalized treatment of the patients, and that can be achieved by setting up reminders. Okay. Next, emergency samples, they are missed many times, and though they are to be run on priority. So I don't know if there would be people from diagnostics who would be aware of the fact that nowadays the automated equipments, they do have stat channels in them. So gone are the days when you used to have stat labs separately. We have, though we don't have at Ames, but I have worked with pneumatic chutes. So the time of transport is decreased, and there are stat channels, so you don't need to have stat laboratories separately. The samples anywhere in the facility can reach your central laboratory within less than 2 minutes. So then once they are separate, we segregate the samples generally in the laboratories. That is, the procedure is essentially manual, which is an elaborate one. Again, time taking, so we are defeating the very purpose of calling a sample an emergency sample. So what classifies a sample as an emergency sample is also a big question, in the sense that, can we say that all samples coming from the emergency medicine department are all emergency samples? Or all the samples coming from the wards are routine samples? Difficult to say that. So if we are segregating based on from which department they are coming, at times we will end up missing a few very crucial samples. So again, here, can we look for solutions through AI? So AI, it understands the patient history and the type of the test, lab test. It determines it as an emergency. So it looks at the patient history and then decides whether it is an emergency or not. And then it auto scans and runs the test without any manual intervention being required. So saving on time and providing the test results to the patients, accurate results and in a timely fashion. Then another problem could be rejection of the samples. When the samples are hemolyzed, icteric or lipemic, or they have other interference presence, usually every laboratory has their own rejection and acceptance criteria. Once the samples are accepted from the pre-analytical phase into the analytical phase, that means into the laboratory, then it is mandatory for the laboratory to release the results. So to decide beforehand whether the sample integrity is in place, whether it is fulfilling your acceptance criteria, has to be ensured. So one of those things of concern would be the presence of hemolysis, icterus or lipemia or any other interference if that is specifically interfering with the desired test analyte. So do all the samples with the interference need to be rejected? That's a big question, because if we don't do this, we end up pricking the patient again and again. So every laboratory maintains a record. There are SOPs in place wherein they will be telling for this analyte, these are the interference. They can interfere with the results. That means the whatever false positives or higher values or lower values you are getting, they can be attributed to the process of doing the test and not because of the condition of the patient. So can AI help there? Yes. AI auto-learns and scans the samples to determine the type and amount of interference present in it. Hill index, that means hemolysis, icterus and lipemic index, it is calculated. So basically, even now, the automated machines do have it. But what happens is, it takes the sample. If somebody is from diagnostics, they'll be able to appreciate that. The sample arrives then in the laboratory, the tests are run. What remains, a part of that is taken to assess the Hill index. That means you've already lost your resource. You've already lost your time. So can we scan? We are not doing that before running the sample because it takes time. So can AI pitch in here and help us with this? Based on that, it can run the sample and reject the sample. So at the time when the patient has given the sample, he's waiting, he's around the collection center only. If he can just scan the samples and see that these are compromised samples, we can inform the patients well in advance if we really need to and get the timely samples. Coming to the analytical phase. QC is the bread and butter of the laboratories because we thrive on that way. All the confidence we get in the laboratories because we are maintaining our equipments and the system very stringently. So what is QC is the quality controls which are run in the laboratories, ensuring that just as a, in simple words, we are ensuring that for a said analyte, if the value is 2, the equipment should be able to read 2. If it is reading 2, that means it is going to read the rest of the results of the patients also correctly. So all these things are, the QCs are run beforehand before subjecting the patient samples to testing. Now this is a regular practice. Usually we follow an 8-hourly QC running. That means a set of QC, higher value set and a lower value set is run on 8-hourly basis because it's believed that the equipments are able to maintain that QC levels or that standard for 8 hours. So to just give a coverage of the whole day, so probably it will be 8, and then in the evening depending on the kind of workload you have. So can the shifts and the drifts be detected? So shifts and the drifts or the trends, they are changes in the QC value which are slowly happening because your reagent may have slowly getting deteriorated, your maybe your equipment is depreciating. There are so many things which will slowly contribute to the changes in the values of the mean values of your QCs, which are good indicators. But then, when do you come to know? You would require at least 10 data points towards, skewed to one side to say that it's a shift, a sudden change, or slowly it's happening, a drift, or it has crossed the mean, it's a trend. So that means it will require time. But can AI help us in that? Well, yes. So it can learn and create moving averages. So in real time, it is taking averages. The QCs are there on the equipment. As and when required, it picks up the QC, runs the QC, and sees whether it is in sync with the desired limits or not. If not, it will run, rectify, or maybe pop up depending on what kind of programs you have done, that whether you have to go for recalibration, change the reagent, or whatever the root cause could be. Then it can also ensure reliable results, suggest running of the QC at the right time. So it will be able to pick up those minor changes. What I'm trying to suggest is, since we are giving QC on 8-hourly basis, so what if we miss those changes within those 8 hours? So AI can help us detect those minor deviations and rectify them on time, because we are reporting samples of patients during that period as well. Then the other problem could be, it takes a lot of time to troubleshoot issues, especially when they are happening with the machines, if you're doing it manually. This in turn can affect the turnaround time of a laboratory. Every laboratory, we are in the process of accreditation, but all those laboratories who are accredited, they are committed to a certain TAT, that's a turnaround time. They do say that I would, come what may, if it is an emergency report, I will give it within 2 hours. If it is a routine report, I will give it within 6 hours. So that's your commitment, and you have to abide by that. Now, whenever there is a problem, you halt the testing, and there is every chance that you would cross your TAT time. So can AI help in that? While integrating AI, it compares the QC maintenance charts in real time. It troubleshoots in seconds. For us to look for all things, whether the calibrations went wrong, whether the reagents are wrong, whether something happened to the machine, whether the sample is not correct. So there's so many things we'll have to, and in each category we'll be looking for 5 to 10 reasons. So it takes time to see each one of them and rule out each one of those causes which can eventually lead to poor performance. But AI can do it in seconds, saving time. So it reduces the TAT, providing faster and more reliable results. Then the results of the test, they once they are done, as I said, once they are done, they go to the physician for analysis. So at the time of reporting, then it will become a post-analytical phase. But if at that point of time, the physician feels, oh, I think we should have got this test done as well, then what do? We usually go back, ask for a repeat sample to the laboratory. So the question is a fresh sample required always? Well, there could be a solution through AI as well here. Since AI can understand the clinical history of the patient, compare it with the result, and do reflex testing. So it can give you a pop-up saying that, for this history of the patient, these are the tests already done, but I suggest, if you want, with the same sample, this another test can be done. And then in consultation with the same sample, the additional tests can be, the add-ons can be done, saving on extra pricks or discomfort to the patient. Then when it comes to understanding complex charts, reports, integrating them, as in case of mass spec reports or a chromatograph or FTIR reports, wherein complex data has to be studied, there is every chance that we might end up making manual errors. So here again, we can take help of AI.
Monica, you're taking little time, or is it an issue?
So AI learns from the laboratory of the reports, integrate all patient data before preparing the results. So it gives faster results, more accurate and more reliable results. Management of inventory is a big thing, big issue, because especially for labs which are having large workload, managing the inventory is a Herculean task. So here too, we can sought help of AI. It can, look at your reagents or place the orders and maintain the availability chain of the reagents. In the post-analytical phase, the reports, it can prepare the reports in a very short time. In this era, we are looking for interpretation of the results. For consultants to do it for individual patients is very difficult. But AI can help us in that. So we can go more towards personalized medicine. Again, the same thing, personalized medicine, it will help in early diagnosis and treatment. We can personalize the testing and the results. So certain applications of AI, Twin, there are certain applications wherein AI is doing all that work for you. They are preparing your notes, they are guiding you to do the test. These are the places where cell culture labs are using that just to ensure lack of contamination, high accuracy and fast results. Last, there are advantages, but we have to be wary of the disadvantages as well. AI requires lot of cost investment. It can cost us jobs as well. It lacks creativity and emotional component. That's a limitation of AI. And the biggest limitation being the ethical concerns. Since we do not have ethical rules in place, especially black box phenomena, they are big concerns. So that have to be addressed before taking up AI in a big way. So summarizing, last line, it's good as long as we know how judiciously it has to be used. So ultimately we have to rest our clinical acumen as regards to using AI in healthcare. I would leave you with this quote. Artificial intelligence is good, but we should not lose on real intelligence. Thank you very much for your time.
Thank you, Dr. Monica Kakkar. I think it is more, till date, more theoretical than being practical at the time being, you see. Maybe coming time, you see,
So we're using it partly basically, and that is why we have ended up creating bottlenecks. So it has been partly manual, partly automated. Once full automation, the biggest, I think the bottleneck here is the data, because AI is essentially dependent on very clean data. So if we don't get the histories, we don't get the patient data, it's difficult.
It's like 10 patients with the diabetes, you see, or maybe having fever, and if you feed the data, you see, it may not be the same, you see, for everybody. No? That is the problem.
So curating that data and cleaning it up, that is a big concern.
The other paradoxical is that something devised by the human mind, and it is telling you the human error. Okay, thank you very much. So friends, so we have come to the last lecture of MAPICON 12th edition. Dr. Ram Samuz is professor and head of the Department of Pediatric Surgery at AIIMS Bathinda, and the topic is common pediatric surgical condition in office practice. Sir, what do you mean by office practice? Is OPD?
Yeah, it's OPD basis. Actually, good afternoon, chairperson and fellow delegates. Thank you very much, Professor Vitul Gupta and the organizing team for inviting me. But when Vitul Gupta sent me a message for this talk, for some talk in this MAPICON, I could not say no. But in this august gathering of physicians, I am the pediatric surgeon. So I thought I will simplify this talk so that at least physician can understand what the pediatric surgical problems, and at least they can refer early to the pediatric surgeon. This is the only aim. That's why I came here.
Thank you very much, sir. I was reading your slide. You have written former. So I think you have left AIIMS.
Yeah, I will tell you, sir.
So we are really thankful that you have come from Chandigarh to deliver the lecture. We
Yes,
are
sir.
highly obliged, sir.
Thank you, sir.
Thank you. Thank you very much.
Actually, I worked in PGI Chandigarh as a pediatric surgeon for last nearly 40 years. And after superannuation in 2023, Professor D.K. Singh called me to develop the pediatric surgery department at AIIMS Bathinda. So I came here. I worked here for more than 2 years. But because of my family problems, I have to leave AIIMS Bathinda. My last working day was 13th of this month only. So I went back, then I thought I will come back and just do that. Okay. So I am just going to talk about this. यार एक मिनट ये बताना जरा इसको कैसे दबाना है बस अगले के लिए बस ठीक ठीक ठीक. So today I am going to talk about the common pediatric surgical conditions in office practice. So this is Advanced Pediatric Center at PGI Chandigarh, where I worked for nearly 40 years. After that I joined AIIMS Bathinda. Now I am going to discuss about the common surgical problems. They can be divided into below the belt and above the belt level. Below the belt level, the more commoner problems are urological problems, hernias, undescended testes, rectal bleed, constipation, and rarely anorectal malformation, though they may be also common in neonatal age group. Above the belt, tongue tie, cleft disorders, bronchial defects, lymphovascular defects, umbilical defects, and then esophageal atresia with tracheal fistula and hepatobiliary problems. The hydronephrosis can be diagnosed in antenatal period, and this is now becoming the more common problem in all the neonates. And we say that there is a hydronephrosis in antenatal period when the antero-posterior diameter of the renal pelvis is more than 4 millimeter in second trimester and more than 7 millimeter in the third trimester. So depending on this, it can be mild, moderate, severe. We label it as severe hydronephrosis when the epidiameter is more than 10 mm in second trimester and more than 15 mm in third trimester. In antenatal period, we advise ultrasound at 16 to 20 weeks to evaluate for lower urinary tract obstruction and renal dysplasia and extra-renal structural malformations. This is the algorithm how we are going to treat the hydronephrosis depending upon whether this is unilateral, bilateral, or associated with systemic malformations. So coming to the postnatal evaluation in hydronephrosis, this is again the detailed algorithm I am not going to discuss, otherwise it will take a long time. But usually, I can say only one thing, in about 60% of the cases, the hydronephrosis which diagnosed in the antenatal period, it resolves spontaneously. So only 30 to 40% of these babies require surgical intervention later in the life when we go on following these with serial ultrasound and nuclear scans, EC scans. So now coming to the problems below the belt problems. Inguinal hernia being the most common anomaly seen in our neonates and children. And this is more common in premature infants, and it is because of the failure of the closure of the processus vaginalis completely during the fetal and newborn development. Usually it remains asymptomatic, seen either by the mother while bathing or the physician when examining the child. But this is once you diagnose hernia in a baby, we advise surgery at the earliest. In contrast to the hydrocele, in hydrocele you can wait till 1 year of age, and then after that you can decide. But in hernia, you have to operate early because of the problem of incarcerated hernia. What happens? The bowel becomes comes through that ring, and then it gets entrapped, and then edema develops, and then vascular supply gets compromised, and then intestine may become gangrenous. So this is the real emergency. We have to go in and resect the gangrenous bowel, and so we advise parents to get hernia operated as early as possible. Previously there was a saying that if the child is less than 6 months of age, if it is a female baby, or if it hernia is on the left side, then you have to get the contralateral expiration of the opposite side. But we are not following that principle because we think that incidence is very less, and this may be the policy led by the American College of Pediatric Surgeons because of their money earning habit and getting money from the insurance companies. That's why they have started this business, but we are not following in India this practice at all. This is the operative photograph of a baby with hydrocele. You can see the fluid filled sac. Now coming to other problem in these babies, undescended testis, where on examination you may not feel testis in the root of the scrotum. So what happens, this is the diagram showing that it may arrest at the site of in the abdomen because it descends from the renal fossa to the inguinal region and to the scrotum. So it may get arrested at any point. So it can be intra-abdominal, it can be canalicular, it can be inguinal, or in the superficial inguinal pouch. But this undescended testis may be found at the ectopic sites also. Apart from this routine, this migration route, it can be pubopenic, femoral, in perineal, in transectopia on the other side of the scrotum. So that is known as ectopic testis. The most important thing is differentiate between the retractile testis and undescended testis. Retractile testis doesn't require any surgical intervention at any time, maybe after 12 to 13 years of age, because we think that by the 12 to 13 years of age, the retractile testis will descend. If it does not descend, then we go for surgery. So, so how we can differentiate? Retractile testis can be brought fully to the bottom of the scrotum without difficulty, and it stays there. And usually if you take history from the mother or parents, they say that testes reside spontaneously in the scrotum some of the time. And it requires routine examination at birth, and depending upon, we usually operate these undescended testes at 6 to 9 months of age. Because if we leave these testes more in the abdominal position or apart from this inguinal, because God has made this scrotum to balance so that it may not be exposed to the higher temperature. So we don't want to leave it for longer time because then spermatogenesis will get affected. So we operate at 6 to 9 months of age. Other condition is hypospadias. Hypospadias where there is a child passing urine from the under surface of the penis. So urinary stream will not go straight, it will curve towards the inner side. And it may be associated with cordy. So these are the various positions showing that it may be glandular, it may be subcoronal, it may be distal penile, mid penile, proximal penile, then pinoscrotal, then scrotal, then perineal. So this is one of the photograph of this hooded prepuce and then cordy, it was stretched. So this is the other common condition is this hypospadias. But in hypospadias, if it is a pinoscrotal perineal, then one has to rule out the other conditions also. It may be associated with intersex also. So you have to get genetic analysis, you have to do for ultrasound examination, you have to go for cystoscopy. And the best time for hypospadias repair is 6 to 18 months. But what we tell the parents, because hypospadia usually present with the cordy. Cordy means penis is slightly curved this. So we tell that we will correct the cordy first, then hypospadias we will do urethroplasty. And the third stage we always tell parents that there will be fistula, urethrocuteal fistula. We have to close the fistula. So these three stages we have to explain. because the most legal complication happens when you don't explain that there may be chances of fistula formation. And in pediatric surgeons, there was Dr. Ashopa from Agra. In his hands, the results was very good. The fistula rate was less than 1%. Otherwise, in India, nobody claimed such a best results in hypospadias surgery. Other condition is phimosis, that every pediatrician, everybody will see phimosis in the newborn period at 1 month or 2 months. If it is physiological, usually it's physiological, so what we say, mother or father, to just you clean the prepuce every day and then apply topical corticosteroid, that is a 0.1% mometazone cream twice a day for maybe 2 to 3 months, and in 90 to 95% of the cases, it start retracting. So there is no need of any surgical intervention in these cases. However, if there is a scarring at the tip of the prepuce, or because of there is difficulty in retracting even after 3 months of topical steroid application, then one has to go for circumcision. Other acute emergency in babies are acute scrotum. Their children may present with torsion of the testis, where you can see the gangrenous testis and there is torsion, twisting of the spermatic cord is there. So this has to be clearly differentiated from the epididymoarthritis, and one has to get Doppler ultrasound. If it shows that there is a good vascular supply, that means there is no torsion of testis. It may be because of epididymoarthritis. But if there is no vascular supply, that means there is a torsion of the testis and there are chances of gangrene. So this is a surgical emergency. We have to operate within 3 to 4 hours. Other conditions, rectal bleed. The most common cause of rectal bleed is fissure in ano, then intersusception, rectal polyp, and in slightly bigger children around 1 year of age, there may be one term midgut volvulus associated with malrotation. Other common condition in children are constipation. This is usually we say then when the child is not passing stool every alternate day or every day and passing only with laxatives, then we say this is a child may be suffering from constipation. Then we have to take careful history. And then in red flags on history is when the constipation starts within first few weeks, or there is history of delayed passage of meconium. This is most important. One has to ask the parents when the child fasts the first meconium. If more than 40 hours, that means it was delayed passage. In bigger children, failure to thrive, bladder dysfunction, and if there is no response to conventional therapy, lot of fluids and high fiber diet, and there is no response, then also we label it as constipation. And what are the red flags on examination? If there is abdominal distension, pyelonodal sinus, patulous anus, empty rectum, and most important, gush of liquid stool and air from rectum after finger withdrawal, that is known as blast sign. That means child may be suffering from Hirschsprung disease. So this is algorithm to how to treat the constipation, but usually in first we treat with conservative treatment. We advise parents to give lot of oral fluids, high fiber diets, and then add some laxative like lactulose and all those things, and then we see. But the most important thing in these cases, we have to tell the parents for the toilet training. What we have seen, that child is not toilet trained. वो जब उठा स्कूल चला गया, जल्दी जल्दी सुबह मदर ने तैयार किया, चला गया, शाम को आया, फिर शाम को गया नहीं तो ऐसे. So that will lead to constipation in these children. So we have to tell the parents that you have to tell the child to go to the bathroom morning when you woke up before going to school. We have to break that cycle. Whenever he wants, he will go to toilet. That is not the thing. This is the one press report. When in 2002, I I have done this single stage transanal endoductal pull through procedure for Hirschsprung disease in a 21 days old child, and I was the first one in northern India to develop this technique, though it was developed, but already I have applied in PGI. Now, I will see if his video will work. Yeah, this is the thing, because in single stage we operate through the anal route only. So this is, I am operating through anal route, I am giving incision, and then mucosa all around is separated. And then submuscular plane, we pull the bowel outside through the transanal route. But in this case, the frozen section biopsy is very important. If this facility is not available, then we are not able to do surgery. And this is indicated in selected cases, means short segment Hirschsprung disease, when the aganglionic segment is not very short, very long. It should not be beyond the rectosigmoid level. So this video was made in PGI. Now you can see this, I am pulling this in submuscular plane, submucosal plane. See, this whole bowel means about 10 centimeter bowel is taken out. Now after cutting the rectal cuff, I am taking one stitch just so that it will not get disoriented, 12 o'clock position. Then send the 3 biopsy. I am taking full thickness biopsy and sending to the pathologist for frozen section examination. So once they say, at this level there is ganglion cell, I will cut that bowel and then I will do the colo-anal anastomosis. So this is done all through transanal route. There will not be any abdominal incision, no scar, nothing, and child can be discharged on the 3rd postoperative day. So this is the newer technique in Hirschsprung disease. Worldwide, everybody, even in India, all are operating through the same procedure. So other condition is anorectal malformation. The baby may present with absence of anal opening. And here one can see this is a pearl sign where meconium pearl is seen at the site. So this may be low ARM, because we decide this on the basis of X-ray, cross-pointable lateral. And if it is a high intermediate ARM, we have to go for colostomy first, then go for definitive surgery. Definitive surgery is described by Alberto Pina, that is a posterior sagittal anorectoplasty. So this should be done in 2 stages. But in this case, what figure is there? This is low ARM. It has to be done through anoplasty. So it can be done in local, and this is simple procedure. This is again in the management in male ARM is different, female ARM is different. Now coming to the above the belt problems, tongue tie. Tongue tie is also very common, though remains asymptomatic, and it does not cause, we say that there may be problem with articulation, so we usually advise to get it done around 1 year of age. We do it frenulotomy. Now cleft lip, cleft palate, they also present. Cleft lip is operated within 6 months, but cleft lip may be after 18 months of age. Branchial cleft, sinus cleft are there. First branchial cleft, second branchial cleft, third branchial cleft. They all requires excision of the sinus, branchial fistula or sinus. There may be lymphovascular defects, hemangiomas, so they require. In hemangioma, lately the recent treatment is we give propanol, oral propanol. Previously we were injecting this hydrocortisone, but now we are not injecting it. The result is much better with oral propanol. So this is the newer technique in management of hemangiomas. Now coming to umbilical defects. There may be umbilical hernia, but in umbilical hernia we usually tell parents to wait till 3 years of age, and by that time that defect gets closed automatically. We don't advise any coin application and then strapping, nothing like that, because that may cause incarceration of the bowel through umbilical defect. So we advise reassurance and observation. There may be umbilical granulomas, you can see here. So for that, though literature says you apply silver nitrate, but in PGI we have started applying common salt over this granuloma, and result is very good, though it has not been published yet, or in some papers there, but result is very good. So there is no need to search for silver nitrate, common salt found at home. You tell the parents to apply, and in 2 to 3 weeks it always disappears. There may be hernia of the umbilical cord, that is other. Apart from umbilical hernia of the cord requires surgery. And if there is a supraumbilical hernia, not through that umbilical defect at the above, that also requires operation whenever you diagnose. You don't have to wait for 3 years. So hernia of the umbilical cord, supraumbilical hernia, they require surgery when you diagnose it. There may be patent omphallomesenteric duct. So what happens sometimes, you ask mother what is coming through that umbilical, they say some fecal-like matter, some urine-like. So if fecal matter is there, that means there is a patent omphallomesenteric duct is there. And if there is a urine is coming out, that means there may be patent urachus, so it may be communicating with the bladder. So that both conditions require surgical intervention. Now coming to esophageal atresia and tracheal fistula. This is very common condition. In 2024, here in AIIMS Bathinda, most of those who may be from AIIMS here, but from Bathinda, I have operated one low birth weight baby, 1.3 kg case of esophageal atresia with tracheal fistula from Barnala. Now child is more than 1.5 years old, maybe 5.5 kg and something like that. Child is now taking milk, everything through oral route. But here I want to confess that my operated babies of esophageal atresia with tracheal fistula. One is a MBBS doctor from IGMC Shimla, and she has gone to US for further studies. Second one is from Rishikesh, male child, son of a teacher. He is now computer engineer working in multinational company in Delhi. And one girl from Manali, I operated in 1990. She is a physiotherapist working in Delhi. And one from Bihar. That baby was brought because good family, so they brought through by plane to PGI. Then I operated that. Then on 7th day they went back. Luckily no complication, but otherwise there are complications in esophageal atresia also. And most common complication being the anastomotic leak. What we anastomose, that may leak, then we have to keep it for longer time. So here in AIIMS Bathinda, that child is doing well. I am not able to start the neonatal surgical ICU here for outborn babies. So what babies are born in AIIMS Bathinda, we operate it. But from outside, what babies are born, they don't take it, so we have to refer it to outside. But it may be started within maybe 1 or 2 months. So these are the different types of esophageal atresia you can see. Here the C, type C is 85%, where there is a esophageal atresia and the distal pouch is connected to the trachea. This is the most common variety. This is the picture taken maybe 25 years back in our neonatal surgical ICU in PGI, where there were 18 tracheal fistula babies at a time. This is the picture. Nowhere in the world anybody has witnessed such a large number of babies at a given time. And when any MCH student pass from our pediatric surgery PGI, he will at least do 50 independent tracheal fistula surgery. So much of rush of this, I don't know why this incidence so high in northern India, I don't know. When you go to South India, they don't get this one. And now coming to the other condition, choledochal cyst. This is the different type of choledochal cyst. This is the whenever there is a dilatation of the common bile duct. But in choledochal cyst means treatment is surgical intervention. That's all, nothing. Excision of the cyst and then hepatico-jejunal anastomosis. So hepatic duct is anastomosed to the loop of jejunum. That is major operation, maybe 3-4 hours operation. Other one is this is EHBA. EHBA extrahepatic biliary. The child may born with jaundice, means born and then develop jaundice within 2 weeks. So here one has to, if it is diagnosed as EHBA, one has to operate within 2 months of life for the better results. Otherwise, about maybe 1/3 of these babies undergo liver transplantation in future. Now this may be the last slide, because I want to tell everyone that when to refer the patient to the pediatric surgeon. If there is any antenatally diagnosed congenital anomalies, one has to refer it immediately. If it is diagnosed as hernia, it should be referred as soon as detected. Undescended testes, refer it to by 3 to 6 months, so that surgeon can operate by 6 to 9 months. Anorectal malformation, tracheostomy fistula, they should be referred immediately after birth, so that it can be operated within time. Cleft lip, 3 months, cleft palate, 6 to 12 months of age. Usually one has to refer for early surgery. Tongue tie around 1 to 2 years. Bronchial cleft are operated about 1 year of age. Thank you very much for your patience hearing of it.
Thank you, sir, for an excellent talk. I think you were wrong. This would have benefited each and every delegate present here. So it was such a beautiful presentation. And I think all doctors, MBBS, physicians, they have benefited from your deliberations. So I'm again thankful to you for coming all the way from Chandigarh. So thank you, sir. Thank you. So with this, dear friends, we have come to the end of MAPICON 2025, and we hope to meet next year during the dates 17th to 20th September 2026. I am really grateful to all the delegates for enthusiastic response. Maybe it was because of the certificates that we have maximum attendance now in the evening. But anyhow, we had about 350 registrations, 150 online registrations, which we expect to increase with your efforts, because you will go as brand ambassadors. That MAPICON is one of the largest hybrid conference of the region with 16 credit hours. Even no national conference is going to give you 16 credit hours, which fulfills your need for PMC registration in one conference, and that too economical, because we are giving you 5-star lunch and breakfast with a certificate of 16 hours. So I request you all that whenever you get a brochure of 2026 MAPICON, please circulate it amongst your groups, because we will be encouraged with your response. Already about 50-60 early bird registrations have been done. So thank you very much. Now it is time for certificate distribution. We have streamlined the certificate distribution in 7 counters. So it will be alphabetically given. You sign your attendance sheet and get your certificate. There is a humble request. Those who are from Bathinda, they can collect their certificates from 12 to 2 any day except Sunday from the conference secretariat. So that is Kishori Ram Hospital building, Kishori Ram Road, Basant Vihar, Bathinda. My phone number is there. Anytime you can call me for any query. So if I am busy, I will revert you back, I will call you back, but I will communicate, or I will address to your all inquiries. So my request is, please don't, उत्थे मतलब भीड़ ना पाइयो यार, आराम ना ले लियो। सर्टिफिकेट तुसी 2 साल बाद भी मंगोगे थानू मिल जाना, असी संभाल के रखना है। So please go alphabetically to the counters, get your certificate, and local doctors, they can go home and collect their certificates by sending anyone to my hospital and getting the certificate. So thank you very much. See you next year on 17th, same venue, same hall, I think same lunch venue also, because this time they are lent us the restaurant, which is a great experience, because in no conference you will get a sitting lunch, right? So thank you very much. Thank you.